throughout the day. The first session is a debate of better way of managing diabetes with conventional drug and with newer drugs. So to chair this session, I invite Dr. Tyrone Fernandez and Dr. Aswin Bhatt to chair the session. Please, sir.
Good morning, everybody. We'll start with the first session. Our speaker would be Dr. Alok Rai. He's an MD Medicine from GMC Bhopal, Senior Consultant in Medicine, Right Board CG, past Chairman of CG State API, Executive Member and Chairman, Scientific Committee, CG State RSTI, a member of ADA, ASC, and ASCC, life member of RSDTI, ESI, DI, PSI, DFSI, ITS, API, IMA, CSI, etc., actively participating in various national and international conferences. Sir, I invite you.
Thank you, respected chairpersons. I am extremely thankful to Dr. Akash Singh and his wonderful team for giving me this opportunity and great hospitality. The topic allotted to me is what is the better way of management of diabetes? Obviously with conventional drugs. The question is, should we discard the legends shown on the left side, Lata Mangeshkar, Asha Bhosle, Mohammad Rafi, Kishore Kumar and Mukesh in favor of the newcomers? Certainly not. Poverty is a big issue in India with every fourth Indian living below poverty line. And therefore, there is rising inflation. So there is a rising cost of living, and diabetes, you know, is a lifelong medication, and therefore cost matters. That brings me to the first molecule which I am going to cover, and that is pioglitazone. Pioglitazone के साथ एक सौतेला व्यवहार हुआ है. So let me talk about pioglitazone first. It has multiple cardiovascular benefits. Even after a PCI following a coronary artery disease, it reduces neointima progression and instant restenosis. In patients who have undergone radiofrequency ablation after atrial fibrillation, it reduces the recurrence rate and maintains sinus rhythm. Not only that, it also reduces coronary artery atherosclerosis by reducing the intima media thickness progression and reduce the plaque inflammation. It reduces blood pressure, favorably affect the lipid profile, improve endothelial functions, reduce arterial stiffness, and there is shifting of the adipose tissue from atherogenic visceral fat to the peripheral fat. And these same things are shown. Just one point I want to make here. Contrary to the popular belief that pioglitazone causes left ventricular functions dysfunction, it does not. It actually improves systolic and diastolic functions irrespective of diabetes. So do we have cardiovascular outcome trials? Yes, we have all these trials. I don't have time to talk about it. So I will be covering only just summarizing 4 of these. The proactive trial is, please remember this wonderful number, 16. 16% reduction in the composite of all-cause mortality, non-fatal MI, non-fatal stroke in high-risk diabetics. In a meta-analysis of 9 trials, with pioglitazone, there is a reduction of 23% of MACE in prediabetes and 17% in diabetics. Another meta-analysis of 10 trials with established cardiovascular disease, pioglitazone reduces major adverse cardiovascular events by 20%. And finally, this recent trial, meta-analysis of 26 trials, there's a reduction of 20%. Not only that, pioglitazone also reduces liver fat and reduces liver fibrosis. It is a guideline recommended molecule by the American Association for Study of Liver Diseases. It is nephroprotective. This is a study published in the Indian Journal of Endocrinology and Metabolism. It significantly reduces urinary albumin creatinine ratio, and this is the meta-analysis where it has been found to benefit all subset of patients, whether they have normal albuminuria, microalbuminuria, or macroalbuminuria, by a significant 18.5%. So, in a nutshell, pioglitazone reduces MACE by 16% compared to what you get with SGLT2 inhibitors in EMPA-REG and DECLARE-TIMI. You get a 14% reduction in MACE. With GLP-1 in SUSTAIN and REWIND trials, you get 16% reduction. So it has pleiotropic benefits beyond glycemic control. It reduces cardiovascular and cerebrovascular events. It is renoprotective. It is cost effective, is one of the best insulin sensitizer. It has insulin sparing effect. We have 37 years of use, and still it is a part of all the guidelines. That brings me to the second molecule. Indian diet, you already know, is rich in carbohydrate. We take something like 70 to 80% of our diet is carbohydrate. And therefore, contrary to the popular belief, alpha-glucosidase inhibitors are potent anti-hyperglycemic drugs for Indians. And in this study, you can see it reduces A1C by 1.54. So it's a potent drug. And this occurs because of a reduction in postprandial hyperglycemia because of delayed intestinal absorption of glucose. It also increases GLP-1 and alters the gut microbiota. It also prevents conversion from prediabetes to diabetes with significant cardiovascular disease risk reduction. And in this ACE trial, it has been found to be CV safe. And the effect is sustained over 5 years. And it reduces glycemic variability mainly because of it takes care of the prandial peaks. As compared to metformin, for similar reduction in A1C, there is increased more reduction in the prandial glucose, and you see the weight reduction. With acarbose, you get a weight reduction of 2.52 kilograms. If you combine these two drugs, you get additive benefits. These are the mechanisms of cardiovascular benefit. And compared to vildagliptin in this trial, you can see this acarbose is a better drug in terms of glycemic control and weight reduction. And it gives a comparable A1C reduction as compared to SGLT2 inhibitors. Coming to the third molecule I am covering, it is metformin. 65 years of use is still going strong, and all guidelines recommend it as first-line drug. It can be used up to an eGFR of 30. Cost-effective, very potent A1C reduction. It reduces hepatic gluconeogenesis and thereby mainly controls the fasting hyperglycemia. It increases insulin sensitivity in muscles, it increases peripheral glucose utilization, it delays the intestinal absorption of glucose, alters the gut microbiota, it also increases GLP-1 and modulates AMPK, and can be used with all other drugs including insulin, सब्जियों में आलू और anti-diabetics में metformin. And these are the mechanisms of macrovascular and microvascular protection. So it can be used up in children up to 10 years of age. It is used to prevent diabetes, safe in elderly. It reduces diabetic complications and mortality and reduces weight, and it by itself does not cause hypoglycemia. There are multiple other benefits. It is safe in pregnancy. There are potential benefits in polycystic ovarian disease, aging, non-alcoholic fatty liver disease. It has antibacterial, anti-tubercular effects, and Alzheimer's, dementia. It reduces death from COVID, reduces cancer risk. Even in non-NAFLD, it prevents cancer. In age-related macular degeneration, it reduces osteoarthritis and need for total knee replacement and reduces the fracture risk. So that brings me to the last part of my talk, sulfonylurea. 72 years of use is still a part of all guidelines. One of the most potent drug, no GI side effects, safe as DPP-4 inhibitors. It is safe in kidney disease. It is one of the cheapest drug. Hypoglycemia is always doctor-induced because we initiate with a higher dose than required. Weight gain is modest and can be managed. So for early aggressive glycemic control, you need sulfonylurea for good glycemic legacy, which has long-term benefits. It is safe in pregnancy, although insulin is ideal. This is head-to-head comparison between linagliptin and glimepiride, 6,000 plus patients, 6.3 years follow-up. Glimepiride is as safe as linagliptin in terms of CV outcome. There is another network analysis of 18 trials. I don't have time to talk about. WHO and IDF guidelines recommend this molecule as add-on to metformin. It is effective in 2 common forms of monogenic diabetes. Compared to sitagliptin, it is more potent in glycemic control. Now, last 2-3 slides in terms of, this is a recent network meta-analysis on DPP-4 inhibitors, and it has conclusively shown in more than 1 lakh patients that DPP-4 inhibitors increase the risk of gallbladder and biliary disease and cholecystitis, especially with longer duration of treatment. And liraglutide, you already know from LEADER trial, increases the risk of gallbladder and biliary disease, including cholelithiasis. So when you use SGLT2 inhibitors, what you get UTI, genital mycotic infections, ketoacidosis, joint pain, increased risk of lower limb amputation, bladder cancer, bone fractures, and reduced BMD, and Fournier's gangrene. When you give a GLP-1, the cost is prohibitive. And what your patient is getting, nausea, vomiting, abdominal pain, dyspepsia, diarrhea, pancreatitis, pancreatic cancer, potential risk of medullary thyroid carcinoma. It can cause prerenal acute kidney injury. It increases diabetic retinopathy. And these are some of the selected slides from FDA side. On the left side, you can see semaglutide significantly increases diabetic retinopathy by 76%. Elogliptin increases the risk of heart failure or hospitalization by 19%. Sexagliptin increases by 27%. And canagliflozin increases the risk of lower limb amputations significantly. So my last slide, my questions are, do all diabetics have high risk cardiovascular or heart failure or DKD? Certainly not. If you have a patient who is high-risk cardiovascular with dyslipidemia, will you not use statins because your patient is on GLP-1 or SGLT2? If you have a very high-risk cardiovascular patient, will you not use antithrombotics? Or if you have a patient of diabetic kidney disease, will you not give ACE inhibitor or ARB because the patient is on SGLT2? Certainly not. And final comment, all these trials which my worthy opponent, Dr. Is going to present, they are cardiovascular and renal outcome trials. They have compared the drug with placebo. They have not compared it with pioglitazone, metformin, or AGIs. And therefore, my last slide, on the left side, you can see the older drugs where you have experience, you have clinical trials versus the newer drugs where you have only trials. Thank you so much. Okay, please. Welcome.
Great job, sir.
Hello.
Let's put it full screen, yes.
Good morning, everyone. My pleasure to introduce Dr. Vinod Abhichandani. His exhaustive achievements. He has a MD and endocrinology qualifications from UK, and he's a 1985 endocrine physician from Ahmedabad. He's a member of all the society, life member of RSSDI, written book chapters, and recently published plenty of articles. I think it's very self-explanatory, and we will go with his wisdom on what his point of view for the management.
Thank you
of
very much,
diabetes.
Honorable Chairpersons, Moderator, and all esteemed colleagues. And you have done a brilliant job, my worthy opponent. I am going to contest only the slide number 1. I am going to pitch for the generation next. And you will be, I am sure, convinced with even not only my rest of the colleagues, but I will be able to convince you too. So in the early 1990s, providers' choice for pharmacological management of type 2 diabetes were limited to insulin, sulfonylureas, and metformin. Since then, multiple classes of agents have been discovered, approved, and put into clinical practice. Especially important are the discoveries that SGLT2 inhibitors and GLP-1 receptor agonists improve patients' cardiovascular and renal outcomes. And accordingly, various medical associations have updated their guidelines for the treatment of diabetes in this new era. And you referred to many studies, but there were slides from up to 2017. And I have a set of slides which start at 2018 and end at 2022. So how the things have evolved over the last 2 decades. If you see, with the turn of the century, glucose-lowering agents were meant for improving HbA1c, and by 2008, once the FDA mandate came, we were asked to make sure that we not only improve HbA1c, but make certain that without inducing any enhanced CV risk, weight gain, or hypoglycemia. By 2015, the first reports appeared which pointed to a possibility of improving CV and renal outcomes with newer generation drugs. And by 2020s, the term diabetes or disease-modifying drug was coined with focus on 2 classes of medicine, SGLT2 and GLP-1 receptor agonists. And the development and characterization of the diabetes or disease-modifying drugs provides us with a golden opportunity to simplify the treatment of type 2 diabetes while reducing the disease complications. And the simple approach is S is for simple, I is for initial combination, M is for multiple risk reduction. We are going to simultaneously target, as my honorable colleague said, okay, shall we not use statin? Yes, we are going to use statin. And we are going to use ARBs and AC inhibitors for certain. So we are going to target multiple risks and try to reduce them, the ABCs, blood pressures, lipids, uric acid, inflammation, and with the help of a primary care team, which will also do a lot of job in ensuring that the patients adhere to lifestyle changes and preventive measures, and periodically evaluate these patients for a better outcome. And the choice of glucose-lowering agent hovers around, if you see, The basis for treatment includes lifestyle modification, teamwork, patient empowerment, and shared decision making. Very, very important. Every time in this new generation period, the most revered Lata Mangeshkar, now no more with us, against Shreya Ghoshal. So every actor, every talented person has a place in our heart and in our day-to-day life, and so do these newer agents. So for most patients, lifestyle, metformin, and a drug-modifying disease, disease-modifying drug. And if the HbA1c is more than 9 or there is symptomatic hyperglycemia, we can consider short-term basal insulin. That works very well, and I tell you, many patients accept that. And occasionally, we can combine the same with a GLP-1 receptor agonist. And mostly, the first and second line therapy for most patients, and I do agree with you, Honorable Dr. Rai, that metformin still remains the first choice. And if there is a risk for or evidence of heart failure or CKD or atherosclerotic cardiovascular disease, we can look at the SGLT2 inhibitors. If there is a risk for ASCVD or evidence of ASCVD, GLP-1 receptor agonists come ahead. And if there is obesity, I think both the molecules can feature in the same prescription. Every 3 months, re-evaluation and treatment is, whenever appropriate, is justified. And if required, intensification can be offered. And that intensification can be in form of an injectable drug. So injectable drugs for patients with type 2 diabetes will require initiation, titration, and intensification. So if you have a typical patient with type 2 diabetes not controlled on OAD, on the left, this unfortunately the pointer is not working. And most patients will do well and respond to a GLP-1 receptor agonist. And if you take a clinical call that the patient needs insulin, then you can initiate a GLP-1 receptor agonist and basal insulin or fixed ratio combination. Zaltafy is one such molecule from Novo Nordisk. It's IDAG Lira. And if the patient does not tolerate GLP-1 receptor agonist, we can initiate a basal insulin of our choice, analog insulin. And for further intensification, we need to consider bolus injections or choosing from the available analogs, short-acting insulins. And we have to weigh the benefits versus risk while doing this. And this elegant study published in 2018, it covered almost 132,737 adults with type 2 diabetes, and the authors found that sulfonylureas and basal insulin were associated with comparatively higher CV risk, and they recommended that we as clinicians may consider prescribing GLP-1 receptor agonists as SGLT2 inhibitors or DPP-4 inhibitors more routinely after metformin rather than SUs or basal insulin. And why this recommendation comes? It comes on the basis of very solid evidence. So CV effects of GLP-1 receptor agonists are thanks to their anti-atherosclerotic effects. They improve the endothelial function. They offer anti-inflammatory effects. They modify several risk factors, if you see, by improving the glucose control, reducing insulin resistance, reducing body weight, improving lipids, and correcting blood pressure. And lastly, very importantly, they also impact the infarct and injury size. They reduce that by intracellular calcium, reducing intracellular calcium overload and glucose-induced apoptosis. And a very recent 2022 paper has shown us that GLP-1 receptors also offer some stroke reduction in type 2 diabetes. The disadvantage is also very important by ensuring enhanced neuroprotection on the A side of the cartoon and by making sure that the cerebral atherosclerosis process is minimized. And there are a couple of explanations, but the time does not permit me to go through. And this is another 2022 publication where you are now looking at SGLT2 inhibitor and its cardiorenal and cerebrovascular metabolic effects, which are very, very useful. You are looking at the future, diabetes prevention. If you see, that is the word used by the authors, and the mechanisms and the benefits are outlined. then we are all aware that cardiac protection is there, renal protection is there. Again, very concisely, mechanism and benefits are mentioned on this slide. And at the end of my presentation, my humble presentation, if anybody needs this set of slides, I would be very happy to share with everyone. And the effect of SGLT2 also extend to stroke people. So pre-stroke prevention and post-stroke protection. This comes from a host of features, virtues, which include stroke risk factor reduction, antioxidant and anti-inflammatory and anti-apoptotic effects. And on the right side, neuroprotective effects, which include increase in synaptic activity, increase in memory function, a decrease in ischemic neuronal damage, improvement of cognitive function, and improvement of overall survival rate post-stroke occurrence. And just imagine if we had the opportunity to combine both the wonderful class of agents, what would happen? So I would focus on the middle part, common effects. The sugars will get very handsomely corrected without inducing or inviting hypoglycemia. There will be a significant weight reduction, blood pressure correction, and improvement in lipid profile, uricosuric impact, decrease in visceral fat, which is a major. Dr. Saab spoke about pioglitazone. Honestly, I am not against those, but I am here to embrace the newer generation. So as we progress, as we pass by the day, I think we should not dismiss everything that comes on the horizon as a new, as being useless. And there is also, I have added that in red is decreased arterial stiffness. And if you combine, if you go through the three boxes, plenty of benefits. What about diabetes management in patients with heart failure? Diabetes and heart failure can really worsen each other and coexist in so many of our patients. And if you see SGLT2 inhibitors at the bottom doing an outstanding job. Why? How does that do that? How do they do that? So SGLT2 inhibitors act through, this is 2022 publication, antioxidant, anti-inflammatory and anti-fibrotic pathways. And they ameliorate the endothelial, that is, they improve the endothelial function of cardiac microvascular endothelial cells by improving NO bioavailability. And additionally, they tone down the leptin activity and thereby ensure shrinkage of epicardial adipose tissue, EAT. What about CKD? So this is a 2020 publication. And what does it say? Over a period of 10 years, starting 2007 to 2017, there is a noticeable increase of cautious use of metformin, but along with newer classes of glucose-lowering medications like DPP-4 inhibitors, GLP-1 receptor agonists, and SGLT2 inhibitors. And of course, the newer analog insulin. So they include aspart, lispro, glulysin, detimir, glargine, and degludec, and the concentrated glargine also. What is the future for us? We are going to very emphatically tackle obesity with type 2 diabetes with the help of this dual incretin receptor agonist, tirzepatide. It has shown stunning results and great weight loss comparable almost to some of the surgical procedures. And the SURPASS group of trials have reassured us. We are awaiting the arrival of this new molecule in our country. Maybe early 2023, the Lilly people will bring it to us for clinical use. And Dr. Saab said we are a poor country. I do agree. Most of us are finding it difficult to purchase all the medicines all the time. So this seemingly expensive things I have put on this slide, insulin glargine concentrated, 2-geo, Rhizodec, a great co-formulation of IDEC-S, and ultra rapid acting aspart, that is FIAS. The companies have worked to bring down their cost, and they come with a plenty of perks, complementary perks like free drug samples, autopens, needles, syringes, complimentary, 100% free AGP or continuous glucose monitoring offered to such patients, patient education, nutrition counseling, and regular follow-up with the help of their diabetes educators. And if still the patient is not able to afford this excellent new molecules, then we have biosimilar interchangeable insulin. Only example so far in India comes from our own country or our own company, Biocon, which is the Bazalog brand, is the only interchangeable insulin FDA approved. And then you have a host of generic dapagliflozin, Sita, Lina, Vilda, and various fixed dose combinations to play with. So if cost is a factor, still the new agents can be prescribed in most of our patients and to some stunning advantage. So perhaps my last slide. Would we always go for the vintage ride in Ambassador? I am sure most of you and Dr. Rai sir has a very swanky new car, brand new car. He doesn't use an old Fiat or an old Ambassador. When it comes to a car, probably he affords a BMW also. So thank you very much. What should we settle for? I think while I'm not at all against, please, I'm not going to be in a fierce battle with you. I accept all your lovely slides. But at the same time, I would urge you to accept my point of view also. And I think you will agree to that. That I'm not saying pioglitazone has no place, metformin has no place, SUs are good for bringing down glucotoxicity rapidly. But as you said, we have to be very, very pharmacovigilant. And there have been reports of fatalities starting from UKPDS and earlier studies way back in 1970s. The first study gave a worse prognosis of the first SU. So I'm not going to go through that. So thank you very much, sir, and thank you all for listening to me patiently.
Thank you, sir. It was a very wonderful talk. Would like to invite any questions?
Can someone give the mic in the audience?
Okay, so this was an excellent presentation by Dr. Abhichandani sir. Wonderful. I fully agree with what he presented. Cost, there are two issues. One is cost, and cost does matter because it is a lifelong medication. And number two, there is a prick phobia amongst our patients. They do not easily accept any prick. And most of the GLP-1 and insulins are pricks. Now, if you talk of recently, now since the debate is now over, I want to make a single comment. Recently, in one of the articles, Dr. Ralph D. Fronzo, who has given you the ominous octet, he has written this article that perhaps the best combination of two drugs which we should use in practice, and they will have additive and multiplicative benefits, is pioglitazone with SGLT2. And they will take care of each other's side effects also. That's my last comment. If you have any questions, you are welcome, Dr. Rajat.
Can I have a quick comment? So you referred to Defranzo, sirs. I think his take is 3 medicines, GLP-1, SGLT2, and Pio. So he has his own concepts. We respect those. But regarding the prick phobia, we have oral semaglutide with us for people who can afford. I agree. It's steeply priced. And I think the trade-off in the long run favors use of newer agents. If you see, the initial cost may be, that's why I showed Creta, no maintenance, if you carefully use long term. And Ambassador, every 15 days you have to send to the garage. So thank you very much.
Good morning, sir. My question to both of the speakers. Beta cell biology is now the buzzword. Beta cells के हित के लिए काज करेगा वो ही diabetes पे राज करेगा. So just wanted to know which of the newer as well as which of the older anti-diabetic drugs are really useful in beta cell rejuvenation.
With pioglitazone, we have some studies, although they are not in vivo. They are in vitro. But you have trials that they have beta cell preservating effect. And all other drugs which do not act through beta cells, like alpha glucosidase inhibitor, it acts locally in the intestines. So it spares the beta cells. Okay. Similarly, for SGLT2 inhibitors, they act on the renal axis. So they have they have beta cell sparing effect. They do not enter. So even in SGLT2 indicated even in type 1 diabetes, although it is not a on-label indication right now, but we are using it in our practice in some of the patients. Of course, every type 1 patient, we must not stop insulin at the cost of SGLT2 or GLP-1. We must give insulin to these patients.
Okay, congratulations to both the speakers, they are excellent. Now, most important thing, in the practice of diabetes, there is one proverb, Jo Jita Wohi Sikandar. Means, if your patient's blood sugar is controlled well, with whatever the medicine you are giving, don't disturb him. So you don't, I agree with Abhichandani sir, but if your these Marutis and other cars are working well and you are happy, then don't run for Creta.
I totally agree with you. I didn't say that, jump from a cheaper thing to a costlier just for the heck of it. No, only if it is required. If there is an appropriate indication, I will evaluate the patient, discuss with him, and if he is able to somehow, manage to switch, I would do that. But there is nothing, it's not a pharma-driven recommendation. It's on pure merits.
I fully agree. For any class of drug, because now you have the option, you must select a proper patient before you start, suppose SGLT2 inhibitor. Your patient must be literate. He should be able to maintain proper urogenital hygiene. He should maintain adequate electrolyte and fluid balance. Otherwise, he is not a good patient, good candidate for SGLT2. And number two, the comment which he has made, I fully agree. It is not glycemic control alone. We have to think of the long-term complications, cardiorenal. And therefore, select the drugs. If your patient is a proper candidate for that drug and he can afford, select the best drug which we should offer him. So there is no hard and fast rule, no one thing fits all formula. There are no guidelines. It is always a tailor-made therapy to suit the individual patient. And selection of a proper patient is very important, and that is the only way to go and will improve your long-term compliance. Thank you.
Yeah, last clarification on behalf of both of us, please don't ever use SGLT2 inhibitors in type 1 diabetes. In India, it is banned, and even European Medical Agency took off that dapagliflozin they had allowed. They have withdrawn that indication. So please don't. Dr. Mona, madam, would you have a comment on this?
I will like to end this session. Okay, yeah. Go ahead.
We now don't use SGLT2. If we follow British guideline, if we follow the Transatlantic American Diabetic Association guideline, they still use SGLT2 inhibitor. To answer Ankur's question, it is GLP-1 which increases alpha-beta switch, and that helps in beta cell preservation and neogenesis. So that's one product, GLP-1, which helps in increasing beta cell proliferation and increasing in beta cell preservation. Thank you.
Yes, I would like to end the session because we have so many interesting. This is, I suppose, was one of the most important interesting sessions. There was a conceptual dilemma, and I will leave to the audience to do this little homework. The concept of glucotoxicity helping diabetic person and giving a rest to beta cell is a different concept. And what Dr. Mona concluded was the data of keeping the beta cells surviving, if not rejuvenating, keeping them surviving or keeping them more alive, influencing their biology. The data lies with PIO and the GLP. So all others are doing their job. The rest to beta cell is something different, and try to find out the articles where you'll find that the biology of the longevity of beta cell was affected. Thank you, everyone, and I think we'll end the session with this.
Thank you very much, both the speakers, for the wonderful debate. And now I invite Dr. Alok Rai sir to come on the stage, and I will invite Dr. Tyrone Fernandez to give a moment of appreciation to Dr. Alok Rai. Yeah, both. Yeah. I will invite on the stage Dr. Manoj Mehta sir to give a moment of appreciation to our chairpersons. So now with this, we end the first debate, and I would request Dr. Manoj Mehta sir to be on the stage to chair the next session. And along with him, I also invite Dr. Rajesh Sampal and Dr. Ankul Rawal to chair our next session, which is also debate number 2, atrial fibrillation management. One speaker will talk on with drugs, and second will talk on with devices. One more request, I would request all the chairpersons and speakers to stick on that time so that we can complete the session within a stipulated time. Thank you.
Good morning to all of you. It's really the pleasant morning, and the way probably the morning session started with the debate, it's really encouraging. Well, beginning is always half done. It is always a pleasure to introduce our own Dr. Chirag Sheth. I know him since UG time, and from UG to PG and super specialty, and now becoming probably the international faculty. So introducing him would be just like showing a sun just by the torchlight. So rather than speaking more words, I'll just invite Dr. Chirag to express his views on today's topic. Over to you, Dr. Chirag.
Right. Thank you. Very good morning to everyone, and thank you, chairpersons, and thank you, Ankur Bhai, for these kind words. And the purpose of this talk is to put atrial fibrillation into a correct perspective. Compared to the previous debate, I think this debate is not going to be versus drug versus the device therapy. Rather, the purpose is to put into perspective where devices have more role to play and where the non-device therapies come into picture. So atrial fibrillation everyone knows, and everyone is managing in their day-to-day practice. We know that it's a commonest arrhythmia which is treated in clinical practice, and almost 1/3 of arrhythmia hospitalizations are related to AF. almost 5 times increased risk of CV stroke and 2 times increase in risk of all-cause mortality is attributable to atrial fibrillation. Incidence is age and gender related. With increasing age, increasing aging population will encounter more and more patients with atrial fibrillation coming to ER. We also know that heart failure, valvular heart disease, hypertension, LA enlargement, advanced age, obesity, and sleep apnea, they are all independent risk factors for development of atrial fibrillation. AF, it is prevalent in diverse scenarios, and the classification, if you look into it, is more based on duration of AF. Our textbooks used to describe that AF begets AF. The longer it persists, it is more and more difficult to control. And it increases its nuisance value as the years pass in the presence of this arrhythmia. Briefly, having a look at this classification, we know that is paroxysmal, persistent, a long-standing or persistent AF, a permanent AF when a long-standing AF which is refractory to cardioversion, and there is lone AF which is occurring in patients with less than 60 years of age with no structural heart disease or hypertension. Again, paroxysmal atrial fibrillation can have 3 subtypes. One is vagotonic, which happens to be in post-meal scenarios or when the patient is at rest. There can be adrenergic AF, which is present in patients with exercise-induced arrhythmias. And there can be mixed or random form of AF, which is relatively much more common. So why this classification is important? Because a particular strategy in treating AF, whether it is successful or not, it is more dependent on what is the duration of this atrial fibrillation. Are we dealing with a paroxysmal form, persistent form, form which is resistant to cardioversion, or it is a lone AF? So choosing correct patient and choosing correct strategy is important as far as success of treatment is concerned. Briefly going to mechanisms of AF, mechanisms of triggering AF and its sustenance may be different. And the electrophysiological characteristics of different AF subtypes may be different due to atrial remodeling and fibrosis. We have to understand that AF can happen in diverse scenarios, but there are primarily 2 major mechanisms. One is automatic triggers or the drivers, which are existent in foci in the left atrium, more so in the pulmonary veins, and they arise from the left atrium and then they spread to right atrium. So they are focal origin and then spreading into both atria, more commonly from the left. And then there can be other form, which is a multiple reentrant circuits which annihilate and reform the wavelets, and that perpetuates the AF, which are called the rotors. So you can have drivers from focal origin, you can have rotors with a non-focal or more diffuse form of origin. So why this mechanism is important? It is important because the rapid triggers from pulmonary veins, which are more commonly found in patient subset of paroxysmal AF, and where RF ablation or pulmonary vein isolation may eliminate atrial fibrillation. It may be curative. Whereas in persistent forms of AF, what one has found is a complex fractionated atrial electrograms, which result from anisotropic conduction due to atrial fibrosis and their re-entry, which are major mechanisms which drive this AF. And in these cases, the RF ablation may be insufficient to eliminate the atrial fibrillation. So you can have distinctly 2 different subtypes which drives this arrhythmia. Management, we all know that we assess the clinical background and try to find out what all patient has, and often not one, but more than one clinical entities may be present in a given case. The list is here, so and so forth. Important thing here we would to like to highlight is LV dysfunction. Patients who have a long-standing atrial fibrillation with a rapid ventricular rate, poorly controlled, many of these patients progress to develop LV dysfunction. And conversely, you can have patients of heart failure where during the course of progression of heart failure, the patients may develop atrial fibrillation. So it is at times difficult to find out whether arrhythmia has led to heart failure or whether the arrhythmia is occurring as a part of natural history of a heart failure. So this is one clinical entity which really is very important as far as understanding is concerned, and it also underlies the importance of controlling the AF well. There are going to be subsets where if you control the atrial fibrillation and if you try to achieve cure either with drugs or with non-drug therapies, your LV function might improve, provided that subset is tachycardiomyopathy. But the clinical dysfunction, clinical discrimination between these 2 entities are a little difficult. And again, there can be temporary or reversible causes of AF, which everyone knows, most importantly, systemic inflammation, alcohol, post-MI, pericarditis, embolism, so on and so forth. A small subset of atrial fibrillation happens in patients with supraventricular arrhythmias. It can happen in patients with AVNRTs. It can happen in patients with WPW syndrome, where you can have pre-excited atrial fibrillation because of antidromic AV reciprocating tachycardia. So briefly coming to now the targets of drug therapy, you have rhythm control with achieving and maintaining sinus rhythm. You can have a rate control strategy in patients with atrial fibrillation, and there can be prevention of thromboembolic event. For the sake of time, I will not be talking in detail about the last topic, that is prevention of thromboembolic event. Acute AF, we know that electrical cardioversion is mandatory in patients who have hemodynamic instability, more so in patients who present with pre-excited AF, acute MI, or cardiogenic shock. For the hemodynamically stable AF, we know that TE guidance prior to cardioversion for AF is mandatory if the AF is more than 48 hours. Anticoagulation before and after cardioversion is mandatory. We need to decide about early versus delayed cardioversion, decide about pharmacological or electrical cardioversion, and there are various drugs which is used for rate control for symptom relief. I'm not going to go into details of each and everything because this is our day-to-day practice and there is nothing new as far as drug therapy is concerned. As far as acute pharmacological conversion is concerned, we have a drug with amiodarone and ibutilide with a reasonable success rate. But important is that ibutilide should be avoided in patients with low EF, whereas amiodarone can be used in patients with LV dysfunction and ischemic substrate. One less commonly used group of drugs are class 1C drugs, that is flecainamide and propafenone. They are available, and important is that when you encounter patients of atrial fibrillation who have a structurally normal heart and a normal ejection fraction, if they do not have substrate of ischemic heart disease, one can safely use flecainide or propafenone as far as acute pharmacological cardioversion is concerned. These are the drugs which can be relatively rapidly acting compared to amiodarone, and they may be relatively safer. Of course, they always have to be combined with a beta blocker for a rate control, and always all these patients need a close monitoring with QT intervals, and preferably all those patients should be hospitalized for a day as far as acute cardioversion is concerned. It should not be an OPD-based treatment. The long-term management of AF, if we discuss, we have two broad strategies, rate versus rhythm control, and several studies have emphasized the importance of rate versus rhythm control, and these are the few things which says where the rate control strategy is likely to be favorable and more successful. So age more than 65 with minimal symptoms, if you have markedly enlarged LA, more so more than 4.5 or 5 centimeter, if you have a failed rhythm control strategy, that is an attempt of about 3 to 5 times achieving sinus rhythm in 1 year, then that means your rhythm control strategy has failed. So if you have failed rhythm control strategy, and if you have persistent form of atrial fibrillation, these are the groups of patients where rate control strategy should be accepted, and it will help the patients in improving their outcomes. A word of caution should be tachybrady syndrome. There are going to be patients of atrial fibrillation, when you treat them, they go on to the Brady arrhythmias. And in these kind of patients, this kind of strategy is not likely to be successful. A small discussion could be on a lenient versus tight control to choose based on functional capacity, LV ejection fraction and symptoms. One can accept based on how the patient's symptoms are and ejection fraction is. The worse the ejection fraction, tighter the control of heart rate is in nutshell. Whereas if you have a younger patient that is less than 65 years of age, having paroxysmal atrial fibrillation, a symptomatic patient with persistent AF despite good rate control, if you have a tachycardiomyopathy, if you have valvular heart disease, especially mitral valve disease, there is some Indian data with valvular heart disease in rheumatic mitral valve disease, where rhythm control strategy is supposed to be better than rate control strategy. So in these group of patients, rhythm control strategy will be better. It is important to understand here that due to adverse effect of antiarrhythmic drugs, discontinuation rate with antiarrhythmic drugs may be as high as 40%. So that's the limitation of our pharmacological therapy as far as rhythm control strategy is concerned. We know that amiodarone is 60 to 70% more effective than other class 1C and sotalol group of drug. Chances of proarrhythmia and torsades is much less. There are the problem with amiodarone is a wide spectrum of organ toxicities, and it has got slower onset and offset of action. Whereas other class 1C agents, they have similar efficacy. However, the risk of torsade is little high. They are well tolerated and have a relatively quicker onset of action. So if you have a lone AF, we have recently discussed about when you have lone AF, mild LV hypertrophy, a structurally normal heart, class 1C drug has a preference and should be used as a first-line drug rather than amiodarone. And rest of all other indications, that is severe LV hypertrophy, coronary artery disease, heart failure, amiodarone scores over other groups of drugs. If we compare these two strategies, in general, it is said that there are no difference as far as major outcomes are concerned. Whichever strategy you follow in appropriately selected patient, all-cause mortality, CV stroke, bleeding events, heart failure, or quality of life, they are not going to be very different if you select any other strategy in given in given patient. However, patients who are undergoing a rate control strategy, they have a relatively lower rate of repeated hospitalization, and they are likely to be much more symptomatic. It is mainly because rhythm control strategy has frequent failures, and that's why hospitalization rates are going up compared to rate control strategy, which tends to reduce that rate of hospitalization. A word on unproven and conflicting data for the use of drugs in prevention of AF, that is ACE inhibitors, ARBs, statins, and omega-3 PUFA. They may have some role as far as preventing ventricular remodeling is concerned, but they don't have direct impact in prevention of atrial fibrillation, and they are not recommended solely for this purpose if you don't have other indications for use of these drugs. So coming to towards the last half of the talk, beyond drug therapy, when one considers that there is a role of non-pharmacological role of treatment. So if you have a young patient with paroxysmal AF, if you have AF in presence of structurally normal heart, if you have a component of tachycardiomyopathy, if you have AF with a WPW syndrome, pre-excitation, if AF coexists with other arrhythmias like a typical atrial flutter or focal atrial tachycardia in the same patient, if AF is associated with systolic dysfunction, and if you have symptomatic patient with failure of drug therapy, these are all the indications which says that we, at some point of time, we may have to think beyond drugs, whether we can consider ablation as a therapy in these group of patients. However, need of stroke prevention in high bleeding risk patients should never be underestimated, and we have to weigh in the option of LA occlusion device in these group of patients also. So let us say a patient undergoes non-pharmacological treatment for AF ablation. Are the drugs needed after that? So success of ablation for atrial fibrillation is variably reported to be in the range of 70 to 75%. I'll just take 2 minutes more. Variably reported to be 70 to 75% for paroxysmal AF and about 50 to 60% for persistent AF. The recurrences may need repeat ablation and the success rate may go up. I think Dr. Abhishek will be talking about this in a greater detail in the next talk. But it is important to understand that despite ablation, recurrences of AF occur 10% per year for almost up to first 3 years, and almost 4 to 5% per year beyond 3 years, almost up to 12 years, necessitating the role of drug therapy for rate control, as well as other modalities like AV node ablation with a pacemaker insertion. So what is superior, drug therapy or ablation for atrial fibrillation? Do we have randomized controlled trials comparing ablation with antiarrhythmic drugs for rhythm control as first-line therapy? Mind well, we are talking about first-line therapy, that without giving them antiarrhythmic drugs, can we straightway advise the patient for RF ablation? So do we have data? There were small studies, RAFT and MANTRA PEF studies, which are published. In RAFT, about 127 patients, almost 88% were having paroxysmal AF. And they reported that a higher 1-year freedom of atrial fibrillation in 45% versus 28% who were not undergoing ablation. Mantra PEF, almost more than 250 patients. At 24-month follow-up, again, more patients in ablation group were free from AF or symptomatic AF, and the quality of life was supposed to be significantly better. In 2019, a large landmark trial has been published, Cabana, comparing this two strategies, where there is antiarrhythmic drugs versus catheter ablation, and its impact on mortality, stroke, bleeding, and cardiac arrest. So 2,200 patients, symptomatic AF, both paroxysmal and persistent forms, enrolled between 2009 and 16, follow-up 48.5 months, so almost close to 5 years. Primary endpoints being death, disabling stroke, serious bleeding, or cardiac arrest. And secondary endpoints with all-cause mortality, total mortality, CV, hospitalization, AF recurrence. And what the findings were, no significant difference in the incidence of primary endpoint in catheter ablation versus drug therapy. With a population hazard ratio, you can see 0.86. So in an intention to treat analysis, this study has shown there is no difference between catheter ablation and a pharmacological rhythm control strategy as far as primary endpoint is concerned. But if you look into on-treatment analysis, ablation arm has been shown to have a reduction in the endpoint of death and cardiovascular hospitalization. So to conclude, the drug therapy remains an important component in management of AF with varied clinical presentation, and it is not going to be replaced by the non-drug therapy or the ablation. Non-pharmacological therapies for rhythm control in paroxysmal AF are rapidly evolving, but significant challenges remain in selecting appropriate patient, as we discussed about the problems with tachycardiomyopathy patients or patients who have paroxysmal versus non-paroxysmal forms of AF. So we need to identify that subgroup of patients which can have better long-term outcomes. And lastly, the oral anticoagulant remains the mainstay in stroke prevention of AF despite rapid strides in evolution of LA occlusion devices, especially in high bleeding risk patients, which we have not discussed in great detail at this point of time. Thank you for your patient hearing.
Excellent talk by Dr. Chirag said.
Yeah.
And if somebody has any question, they can ask.
So I think it's in the form of debate, so maybe Dr. Abhishek will be speaking, and then if you permit. Yeah, thanks.
Now I will invite Dr. Abhishek Raj Popat for the next talk, that is atrial fibrillation management with devices.
Okay, thank you, organizing committee and everybody in Baroda for being present here on Sunday morning. And special thanks to Chirag Bhai for covering atrial fibrillation basic part in such a detail. So now I will be focusing more on a device therapy, which is basically meant for prevention of stroke. Atrial fibrillation is a much dangerous arrhythmia than it appears to be. For a patient, it is just some rhythm disturbance, feeling of palpitation. You give a couple of medication and it goes away. Problem arises, what it creates for you is a worse than death. It gives you a stroke. You are alive, you can't move, you can't pee, you can't itch yourself. So there's a much dangerous situation. The perception of atrial fibrillation in large number of population, it should be perceived as a left main stenosis or LAD stenosis, which can give you a very hard time in coming time. So magnitude of atrial fibrillation is very well covered by Chirag Bhai. I will not go much in the details. But if you see from the stroke point of view, 15% of all stroke and 30% of the stroke in elderly more than 80 years are because of atrial fibrillation. It creates more disability and worse outcome. 50% likelihood of death or disability in a first year if your stroke is caused by atrial fibrillation. Against non-afibrillated stroke, disability chances or death chances are only 27%. See the number. In a coronary artery disease, ACS, we are feeling, okay, we are going to die just now. But this gives you a very slow, poisonous death. So anticoagulation is very, very important. Prevention of stroke is very, very important, which we usually do, and our standard practice is to use a CHAD-SWAG score. If you see the component of CHAD-SWAG score, that is congestive heart failure, hypertension, age, diabetes, stroke, there is a modified score which considers age, gender, as well as vascular disease. But problem arises where, when we speak about the drug therapy, there is a one score called a Hasbled score, which predicts the risk of bleeding on anticoagulation. And the three dominant components are common. Hypertension, age, and stroke itself increases the risk of bleeding. So it's always a bargain. You can't fit everybody into the one shoe. There is not every patient who is eligible for the device, and there is not every patient who is eligible for medications. So let's have a clinical scenario which occurs very often with ourselves and must be happening with everybody of us. This is a 72 years old female, history of intracerebral hemorrhage 3 years back. Now she gets right hemiparesis, she comes in 3 hours. Now she has a history of ICH, you can't thrombolize her. MRI shows cortical infarct in a LCA, left ACA, MCA infarction, ejection fraction normal, ECG is showing atrial fibrillation, controlled ventricular rate, blood test normal. What to do? What we are going to offer this lady in a shorter term and longer term? That's why we need an alternative therapy beyond medication, which is our common practice, right? In our usual practice, this is international data, 30 to 50% patients do not receive oral anticoagulation because of absolute contraindication or risk of bleeding. 1/3 of the patients who are on warfarin, because still warfarin is a dominant component being used by many of us for stroke prevention in atrial fibrillation. 1/3 of the patients are not in a therapeutic range. Patients on oral anticoagulation or NOACs has a 2.1 to 3.6% lifetime risk of major bleeding. Discontinuation rate approaches 25%. Residual stroke risk do exist 2 to 5% of the cases. So that's why we need alternative therapy, right? So now, warfarin, if you go, you are just creating, you are preventing 28 strokes at the expense of 11 bleeding. And in aspirin, you are preventing 16 strokes at the expense of 6 fatal bleeds. Warfarin versus no therapy, reduction of stroke is 60 to 70%, aspirin is 30 to 40%. So it is important to understand that aspirin is not an answer for a stroke prevention in atrial fibrillation. And here we are talking about non-valvular atrial fibrillation, right? Whatever this patient qualifies is for anticoagulation, preferably newer anticoagulation. Where is the caution? In which cases we should be careful? When the patient had a history of GI bleed, intracranial bleeding, symptomatic critical organ bleed like ocular, pericardial, spinal cord, recurrent epistaxis requiring medical attention. This is a major thing where you should be seeing yourself in a state to think before you offer anticoagulation to such patients. And there are many multiple criteria, but they are more of minor. I don't think so we are commonly using our clinical practice to see all these things like, amyloid angiopathy or kind of bowel dysplasia. I will not go into this heavy slides. So now, in a conclusion of, the therapy in a short, that is, we have 3 options. Vitamin K anticoagulation, this is very well detailed, and we know we have been using since decades now. Newer anticoagulation, and that also has completed 1 decade in our country. So it started from dabigatran, now we have a rivaroxaban and apixaban. Eroxaban still not available. Then it comes the device therapy for such patients, right? So LA appendage is an area which is a slow stagnation where 90% of the thrombus arises in non-valvular atrial fibrillation. If you plug that area, technically you are preventing the area from where the clots arises. So this is a rationale. You don't use device therapy for a valvular AFib. Valvular AFib is defined when the patient has either severe mitral stenosis or a prosthetic mitral valve in the mitral position. This is the kind of devices what we had. We had a Plateau, which was the original device. Now we are commercially available devices in India is Watchman, Amplatzer, and LifeTech device. The erstwhile trial of device therapy were criticized for the huge side effects. The reason for that, I am a structural heart guy, how the transcatheter aortic valve therapy has evolved. It started from extreme risk, then it came to high risk, then it came to intermediate risk, and now we are doing TAVI in a low risk population. The people with LA appendage were very ambitious. They started their trials right away with the low risk population. So what happened? The learning curve of the operator and the evolution of device was not there. So initial trials were criticized of having a very high number of side effects in such cases. But if you see the current data in a prevail, the rate of stroke, ischemic stroke against the warfarin control group, the LA appendage gives you better stroke prevention against any commercially available anticoagulation in India. So there is no doubt about efficacy of LA appendage closure in a stroke prevention. Now let's see the clinical situation. This is a large propensity match data, and this is a trial mainly done in the Scandinavia. My center from where I have got trained in Copenhagen, Denmark, was one of the participants in that. Here we have seen the propensity match data of treating atrial fibrillation with in the patient with history of intracerebral hemorrhage. And it's a beautiful randomization and how propensity match data has been collected. Out of 151 patients were found to be who were offered LA appendage closure, and others were a physician-driven therapy. Physician includes cardiologist, everybody. It's upon physician whether not to treat a patient with anything because he doesn't feel comfortable to treat. It can be antiplatelet or it can be anticoagulation. And let's see the real world data and how these intracerebral hemorrhage patients are responding to that. The patients are obviously matched for all the STAT-SWAS score as well as the HAS-BLEED score. And if you see the outcome, I'll show you the next slide which is more appropriate. So now if you see lower risk of composite outcome as compared to the standard medical care with 53.3 versus 366.7 hazard ratio. That is amplifying by 5 times. And this is the Kaplan-Meier curve. If you see the lower one is the standard therapy and upper one is the LA appendage closure. And one thing we have to understand, the risk of bleeding and risk of stroke is a continuous risk when you are on pharmacological therapy. You have to take the medication every day to ensure that you are safe and to subject yourself at the risk of bleeding. The risk, what you are taking for LA appendage is a one-time risk of the procedure. That's a big difference over a period of years together, especially in a relatively younger population who are going to live longer. And this is the latest trial of the Prague 17 trial, because now finally we have come to the more regular population, with a bigger number of population, what we are seeing in our everyday practice. This was a randomized non-inferiority trial, LA appendage versus NOACs, because erstwhile trial were against warfarin. The people were saying that NOACs is a game changer for stroke prevention and atrial fibrillation, which is not so. So the patients were randomized to LA appendage versus anticoagulation if they had a history of bleeding requiring intervention or hospitalization, or history of cardiometabolic event while being on anticoagulation, or if your CHADS-VAX risk score is more than 2 and has blood is more than 3 and has blood more than 2. These are the standard indications what are being practiced in Europe currently. Exclusion criteria are diffuse and mostly technical, which is related to the procedure. And in the follow-up, this is the intention to treat like 200 patients. What is important is to see the kind of medications they have used. 95.5% patients were on apixaban, which is so-called considered to be the safest anticoagulation agent available as far as the bleeding risk is concerned. 8 patients, it is 3.5 or 4% patients were on dabigatran. Xarelto is something, carries a high GI bleeding risk. So it was only 1 patient. What happens to this patient? 187% patient underwent a successful, which is 96.8%. 96.8% of the patient had a successful device implantation. All majority of commercially available devices like Amulet, Watchman were used. There were 9 patients who had, including 1 patient had a death. The complications were mainly vascular surgery, groin hematoma and death. And there was the one device-related death, which was because of the late pericardial effusion, which is, and if you see what happens to the primary endpoint, it attains non-inferiority. It is 0.04, nothing to worry. And if you see the number of cardiovascular death, old stroke, and TIA, everything that is matching with NOACs. And if you see later that, the NOACs curve is going up, LA appendage curve remains static, because that was the one-time risk you took back then, and now it is over. But NOACs offers you, any anticoagulation keeps on offering you continuous risk of bleeding and residual risk of stroke over a period of time. Let's not go much into this thing. If you see from clinically significant bleeding, if you see LA appendage closure versus NOACs, again it achieves non-inferiority and non-protocol related bleeding. All the things they achieve non-inferiority in this. So now let's understand why there is a difference. Difference, as one thing I have explained, that the trials were conducted in a different way. Third thing, LA appendage is a very complex anatomy. If you are doing a TAVI, your annulus is either going to be circular, oval, you are doing a CT scan, it doesn't matter much. But in LA appendage, it can have a multiple variety. It can be cactus-like chicken wing, reverse chicken wing, windsock and everything. And that anatomy decides how complex the LA appendage closure can be. A simple LA appendage closure can behave like your appendix surgery, and complex can really behave like a Whipple surgery if you go ahead without a plan. So in imaging, we are doing more on a TUE, because still our education level for understanding was limited back then. But now we do a CT scan. CT scan gives you more predictable images and everything, and then you decide the landing zone depending upon the anatomical features and patient's anatomy. Then you just cross the interatrial septum, put your wire into the pulmonary vein, go into the LA appendage over there, deploy the device, release it, balle. So in summary, in the current NOACs era, LA appendage may be considered as a pharmacological as an alternate to pharmacological therapy when you have a contraindication to NOACs, anticoagulation is not tolerated, or you have a stroke while being on NOACs. Thank you very much for the patient listening.
Thank you, Doctor. Dr. Chirag, if you have to say something for the rebuttal or...
So it's not kind of rebuttal. I mean, with Abhishek, I think it's going to be our combined learning, of course. Yeah. So just simple question for the sake of discussion among the attendees. At this point of time, which all patients you select straightway for LA appendage closure versus leaving on medical therapy?
In current practice, we are strongly dependent on referrals, and we don't get any patient who has genuinely not had a bleeding. We are not yet achieved that level of education in the general population as well as in our medical fraternity, where LA appendage closure is considered to be a very strong option against anticoagulation. So as of now, whatever patients we are seeing are mainly had a one major bleeding or ICH. That is a dominant fraction of the patients what we are treating as of now.
So, when you had said that you can get rid of anticoagulation, but looking into closure, what actually happens when the patient is undergoing device closure? For at least first 3 to 6 months, you do need anticoagulation because devices, so depending on what device you are selecting, whether it is Watchman or Emulate or Watchman Flex. But some degree of anticoagulation, initially, it may be as less as even 1 month also. And later on, you can switch off anticoagulation. But one of the problems, I think you also will agree, is the para-device leaks. Some of the patients who are undergoing device deployment, you have seen the complexity, how the appendage structure is. And the device you select based on CT scan, but still, there are going to be sizable number of patients. That number is not small, probably. It is declining with increasing expertise of the operators. But that component is still there, para-device leaks, which still keeps patients at high risk of stroke and ischemic events. And therefore, all those patients who continue to have some sizable para-device leaks, they will continue to require antiplatelets and anticoagulation. So when the procedure is successful, everything good, no para-device leaks, I think that is the kind of patient who is going to be perfectly doing well in long term versus small number who do not have this. And lastly, though we know that patients who have atrial fibrillation at high risk of stroke, we have to understand these are all elderly patients. So in patients with AF, yes, L appendage is dominant source of thrombus, but elderly patients have extensive atherosclerosis, and that source is not going to go away, even by closure of L appendage closure. And therefore, you still may have to rely upon some degree of antiplatelet therapy for prevention of all those aspects also. So I think it's not a very great win-win situation in all the patients, but yes, a careful choice of patient is important.
I would like to give some inputs on that. So the initial trials were criticized for having a bleeding risk later on, and then it was discontinued since 5 years. We don't offer any anticoagulation after LA appendage closure. Typically, what our protocol is that patient remains on clopidogrel and aspirin for 3 months, and then aspirin, that's a single antiplatelet for life. So obviously, that single antiplatelet for life, because you are putting some device into the left-sided chamber, you don't want this patient to be naive of anything. So you just give an aspirin. And that equally takes care of the atherosclerotic plaques and everything. As far as the peri-device leaks are concerned, they are not more than 5% of the population with the kind of our understanding of LA appendage anatomy as well as the device evolution. So I would say if you are having a bleeding risk, it is a dominant fraction of the patient can be offered this, and once the procedure is being done, it is indeed successful, there is no doubt about it. Obviously, these patients are much sicker. You don't see like a 40 years ago, a guy got over the stent. These patients are much sicker. You are going to see octogenarian, septuagenarian population with multiple comorbidities coming in front of you. So if you see the data over a period of time, I would agree that these patients have some additional reasons of having a stroke. So we don't say that it is absolutely like giving an immunity, that you will never ever have a stroke. But at least what we are discussing in our trials and in our forums and everything, it gives you non-inferiority against anticoagulation agent. And that's what we have weapons as of now as a non-device therapy as well.
Thank you, both of the speaker. Yeah. Because of the paucity of the time, just we are concluding this. And good applause for both of the speakers. They have done the wonderful job. Thank you, both of you.
Now I invite both the speakers to come on the dais, and I would require the chairperson to give the moment of Felitis. Dr. Chirag Seth and Dr. Abhishek. I invite Dr. Arvind Dayar sir to come on the dais and give a moment of appreciation to our chairpersons. So now we are moving quickly ahead towards the session number 1 after the 2 debates. To chair this session, I would like to invite our chairperson, Dr. Manoj Parmar, Dr. Bhavesh Patel, and Dr. Sanjay K. Shah, sir. Please come on the dais, sir. Dr. Manoj Parmar, sir, Dr. Bhavesh Patel, and Dr. Sanjay K. Shah. If they are not there, I would request Dr. Arvind Iyer, sir, to come on the dais, and Dr. Rumin Shah, sir, if you can come on the dais to chair the session.
Morning, friends. We have Uday Lal, consultant physician and diabetologist, who's going to give the first talk. Because of the paucity of time, I would request the speaker to deliver the talk.
Good morning, everyone. At the outset, I'd like to, congratulate the IDCM, the whole faculty for having their first conference. I think it's been an excellent conference, and I'd like to personally thank Dr. Kamaldeep and Dr. Akash for having invited me here today to deliver a talk on glycemic variability on time and range. So this, we all know, is a very important topic, and it's been in the news for some time now, but there is continuous data that's been churned out on this topic, and it's important for us to keep updated on this topic. So in the next 10 to 15 minutes, I'll try to just highlight some of the important aspects on this topic. So we all know that HbA1c is associated with diabetes complications, but however, it does not reflect the glycemic variability, which can actually worsen outcomes by leading to inflammation, oxidative stress, and even certain cardiac abnormalities. And so for us to really know this, that's why there have been so many numerous publications on the topic of glycemic variability over a period of time. And now, we want to know, why is it important? Now, it is important because in order to get a good glycemic control, you not only need to control the hyperglycemia, and have a good HbA1c control, but the glycemic variability forms a very important component so that you can actually get an overall good control of your diabetes for your patient. So this triad it is a very important thing that we need to look into. So what is glycemic variability? It basically refers to swings, the troughs of highs and lows in blood glucose level beyond the normal level. So you can have the intraday or you can have inter-day swings, and you have inter-individual swings, but I'm not going to talk about inter-individual swings because most of the data is for inter-day and intraday. Now, this is again very important because intermittent high blood glucose level swinging are associated with more deleterious effects for cardiovascular health, even if you compare it to a sustained high blood sugar level. So if you see in this diagram, we have one patient A and patient B. One of the person has pretty decent control. I mean, there's not too much of variability. He has a few swings of hyper and hypo. But if you look at the second patient, there's a significant amount of variability in him. He's swinging from hypo to hyperglycemia, and that's what we call the within-day variability. Now, if you have the same concept where there is a day-to-day variability, then it's within a period of 1 week, then that's what we call as day-to-day variability. Now, when you want to measure glycemic variability, there are a couple of ways of doing it. One of the ways of doing it is by amplitude, which you can, you put on the x-axis, and you can, use this as one of the metrics for measuring glycemic variability. So this is, again, one of the important parts by which you can do it, and some of there are various metrics to calculate the glycemic variability, but the two standard ones are standard deviation and coefficient of variation. I mean, you have other ones like Conga, MAGE, MODE, the high GBI and LGBI, etc. But these are the most common. And coefficient of variation probably is a little better. It is basically the magnitude of variability relative to the mean blood glucose. So, as I mentioned to you, there is another way of measuring the glycemic variability. That is on the x-axis by time. So you look at the patient, how much time he's spending in the normal range, and there would be some areas where the sugars would be going above or below. So you're basically trying to see the time spent outside the target, whether it's hypo or hyperglycemia, as a measure of glycemic variability. We'll talk about this in a little more detail. So when we talk about this, as I mentioned to you, that there's a certain target. Time in range is between 70 to 180, and if you want a tighter control, then the targets are brought down to 70 to 140. Anything when the percentage of time spent is above, it's called time above range, and if it is below, it's time below range, indicating hyper and hyperglycemia respectively. So TIR may be an appropriate endpoint for clinical research, but now we're using it to measure glycemic control in patients in diabetes in our day-to-day practice also. And there is emerging evidence that suggests that TIR is inversely correlated to the risk of developing microvascular and macrovascular complications, which we will subsequently dissect in this other slides. Now, this is a slide that shows 3 patients classically having an HbA1c of the same of 7. But if you see the third patient, he seems to have a very good time in range. It's as much as 100%. The second one has a time in range of 63% with a few hypo and hypers. But you look at the patient with the first one, he's having swinging from hyperglycemia to hypoglycemia with only a time of range of 18%, but his HbA1c is 7% still. So, that gives us an idea that time and range may be very different for the same HbA1c, and that is the reason why we need to look into this aspect also. Because the first patient, because of the swings, it's getting nullified. So then there was an international consensus on the CGM data interpretation by Battellino, by the ATTD guidelines in 2020. And in that, they have said that the target in range ideally should be between 70 to 180, which is approximately greater than 70%, and time-wise, it's about 16 hours, 48 minutes. Now, a patient can be above this range. If you go in time above range, it's in slab 1 and slab 2. The yellow one shows the sugars above 180. And they say ideally you want them to be less than 25% or 6 hours in this. Doesn't mean that he has to be in that, but that much is acceptable. And the slab 2 is when it's above 250 milligrams per liter, then you would want him to be ideally less than 1 hour, 12 minutes, which is approximately about 6%. So now coming down with respect to time below range, here they are much stricter. We want the sugars which are less than 70, you don't want the patient to be in that range for less than 1 hour. And anybody in severe hypo, the red color, we don't want them to be there for more than 15 minutes. These are just guidelines. Ideally, you want them to be in the target range. Now, if you look at it with respect to some other patients, especially the older patients, high-risk patients with diabetes, with respect to the time above range, things have been a little more lenient. They made it, 50% of these patients can be time above range, that is approximately about 12 hours, and 10% for about 24 minutes in the higher range of 250. So slab 1 of 180, you can be a little more lenient for the elderly or the high-risk patients. But the target remains the same as far as the hypoglycemia is concerned. With respect to pregnancy and GDM, it's much tighter. The target ranges are different. It's between 60 to 140, unlike the previous one where we talked about 70 to 180. And the targets of hypoglycemia, again here, as you can see in the slide, are slightly different. But in GDM, in fact, you want more than 90% of your patients to be in targeted range. So it's much tighter here in these cases. Now, why did we come to how did we come to this correlation between HbA1c and time in range? So if you can see in this, is a very good study done by Vigoresi et al. And a number of other people who have done multiple studies on this. In this paper, it was shown that if you see here, for time in range from 0% to 100%, there will be an inverse relationship with the HbA1c, where there's an approximate from 12.1, HbA1c will come down to 4.3 when the time in range is about 100%. So what I'm trying to say is an inverse relationship. So when they did a regression analysis, Vigoresi noted that when you cut a line at about 70% and you see an average sugar over 3 months, you would see that the HbA1c would be about 6.7, which is below the 7% guideline given by ADA. So that's how the percentage of 70% has come in. Now, this is again an elegant slide that shows the relationship of time in range with mean glucose. It's again an inverse relationship when the blood glucose is above 120. So optimal, when the blood sugars are 120, the time in range would be the best. As the sugars go up, the time in range will obviously come down to a level of 200. But if you look at, if the sugars go below 120, that's more towards hypoglycemia, then this inverse relationship actually doesn't exist anymore. The time in range will also start falling with the decrease of the blood sugar because of the hypoglycemia. So the relationship is only reversely falls when the blood glucose decreases less than 120. That needs to be kept in mind. So we will just quickly talk about glycemic variability and hypoglycemia. What is the association? So if you look at this slide, you have the x-axis, y, and the z-axis, where you have the hypoglycemia, HbA1c, and on the z-axis, the glycemic variability. And here, if you have a look, that when the glycemic variability is low, even if the HbA1c is high, there will be some amount of hypoglycemia. But as the HbA1c goes on decreasing, you're going in for tighter control. There'll be more swings of HbA1c with higher glycemic variability. So if you want an optimal good HbA1c, you've got to ensure that the glycemic variability is less. So then the chances of you having hypoglycemia are much less as shown in this. Now, with respect, again, in this also, this is a post-hoc analysis on switch trials where they've used degludec, and they've seen that, again, if you see the amber color bar, which shows a high day-to-day variability in whether it is overall, nocturnal, or in severe cases, both in type 1 and type 2, it's very clearly shown and documented that the higher the glycemic variability, the higher the chances of hypoglycemia. So whether it is in nocturnal, severe, or an overall perspective. Now, this is a relationship between TIR and HbA1c, and this shows it's a nice slide that shows if you have a low glycemic variability, which in the purple slide, which is about 25%, and if as it goes down, the green one has the highest glycemic variability of 50%, you will see that there will be a lower time in range as the CV keeps falling. So you will have a low glycemic variability, a better time in range when the glycemic variability is 25% as compared to 50%, where there will be a high glycemic variability, a lower TIR, and a high mean glucose. So this again shows that the importance of having a good time in range. What are the implications that can take care with this? Now we have in this the DEVOTE trial, which again shows the same thing, that the amber color bar shows that the MACE and all-cause mortality is much higher when the variability is high here, which can again be shown in this slide. If you see the first box, it shows if the fasting blood sugar is high, postprandial blood sugar is high, HbA1c is high, and there is a lot of glucose fluctuations, which here is being measured by MAGE, there will be an activation of oxidative stress, and this will lead to complications. So if you are able to bring down the fasting, postprandial glycemic variations as well as the HbA1c, then the risk of complications come down. This is because you are really bringing down the oxidative stress in this study. With respect to microvascular complications, again here we have seen there's an inverse relationship. that as the time in range increases, the retinopathy increases. But if there is a 10% less TIR, the retinopathy progresses as high as 64% with respect to microvascular complications. This is the same even with microalbuminuria, that as it's an inverse relationship, if you have a good TIR, the chances of progression of microalbuminuria are less. And as shown here, 10% less TIR shows a progression of 40% in microalbuminuria. This is, again, a study done with respect to neuropathy. And in this also, with respect to painful diabetic polyneuropathy, if you see that if the time in range is less than 65%, as shown in the white bar, where there's a high glycemic variability, the neuropathy, painful neuropathy is much higher than when the TIR is above 85%. So decreasing level of TIR was significantly associated with the increasing risk of any pain, whether it's moderate or severe. This is an indirect study done with respect to macrovascular complications with cardiovascular disease, where they've done a study with time and range with the carotid intima thickness. And then here too you see there's a significant association of TIR with CMT, which is with each 10% increase in TIR was associated with a 6.4 lower risk of abnormal carotid intima medial thickness. This was actually a study done in 2020, presented at the ADA, which again showed the same thing, that as the with the increasing TIR, the risk of MACE significantly decreases. So this is a 10-year cumulative incidence of developing diabetes-related complications after improving TR. This is an IQA 10 study, which was done in type 1 and type 2 diabetes. Again, this shows that when the TIR is like, say, 80%, the chances of complications with respect to myocardial infarction, end-stage renal disease, or severe vision loss or amputation come down as the TIR increases. So in summary, I'd like to just say that TIR is a new concept in glycemic monitoring, which is yet to be utilized effectively. We started using it in clinical practice now, and it has shown good trends in reducing both micro and macrovascular complications, and TIR may serve as a good clinical endpoint in outcome trials. Thank you.
Excellent talk, sir.
Yeah.
Dr. Uday Lal has a flight to catch, so I think we'll felicitate him, and questions will be asked to Dr. Om Lakhani, Dr. Mona Madam.
Yeah.
Sir, excellent talk.
Thank you. Thank you, sir.
All the best, sir.
Thank you. Sorry, I've run.
I know.
Right. Clinical
For the next talk, may I invite Dr. Om Lakhani. Om again is a boy from Baroda. Welcome to your hometown, Om.
Thank you, sir.
Over to you, Om.
So, thank you so much for the kind introduction. And, in the next 20 minutes, we are going to discuss the most important medication in medicine all throughout. Whether you take any subspecialty of medicine, whether you take medicine in general, right? I think this is the most important drug. And perhaps, rheumatologists and dermatologists and perhaps even quacks are always in love with glucocorticoids. As an endocrinologist, there's a love-hate relationship with this drug. So that is what is going to be reflected in the next 20 minutes. So to give you an outline of my talk, there are 3 things we are going to discuss. When I started making this presentation, it seemed that my love for glucocorticoids, not the hate, was so much that there were many more concepts which I wanted to discuss, but in the interest of time, we had to stick to 3. So we'll discuss about what is supraphysiological and physiological glucocorticoid replacement. We'll discuss different physiological states where we'll be using glucocorticoids, and we'll be discussing management of glucocorticoid-induced hyperglycemia, where this topic gets linked with diabetes back again. Okay, so in 1950s, these three individuals, Kendall, Reichenstein, and Henk, received the Nobel Prize for isolating glucocorticoid or cortisol. And trust me, and when I tell you, there is no drug in history of medicine which has saved more lives than glucocorticoids. I'm sure you'll agree with me. Perhaps destroyed a few also on the way, but saved more, right? Even today, and we are standing here in 2022, after being gone through 2 years of a horrific pandemic, and of all the drugs which came and went, right, there were quite a few, right, and you'll hear about this every day. The drug which actually stood the test of time was dexamethasone, perhaps the oldest in the group, right? So I think this is a drug which, without a doubt, has saved more lives. And unfortunately, sometimes we have two types of physicians, one who are, very fond of using it, but then there's one who perhaps do not use it as frequently as they should be showing, right? So this is where we draw the balance. And as endocrinologists, we are always talking about balance, right? So this is where I think my talk would try to draw some balance about the use of glucocorticoids. So again, if you had to throw all the medicines in the sea, let's say you are going to a deserted island and they are told that you will have to carry only one. In fact, that happens. When doctors are sent on Antarctica, they are asked to carry only limited medications. You can't carry everything, right? If you had to carry only one and you have to choose one, it's not going to be paracetamol, it's not going to be an antibiotic, it's going to be glucocorticoid. Because this will save more lives on a long trip on a deserted island than any other medication. Okay, so let's first discuss the first concept, the difference between a physiological glucocorticoid replacement and a supraphysiological glucocorticoid replacement. This is very important for physicians to understand. In fact, this is where we draw the difference between the rational use of glucocorticoids versus irrational use of glucocorticoids, or a justified and versus non-justified use. So what is a physiological glucocorticoid replacement? Now, the indication is adrenal insufficiency. Now, this adrenal insufficiency could be organic, and often it could be iatrogenic, right? We'll discuss that as well. Now, typically, when you're using a physiological glucocorticoid replacement, let's say a patient, let's say do a adrenal surgery, and you remove the 2 adrenal glands of a patient, right? How much steroids would you give to this patient for the patient to survive? That is the question, right? And the dose here is, typically, we'll be giving a dose of oral hydrocortisone. Remember, now, hydrocortisone is also available orally. The brand name is Hyzone, H-I-S-O-N-E, right? It's available orally, it's available all throughout. And oral hydrocortisone is the most physiological form of glucocorticoid replacement because it mimics the natural cortisol most accurately. It also has a little bit of mineralocorticoid effect also, so it works in a perfect way. So typically, an oral hydrocortisone dose of about 15 to 30 milligram would be what would be required physiologically. And if you make it into equivalent dose of prednisolone, it'll come to around 5 to 7.5 milligram of prednisolone. Now, remember, when you're giving a physiological replacement of glucocorticoid, this will not affect your HPA axis. This will not, create a havoc with your system. This will save your life, right, or protect your life. On the other hand, let's now discuss what actually is HPA axis. So we said that, our HPA axis requires preservation, but what is HPA axis? So remember, your entire, steroid pathway starts above from hypothalamus. There is production of a hormone called CRH, which acts on the pituitary gland to produce ACTH. And this ACTH acts on the adrenal gland to release cortisol. So this is the hypothalamo-pituitary-adrenal axis. Now, interestingly, the impact on the pituitary gland is from CRH, but it also is, there is a little bit of impact from ADH, antidiuretic hormone. And there's also, remember, physiological stress, right? Stress also increases ACTH production. So when you are in an ICU, when a patient is in ICU, or when you are in a physiological state, right, when you are having COVID-19, these are the situations when body produces more cortisol to defend itself, right? So this is what is HPA axis. And when you are giving a physiological steroid replacement, this HPA axis is remaining intact. But when you are giving a supraphysiological steroid replacement, the HPA axis is impacted, right? And that is where the difference really lies. So what is supraphysiological? Typically, this is 2 to 3 times the upper limit of normal. It is mainly used as an anti-inflammatory thing. Remember, this is where we generally use steroids for a shorter period of time. We don't give it for a longer time. And then the impact on the HP axis will depend on multiple factors. We'll discuss this. All supraphysiological states will not impact the HP axis. So again, don't be afraid of using it where you need it. But in certain situations, you can do that, and that's where you need to really look at. Okay, so when does a supraphysiological dose impact the HP axis, right? So, sorry, the slides did not come up. Okay, yeah. So when you're giving a prednisolone dose equivalent to more than 20 mg for a period more than 3 weeks, that is where your supraphysiological dose, you are likely to impact the HP axis. Or on the other hand, if you are giving even a small dose of 5 milligram, but at night time, right? Remember, your steroids are produced more in the morning time, and as the day progresses, the cortisol levels decline. But if you want to mess with the HP axis, if you give a prednisolone at night time, then you are more likely to impact the HP axis, because what it does is, when you're giving it at night time, the morning surge of the ACTH is suppressed, and hence the HP axis is affected. So even if you're giving a small dose, but incorrect timing, that will also affect the HP axis, right? So these are the two things. And on the third thing, there'll be some patients who have different metabolism, who will not metabolize the glucocorticoid that easily, and in that case, they will develop features of iatrogenic Cushing syndrome. Any patient who looks Cushingoid, right, that patient, the HP axis is affected unless proved otherwise. So these are 3 categories where you need to look at. If you have one of these 3, right, you are impacting the HP axis. If you are giving a prednisolone of 30 milligram for 1 week, you are not impacting the HP axis, right? So you don't need to taper it, you don't need to monitor it, you don't need to do anything around, right? It's fine. But if you're giving, let's say, 20 milligram, whatever dose, more than 20 milligram for 1 month, 2 months, 3 months, then you are impacting the HP axis, and that is where you need to be careful, right? The side effects will then start showing up when you're starting to reduce the dose of these drugs, right? So these are some examples of patients who have iatrogenic Cushing syndrome, right? What is iatrogenic Cushing's? When steroid is given iatrogenically for a long period of time, leading to the patient being Cushingoid, right? Now, when you have a patient with iatrogenic Cushing, now you will often say that, how common is this? Very common. The most common cause of Cushing syndrome in India and worldwide is iatrogenic Cushing. And thankfully, in our part of the country is, we don't see this very common, but, I've done my endocrinology training from Delhi, and in Haryana, right, a lot of patients come to Delhi. This is very common. Every third patient, right, coming from a small village would be some form of dexamethasone or something like that, often being taken for a long time and develop these features. I gave this talk in Rajkot, similar, right? And very interestingly, just a few days back, a physician from Porbandar, right, made a diagnosis, right? There's a patient who was looking Cushingoid, and he took the history, and this patient was taking some tablets in a loose packet, right? And he measured the cortisol was low, and he diagnosed a case of iatrogenic Cushing's, right? And which is, I think, beauty of the thing that, perhaps knowledge dissemination works, right? Somehow somebody made a diagnosis correctly, right? And send the patient over. So when you see this type of patients, when you see these patients, right? Typically what you can see here is a malar flush. You can see the typical stria on the abdomen, on the armpits, right? When you see such a patient, right? This is a Cushingoid patient, right? The first and the most important history you have to take, are you taking medicines from perhaps an unqualified doctor, or are you taking any steroids, or are you knowing that are you taking steroids, right? Some patients will give you the history, some patients will not give you the history, then you need to look deeper, and perhaps you'll find one of these patients, right? So this is not uncommon. Look out, watch out for these patients, because you'll see them in your practice, right? These are some other pictures of patients with iatrogenic Cushing's, right? Now this is a girl with iatrogenic Cushing's. You often feel कि यार बाड़कों ने तो छोड़ दो, right? But that's not true. You will find these people taking patients to quacks, especially those people suffering from asthma or any other inflammatory disorders, right? When these patients are taken to non-qualified doctors, what is given to them? Steroids. And they become better, right? And then the steroid is not stopped, right? It goes on. In fact, our own dietitian came to me and said that, sir, I'm gaining weight, right? I don't know why. Dietitian, right? I said, generally I refer them to dietitians. If a dietitian is coming to me, whom do I refer it to, right? So I said, look, and patient was looking Cushingoid. And this lady is looking Cushingoid. I said, do you have any old picture, maybe year, 2 year back? She showed me a picture. She's thin and lean lady, right? But now she's totally Cushingoid. I said, are you taking any medication? No, sir, मैं कोई दवाई नहीं ले रही हूँ. On the second visit, so we did a morning cortisol level, right? Cortisol was low. Clearly, she was taking glucocorticoids and was taking it actively, right? She said, go home and tell me anything you are taking, whether it's a cream or it's an inhaler or whatever. She said, all in our family, everyone in our family, when they have any kind of allergic problem, right? We tend to have a lot of allergies during a particular season. So we write a letter to some Baba in Kolkata, and he sends me a packet of powder, and we take this, which was steroid. And the entire family was having iatrogenic Cushing's. You will not believe, right? So, anything which is, saying that allergy sari thai jaye, skin lesion sara thai jaye, including in children, you will find iatrogenic Cushing. And in children, right, this patient, of course, is very classical, right? But one telltale sign of a child being exposed to glucocorticoids is that the child gains weight but does not gain height, right? So child is being stunted but keeps gaining weight. Whenever you see this, there are two important differential diagnoses. One is hypothyroidism, another is Cushing syndrome, right? And whenever you find a child with this history, remember, in children, when you have exogenous obesity, they tend to be taller, right? They tend to grow much more, right? The height is also more, right? But when you have endogenous problem leading to obesity, especially endocrine problems, these children, right, you need to evaluate. So whenever you have a child coming with, with growth which is stunted, but weight which is being gained, right, hypothyroidism and Cushing syndrome need to be ruled out, right? These are two things. And remember, again, take a history of whether the child is exposed to probably, medications which they should not be taking. So how do you evaluate the HP axis? We made a protocol. Remember, we made a protocol to make things simpler, right? There is slight deviation from what you will see in international textbooks because in India we have limitations. So the first thing when you do, whenever you are suspecting the patient, the HP axis is involved, the first thing you do in the morning, you measure the cortisol, you measure another hormone which is called DHEAS, and all of this you do in the morning. Fasting, remember, it's very important. Timing is very important because remember these hormones are following a circadian rhythm. So do it in the morning, fasting between around 8 a.m. in the morning. If your cortisol level baseline is less than 5 microgram per deciliter, your HP axis is compromised, right? Then you can find the cause, right? I'll leave that to you. If it is more than 12 morning, more or less likely that it is compromised. If it is between 5 to 12, right, you need to evaluate further. So you go to the next step. Next step, what you do, so if you have a cortisol level between 5 to 12, less than 5, more than 12, right? One is for sure, other is for sure not, right? If it's between 5 to 12, you measure a hormone called DHEAS. Remember, DHEAS, adrenal gland has, the adrenal cortex has 3 parts, right? The DHEAS is an adrenal androgen, which is also under the influence of ACTH, right? The difference between a DHEAS and a cortisol is that cortisol has a short half-life, whereas DHEAS has a long half-life of 2 to 3 weeks. So it is like measuring a glucose value, RBS, versus HbA1c. HbA1c give you a better axis over a long period of time. Same way, if you want to see the health of the adrenal axis over a period of 2 to 3 weeks, DHEAS is a better hormone because it has a long half-life, right? So you measure the DHEAS. It's easily available test. All labs do it. Okay, just 2 minutes, I'll wrap this up, right? If you measure the DHEAS, right, you see the DHEAS and remember, DHEAS values change according to the age, right? So different ages will have different cutoffs. The labs will give you the age-related cutoff, right? So you measure the DHEAS, you take the lower limit for that age, and you calculate the ratio. So DHEAS value of the patient divided by DHEAS of lower limit for that age, and you calculate the ratio. And if this ratio is less than 1, the HP axis is definitely compromised. If it's more than 1.8, HP axis is normal. If it is between 1 to 1.8, then you go to the third step where you do a ACTH stimulation. We have this little bit of software which we have made to calculate the DHEAS ratio. You can just quickly see. So you enter the age of the patient, the gender of the patient, you enter the value, and it will give you the DHEAS ratio. It's not commercially available. We'll make it available soon commercially. Okay. The third thing, so cortisol you have measured, DHEAS measured, you have measured the ratio. If you stand somewhere in middle, you do a ACTH stimulation test. ACTH stimulation is very easy to do, right? You just need to give, I'll tell you the protocol, right? Post-stimulation, measure the cortisol. If the cortisol is more than 18, HPA-axis is normal. If it's less than 18, HPA-axis is compromised, right? So 3 steps, very easy to assess, and I think there are a lot of patients in India where you will have to do this. A lot of patients will be on chronic steroid use, whether from qualified doctors or from quacks, they'll be, right? And you will have to do this, right? ACTH stimulation is very easy to do, like I said. You don't need to do fasting for this. You can directly call the patient any time of the day. Give 250 microgram of ACTH. It is available now in India as Sintropac, right? So you can contact your Sun Pharma representative. They now make this available in India. It's cost about 2,000 rupees. You give this either IM or IV, and you do a sample cortisol at baseline, 30 minutes and 60 minutes. And take the highest value, peak value. If this peak value is more than 18, that means the HPA-axis is normal, and it's less than 18, that means that HPA-axis is compromised, right? So this is how you assess the HPA-axis, right? Unfortunately, I don't have time for the other concepts, but I'll just quickly show you just one, which I feel is important, is the management of glucocorticoid-induced hyperglycemia. We had done a RCT on this. This RCT is now part of the international guidelines for this management of hyperglycemia. And just one thing I want to show you, the concept which we have developed for steroid-induced hyperglycemia. Whenever you have, and this is very important in COVID-19 era, so whenever you have a patient with diabetes or without diabetes who is developing steroid-induced hyperglycemia, right? Whatever steroid you are giving, you give one additional correctional insulin or more additional correctional insulin to correct for the steroid you are giving. So let's say you are giving hydrocortisone. Let's say patient is having diabetes, patient is on oral antidiabetics or insulin or so on. You are giving extra hydrocortisone. You give regular insulin along with the hydrocortisone. If you are going to give a methylprednisolone or a prednisolone, most commonly used, give an NPH, because the steroid effect and the hyperglycemia effect and the anti-hyperglycemia effect of these insulins match. And if you're giving a dexamethasone, give insulin glargine or degludec, any long-acting insulin, right? So let's say your patient is diabetic, patient is already taking the anti-diabetic treatment from you, reasonably well controlled, but now we want to introduce a steroid. Then you give a correctional insulin along with the steroid to correct for the blood, right? So this is my deliberation. I think my time is up. Okay, and so I'll just conclude from some take-home messages. Sorry, yeah. Slide not going back? Okay, fine. So I'll just conclude 2 things today, right? Like I said, glucocorticoids are a life-saving medication, right? It has to be used in the right patient at the right time. You need to understand physiological versus supraphysiological glucocorticoid replacement. Physiological is typically steroids given in the doses of oral hydrocortisone 15 to 30 milligram or prednisolone 5 to 7.5 milligram. If you are giving steroids of 20 milligram more than 3 weeks, right, or giving 5 milligram or more at odd times, evening, afternoon, right, something like that, or if the patient already has iatrogenic Cushing syndrome, these patients has supraphysiological issues and the HPA-axis is going to be compromised. And you need to, whenever you suspect a patient having steroid-induced problems, you need to assess for the HPA-axis. The first thing you do a baseline cortisol level, then you do a DHES and DHES ratio, and if required, you might have to do a ACTH stimulation test, right? So with this, I conclude, and we're happy to take questions. Thank you.
Steroid pharmacotherapy has been a gray zone for many physicians, an enigma. And from our postgraduate days, Sandeep and Arvind would agree that we were told, thoda steroid de do.
Yes.
From that to steroid abuse, there is a huge spectrum, and all physicians here would have some anecdotes to share about steroid abuse.
Yes.
Thank you, Om, for taking us through that journey and clarifying a lot of things. Questions will be at the end of the session.
Sure. Thank you, sir.
May I invite Dr. Mona Shah, the next speaker, to talk on insulin resistance. Dr. Mona Shah is a consultant endocrinologist practicing in Vadodara for last 25 years. Having been trained at All India Institute of Medical Science, all of us know about her. Over to you, Mona.
Thank you, Rumin bhai. Dr. Iyer, at the outset, I'd like to thank the organizers, Dr. Akash Singh, Kamaldev Chawla and team, and Dr. Anuradha, for giving this a fantastic opportunity to share some of my learning with you. What I plan to do today is to talk to you on insulin resistance. We must pay tribute to Professor J.R. Revan, the father of insulin resistance, and at a personal level, I would pay tribute to Professor M.M.S. Ahuja, Dr. Pankaj Shah, and Dr. Amini to teach us insulin resistance and make us present few of posters and presentation at international meeting. In your clinic, you see many acute infection, but before 50% of practice would be included of this all phenomena. Type 2 diabetes, obesity, obstructive sleep apnea, NASH or NAFLD, hypertension, coronary artery disease, peripheral vascular disease. You know, what do they all have common in it? The common is core to it, heart to it. Even heart to this conference is insulin resistance. In presence of hypercaloric diet, hypercarbohydrate diet, obesity, sedentary lifestyle in presence of genetic factor, and subclinical inflammation, it can present with protein manifestation that you see in your clinical practice, varying from diabetes, sleep apnea, fatty liver, coronary artery disease, and all. It is said that when solving the problems, dig at the root instead of just hacking the leaves. And that's what we are going to do. I'm trying to make it very simple today, the concept of insulin resistance. I would start from concept to prevention and summarize. And lastly, I would add one new paradigm for you to think over and learn on regarding insulin resistance. What is basically insulin resistance? It's subnormal response of insulin at tissue level. Today, in view of a theme of a conference, we'll talk about these target tissues as primarily liver, muscle, and adipose tissue. In clinical practice, insulin resistance refers to as a state in which given concentration of insulin is associated with subnormal glucose response. Development of insulin resistance results in many compensatory phenomena, and one of them is stimulating pancreatic beta cell to produce more insulin. Insulin is anabolic hormone, which causes more appetite, and it contributes to increase adiposity and thereby further accentuate insulin resistance. This continued mismatch between demand and supply, and ultimately time comes when pancreatic beta cell gets exhausted, and that's where individuals develop diabetes mellitus. Now, how common is this insulin resistance? Worldwide, the prevalence of insulin resistance ranges from about 15 to 45, 46%. In India, recently, South India, Deepa Group and Mohan Group had published data which says that it is somewhere around 15.6% in middle-age income people. This is more of a disease where you have more high calorie and more high carbohydrate, lack of exercise, which is probably high income population. Dr. Arvind Gurup did a study in obese and children, and he demonstrated that 22.2% of obese children had insulin resistance. They used HOMA index for identifying insulin resistance. If you use its Indian standard, it is about a much higher percent, that is about 32.3%. Asian Indian, all of us we know, has more propensity to visceral obesity, and that makes us more susceptible to diabetes. And we all know this figure, that initially it is insulin resistant, which is followed by insulin deficiency, which leads to diabetes. What are the metabolic consequences of insulin resistance? It can result in high glucose, high blood pressure, lipid abnormality, visceral obesity, high uric acid, various inflammatory markers, endothelial dysfunction, and prothrombotic state. When you look at it, progression of insulin resistance can lead to protein multiple disease, which can occur as comorbidity ranging from type 2 diabetes coronary artery disease, even Alzheimer's and cancer rates are increased with insulin resistance. And this is a nutshell. Just have a glance for a minute. A summary of what I talked about. It is insulin resistant. Sorry. Along with prothrombotic state, oxidative stress, inflammation leads to metabolic syndrome, which are characterized by different factors, and there are different definitions for it, which leads to different diseases. And we all know the definitions by different international societies on metabolic criteria or criteria of metabolic syndrome. When we talk about insulin resistance, we either talk in form of pre-receptor, receptor, or post-receptor insulin resistance, or we talk about endogenous insulin or exogenous insulin. Exogenous insulin is where you are giving insulin to patient, and the requirement of patient is much higher, more than 1 to 2 unit per kg of body weight. We call it exogenous insulin resistant. And there's something called psychological insulin resistance, which is part on patient or doctor, either to initiate, to accept the therapy that you advise. When we talk about insulin resistance, we talk about genetic factors and acquired factor. And there are many genetic factors, and I would love to present each of those cases that we have in a clinic. Few, further, far, but they are existent. For some of the acquired cause is mainly because of extra calorie, extra obesity, inactivity, high glucotoxicity, lipotoxicity, increased sodium diet, and some important drugs which contribute to glucotoxicity. Glucocorticoid and antiadrenergic, protease inhibitors which are used in HIV, a topic really to be discussed besides glucotoxicity. Atypical antipsychotics, and you need to create awareness amongst your psychiatric colleague regarding to it. And of course, exogenous insulin, Gerata syndrome, because of antibody development. These are the few patients of different genetic. And you can see there's definite acanthosis, very significant acanthosis, which is seen in Rebsen-Mendel cell syndrome. And this is case of Werner syndrome, where you see features like in elderly with diabetes, like progeria. So what are the clinical manifestations? Clinical manifestation ranges from glycemic metabolism disturbance to lipid metabolic disturbances. Some dermatological manifestation to reproductive dysfunction like PCO. And you need to create the antenna to pick it up in your office. Central obesity, acanthosis nigricans, skin tech or acrochromes, acromegaloid features, and alopecia, which is more in central. These are the clinical markers that you right on spot diagnosis in our clinic to think about insulin resistance in the patient that you're looking at, or even patient's relative, which will become primordial prevention. So a few seconds here for you. If patients are asymptomatic but presents to you with obesity, lipidemia, or hypertension, pre-diabetes or diabetes, those with microvascular complication or macrovascular disease like stroke, coronary artery disease, or peripheral artery disease, those with PCO referred to you by gynecologist for young adolescent obesity with irregular period, with markers of hirsutism, acne, acanthosis nigricans, and ultrasound showing PCO, or those of infertility, planning pregnancy, refer to you for PCO. Type A and B insulin resistant. Gender-specific increase in weight circumstances. If you see xanthelasma, xanthoma, you have to think of insulin resistance. And stigmata of one of the severe variety of insulin resistance. Something that I love and no one likes me talking about, and that is pathophysiology. I'll make it very simple. What is activity of insulin? At muscle and adipose tissue, it facilitates glucose entry inside the cell. At liver, it turns on de novo lipogenesis, lipid formation in liver. So what does insulin resistance does? There is a little paradox. At muscle and adipocyte level, it suppresses glucose entry inside the cell, so makes glucose more available in blood, so hyperglycemia, but in turn, it causes de novo lipogenesis in liver. And that's why probably liver has more fatty acid and development of NAFLD, NASH, and cirrhosis. And hyperlipidemia can be issue, which can cause endothelial injury and then subsequently peripheral coronary artery disease, stroke, peripheral vascular disease. So there are three primary sites of insulin resistance: muscle, fat, and liver. For diabetes, it is postulated that the insulin resistance begins in muscle, but it can be conglomeration of all three resistance. Now, if you look at muscle, skeletal muscle level, insulin's basic function is to translocate glucose transporter 4 to facilitate glucose entry inside the cell and thereby produce glycogen synthesis. Now, insulin resistance occurs, there is no translocation of GLUT4 outside, and that's why glucose does not enter the cell, and that's why there is hyperglycemia. There is no glycogen synthesis. These hyperglycemia causes de novo lipogenesis in liver, and thereby more lipid formation in liver, and which in turn release more lipid in circulation and the consequences. Same can be explained for adipose tissue, where lipolysis is very sensitive to insulin. So when insulin resistance occurs, lipolysis does not occur, and this lipid goes in circulation, which further enhances insulin resistance and adiposity. At liver, insulin binds to insulin receptor, and it reduces hepatic glucose production via inhibition of glycogenolysis and limiting postprandial glucose. When resistance occurs, not only postprandial glucose increases, it also, insulin also inhibits hepatic glucose output in the morning, that is fasting hyperglycemia. So there are also fasting hyperglycemia in this patient. Again, there is more glucotoxicity, which in turn causes insulin resistance enhancement, and patients can progress to various protein manifestations. It's important to know that not everyone have insulin resistance at every level. Professor Ronald Khan, a stalwart, who described, and he created a mouse model by knocked out receptor of insulin receptor at different level, muscle tissue, adiposity. He also did it brain and beta cell and showed the different manifestation of insulin resistance and type 2 diabetes is because the insulin resistance at are different in different individuals. They are influenced by different factors, and there may be combination, and that's why diabetes is a very heterogeneous disorder. Endoplasmic reticular stress and mitochondrial dysfunction also contributes to insulin resistance. So we need to measure insulin resistance. Do any one of you measure insulin resistance in your practice? How do you do that? There are different methods. There are direct method and there are indirect method. The most commonly used in academic institute direct method is hyperinsulinic euglycemic clamp study. And I was very fortunate to be part of those studies in about 30 years back at the Institute of AIMS through Dr. Pankaj Shah. We did insulin-resistant euglycemic clamp study in second generation of diabetes and diabetes with polycystic ovary disease or adolescent obesity with polycystic disease, and privileged to present the posters at different national and international meetings. There are indirect tests, simply fasting or post-stimulated, either glucose or meal-stimulated C-peptide. And there are different insulin indices like HOMA in IR or HOMA2, glucose insulin ratio, Quickie, Macaulay, Matsuda, serum triglyceride. It's very important if triglyceride is high and HDL is low, the ratio is high, there are more chances of individual having insulin resistance. And there are different formula. You can download it through app, or you can ask your lab to do HOMA IR for patients. Like in Baroda, you use those standard 4 labs to do it on their own. So we have ready report available of HOMA IR. It just costs 700 rupees, not more. Gold standard for measurement of insulin resistance is obviously hyperinsulinemic euglycemic glucose clamp. Very cumbersome. It takes your energy, it takes your day to measure it, and it's not routinely practiced. So in clinic, we get HOMA in IR done. But do we really need it? There are enough clinical markers: central obesity, acanthosis nigricans, skin type, and family history of diabetes or metabolic syndrome. But yes, we still do it. It's one of my favorite tests. We do it when we deal with interdisciplinary management. When PCO comes to us, we do it because it gives a fantastic base to communicate with gynecologists and patient. Google smart patient who know about everything, so it's easy to put them right on the track and discuss with lifestyle modification, different therapy that's available to us. Those who are planning bariatric surgery, these are main patients in which we do. And type 1.5 or type 3 diabetes, where you measure C-peptide and HOMA index and tell the patient that patient is not LADA or not type 1, it's type 2 diabetes who is presented at young age, diabetes of age. So what are the consequences? And all through this conferences, everyone is talking about different consequences. We will not talk about diabetes, hypertension, and atherosclerotic vascular disease. What is new is non-alcoholic fatty liver disease. Recently in May 2022, American Association Clinical Guideline has advised to incorporate FIB-4 score into clinical practice and on your electronic health record in your office to identify patients who have NAFLD or NASH. It is insulin resistant with genetic factor, along with the cytokines from adipose tissue can cause fat accumulation and de novo lipogenesis in liver, which in turn cause non-alcoholic fatty liver disease, which further can be precipitated by same insulin resistant, oxidative stress, inflammation, mitochondrial dysfunction, and glut microbiota to cause further fibrosis and chronic inflammation. And that causes NASH, which can progress into cirrhosis and HCC. At earlier level, we can just modify it by taking care of insulin resistance, but subsequently, otherwise we will need bariatric surgeon or even liver transplant surgeon when it comes to cirrhosis and HCC. How much money would we save? Economically so good. Patient suffering is so much less if we can identify in clinic at earlier stage. Polycystic ovary is not only, hyperinsulinism can work at different level, at lipid liver, at liver by reducing sex hormone binding globulin. Ultimately, it causes rise in androgen at ovarian and renal level, and which causes increased androgen, all the symptoms, and polycystic ovary disease. You would remember and know COVID, diabetes, and insulin resistance any day more than me, and you practiced it more. It is something that increases severity of disease, increased mortality, and poor clinical outcome. So it's time to take care of insulin resistance. You can take care of insulin resistance by working on visceral fat, preventing visceral fat accumulation, working at inflammatory level, working at lipotoxicity and glucotoxicity. So what are the therapeutic strategies? Most important to know that no medication are so far approved by FDA. All what we are doing is we are trying to work, and that is why lifestyle plays a very important role. Besides lifestyle, you can use agents which improve insulin sensitivity like metformin and pioglitazone, and extreme rare variety of those insulin-resistant genetic syndrome, we use IGF-1 2 minutes. And you can use agents that contribute to weight loss. I would just click to know that we can work on visceral obesity by different modality. We can work on lipotoxicity by different modality, glucotoxicity by different modality, and also looking at exercise for inflammation care, glucotoxicity, SGLT2 and GLP-1 analog, again to reduce glucotoxicity, weight reduction, and salicylated and hydroxyquinone for taking care of inflammation. And there are newer drugs in pipeline. We have to think of prevention, primary, secondary, and tertiary, but most important is tertiary prevention here is creating public awareness and acceptance of intensive lifestyle medication and bariatric surgery. So summarize, diagnosis of insulin resistance is important. Clinical presentation and surrogate markers are enough to diagnose it. Although hyperinsulinemic euglycemic clamp is gold standard, you can consider HOMA IR in your clinical practice. No medication are FDA approved, but then still we do a lot of therapeutics. There's new paradigm of insulin resistance. If Obama can win his election of 2008 by telling, yes, we can. If Modi hai, to mumkin hai. We as a fraternity can definitely work by reversing type 2 diabetes by reducing insulin resistance. Roy Taylor, his last year published data of direct study, and you all should read it, to try to encourage patients following it, is diabetes remission clinical trial. 46% of patients had a diabetes remission with low calorie diet, low carbohydrate diet, intermittent fasting is query, and bariatric surgery. Thank you very much. And we would like to invite any questions.
Dr. Mohanasha, excellent deliberation on insulin resistance, which is a relatively very difficult and complex subject, made it so easy. Thank you very much. Because of the paucity of time, the questions will be taken up in the break, so people can contact them. I call upon Dr. Himanshu Rana to felicitate Dr. Monasha. Monasha, please be on the stage.
वो स्लाइड आगे बढ़ेगा। अच्छा वो एक बार हमको दिखा दे उसको लाके। अच्छा अच्छा ठीक।
Good morning, friends, seniors, colleagues. How's the mood? Because I've already asked how's the Josh, and I am here on stage as a part of a surprise event. We had not planned this, and so IDCM, Indian Diabetes and Cardiometabolic Diseases Association, the first of its kind to bring cardiologists, endocrinologists, internists, and diabetologists on a common platform. And the success has been tremendous as we have the feedback from all of you. The achievements have been 52 sessions, 5 workshops, 3 debates, and outreach of more than 20,000 population, and in 3 days, above 510 participants. It is your participation that has given us an insight to felicitate our own talent pool. We are one. So may I invite Dr. Darshan Bankar sir and Dr. Akash Singh to be on stage. Is Dr. Bankar around? Can I have him on stage? Okay, so we'll not wait much. I think, sir, you're there. So, as organizing committee of IDCM has taken this decision that each year at the annual conference, we will be felicitating, honoring our own talent pool. So, we just want to announce this Award of Excellence and Innovation in Diabetes to the emerging leader in the field of diabetes and cardiometabolic diseases, Dr. Anuradha Kapoor. Please, madam, be on stage. This is in recognition of her outstanding contributions in the field of preventive diabetology. She has been the brain behind the recently published textbook of diabetes management and behind several online courses run by various prestigious institutes. She has various national talks to her credit, and all these achievements were during the difficult times of COVID-19 epidemic, which failed to dampen her zeal. So, respected sirs, please honor madam. Dr. Anuradha Kapoor works in Bombay. Thank you, madam. So the next Award of Excellence and Innovation in Diabetes Care, this award is presented to the legendary personality in the field of diabetes and cardiometabolic diseases, Dr. Vasant Patel, sir. Sir, please be on stage. Senior most physician, in recognition of his outstanding contributions in the field of preventive and clinical diabetology, he has various regional and national talks to his credit. Sir, 2 words on the occasion.
I'm speechless. So excellent. So excellent. A concept. You have created a concept. Now in the era of specialization, you have tied the specialized people as such. Cardiologist, nephrologist, endocrinologist, and an internist like me. So it is a great event I can put. And I think everybody should learn many things too, because we have been taught analysis. We have not been taught synthesizer. I think we all are analytic people, but we need a person who synthesizes those dots as such. And if we can't synthesize the dots as such, it will be awkward picture as such. I think our aim is to address the problem of a person and get the solution not of a person, but the problem of a person. Thank you.
Thank you, sir. Thank you, sir. So may I announce the next award for excellence in innovation in diabetes. This award is presented to the pioneer in the field of diabetes and cardiometabolic diseases. Dr. Sailesh Trivedi, sir, please be on stage. In recognition of his outstanding contributions in the field of preventive and clinical diabetology, he needs no major introduction. He has various publications, regional and national talks to his credit. So it's a pleasure for us to announce that this ceremony in the conference will be an annual event. May I request Dr. Sailesh sir to speak 2 words on this occasion, but before that, I think sir has already circulated on WhatsApp that this day itself, 17th July, and a Sunday, was the day when he began his Anand Hospital.
Respected teachers, Dr. Vasant Bhai Sahib, Dr. Shukla Sahib, our Shailesh Bhai, office matters of APG, and near and dear Dr. Darshan Bhai and Dr. Akash Singh. And of course, Dr. Anuradha Madam. Well, today we are entering into the 40th year of our practice. I started in 1983. That is a story apart. But when I see Dr. Kamaldeep, when I see Dr. Akash Singh, I don't know how many of you have seen Netflix series called Money Heist. Have you? Have you ever? Please have a look at it. In the last scene, in the last episode, the professor gave a note to an Inspector Sierra, and she was asked to give this note to Rafil, not Raphael, Rafil, who was Berlin's son. And after reading that note, the money was, the gold was given back. And the last scene of that series was, look at me, how am I doing? The professor was in the plane, and he was adjusting his spectacles like this. And he was seeing through a vision, through a window of the aeroplane. Here I do like this. I should see through this glass, without glass, and I can see miles away. I can see miles away Dr. Kamaldeep and Dr. Akash with all achievements in front of them. That is what I can, compare analogy. They have done a great job, as sir has said, a new beginning, a new concept, and to have it at an India level at Baroda, which is not more than 20 lakhs population, to greet them, to have logistics, It's a mammoth task. Venkar sir is used to do this, has been doing this for years together. But for us, for them, it's a new beginning. But beginning is well done. So half the job is well done when you start the beginning very well. So I congratulate both of you, and they deserve all kudos. Bye.
Thank you, sir. Sir, I beg to differ. I'm not impressed with 39 years or 40 years of journey. We are very happy because today is the day when it began, and still many more years, sir.
I have written in the message that in my thinking, I wish to continue my journey. In my message, I have written that I don't want to retire. Age is a... I don't want to retire. I want to work. I want to work like President APJ Abdul Kalam. I want to work like Vasant Bhai Sahib, Girish Bhai Sahib. They worked many years. So, Shailesh Bhai is there. He's an example, fit. So, why should not I? For me, and I am working at least 12 hours a day right now. I think that's enough.
Thank you, sir. So the next award for excellence in innovation in diabetes, this award is presented to a pioneer in the field of diabetes and cardiometabolic diseases. But I don't want to stop the introduction at this level, because in my city, diabetes means Mona Shah. So I invite Dr. Mona Shah in recognition of her outstanding contributions in the field of preventive and clinical diabetology. She has been a faculty to many national conferences and various publications to her credit. So in our city, thank you, ma'am. Thank you, Banker sir. Thank you, sir. So, Dr. Dishang, please take over. This marks the end of the ceremony. We are not late because one talk has been cancelled, so we'll be on time. Thank you.
So with this wonderful award ceremony, now we are again starting our scientific sessions. And we have session number 2 in this day's agenda. To chair this session, I invite our chairperson, Dr. Arvind Iyer, Dr. Madhu Iyer, and Dr. T.P. Soni sir to come on the stage.
This will move.
Hello. Good morning, everybody. Thank you, Akash Singh and Kamaldeep, for getting me here. We'll start the session. We have Dr. Mrityunjay Singh from Gaya, who's going to talk on diabetes and end-stage kidney disease. It's a very important topic. And we heard Shashank Garg from Nadiyad, who also talked on the kidney point of view of diabetes. So, all yours, sir.
So at the outset, I would like to congratulate the ICDM team, including Dr. Akash Singh, Dr. Kamaldeep Chawla, and Dr. Anuradha Madam for this excellent event. Now, respected Chairperson, sir, today's my topic is management of diabetes in end-stage renal disease. Not moving. So, type 2 diabetes is the most common comorbid risk factor for the chronic kidney disease and the leading cause of end-stage renal disease. As the global incidence of diabetes mellitus increases, so will the incidence and prevalence of CKD. Asian patients are more prone to have renal complications. CVD, retinopathy, and amputations are all more common in people with diabetic chronic kidney disease. The presence and severity of CKD is the major risk factor for premature death in diabetes mellitus. So what are the challenges of managing diabetes in end-stage renal disease which we nephrologists face? Actually, assessing the glycemic control in patients with advanced CKD on dialysis can be challenging because the HbA1c, which is a good measure in general population, cannot be up to the mark in this group of patients. There are several biases which I will discuss in later on slides. Next is there is severe glycemic variability, and the physicians are in dilemma whether to give patient, whether to keep patient in good glycemic control or to avoid the risk of hypoglycemia. Again, insulin requirement in ESRD is unpredictable because we all know that exogenous insulin is mostly metabolized in kidneys. Now, the dextrose in peritoneal fluid can interfere with diabetes management, and metabolism of oral hypoglycemic drugs is disturbed in ESRD. So let us first see how the glucose and insulin metabolism in advanced CKD is disturbed. So the patient moves from hypoglycemia to hyperglycemia. Mostly hypoglycemia occurs. And what are the causes of hypoglycemia in these patients? And the most important cause is the failure of kidney gluconeogenesis. We all know that kidney is the main seat. Here 25% of gluconeogenesis occur. So these patients will suffer from fasting hypoglycemia, more common. Other causes include impaired insulin clearance by the kidney, defective insulin degradation due to uremia, increased erythrocyte glucose uptake during hemodialysis, impaired counter-regulatory hormones responses, and variability of exposure to oral anti-hyperglycemic agents, as we all know. And others, what are the risks of hyperglycemia? We all know that advanced CKD patients are having increased insulin resistance, and these are due to anemia, azotemia, acidosis, this metabolic bone disease, this secondary hyperparathyroidism, this increased triglyceride level, which is the most common lipid abnormality in kidney, impaired beta cell secretion, and glucose concentration of diabetes. So monitoring glycemic control with HbA1c, we have three methods: agar gel electrophoresis, which is not suitable in end-stage renal disease patient. Other one are boronate, agarase, affinity chromatography method, and thiobarbiturate acid method. These two we can use for monitoring glycemic control with HbA1c. But there are several biases, as I have discussed with you, and there are high biases. High biases occurs due to increased uremia and metabolic acidosis, which will increase the level of carbamylated hemoglobin and give high HbA1c. And there are several low biases. These occurs due to the lower RBC lifespan and increased erythropoiesis, which will increase the younger generation RBCs. So we should always keep in our mind this situation when we are seeing a HbA1c report of a end-stage renal disease CKD patient. So what are the alternative glycemic measures? These are glycosylated albumin and fructosamine. They are very good when there is a hemoglobin abnormalities. But there are several confounding factors, and one of the major confounding factor is altered serum protein, which always occurs in CKD patient due to nutritional deprivation and due to the loss of protein in dialysate loss of protein in dialysate fluid, or there is loss of protein in urine. So so these are not very good when there is a hypoalbuminemia. Again, disadvantages with these are that there is no evidence that it is better than HbA1c. There is no reference level we have with this, and they are not routinely available in all laboratories. And most important is that there is no data, very limited data of outcomes with this glycosylated albumin. So now moving on to the next, what we should do. So one answer is continuous glucose monitoring, which can give good access in these patients, and we can have several important information from this continuous glucose monitoring, like glucose management indicator, which is very much similar to HbA1c, and of course we can give time in range, which has been discussed by my previous speaker, and this is a very important parameter by which we can avoid hyperglycemia and hypoglycemia in our patient. So time in range should be 50% or more than 50% in advanced CKD patient, and time below range should be less than 1%. So what the KDIGO guidelines says, which is the highest body of kidney, they say that in advanced CKD, HbA1c has low reliability, so CGMI should be used commonly. Now, one important information about this is that when we are using glucometer in peritoneal dialysis patient or peritoneal dialysis patient is on icodextrin, then there is an interference. So we must see this always. We must always see for this. Now, one important phenomena is burnt out diabetes, which is a phenomena which occurs in 33% of the patient, where HbA1c level is less than 6% despite having established type 2 diabetes mellitus. There is decline in insulin requirements or cessation of insulin altogether, and there is a spontaneous hypoglycemia. For this burnt out diabetes in ESRD, many advocate that whether diabetes is required treatment in interstitial renal disease patient. So there are several possible causes of burnt out diabetes. We will not go in detail. And burnt out diabetes, there is an earlier misconception that it is a favorable outcome. No, it has got poor survival outcome due to low HbA1c. So what should be the ideal HbA1c value? From this data, if you will see, the ideal HbA1c should be between 6.5 to 8%. There is a U curve you are seeing here. Again, in DOPS study, it says that HbA1c, whichever is less than 6% or more than 9%, were associated with increased mortality risk. So on the basis of this, KDIGO says that in advanced CKD, we should not be on a stricter glycemic control. Stricter glycemic control is not required, or if patient is having comorbid condition or patient is having resources of hypoglycemic management is not near to them, so we should go for a liberal HbA1c level. So what should be the treatment of diabetes in CKD patient on dialysis? Insulin, insulin, and insulin. But typical starting dose is 50% of the usual starting dose. And as we all know that with dialysis, the insulin resistance will improve. So reduce basal insulin by 25% on the day following dialysis compared to the day before dialysis. In peritoneal dialysis patient, we should start with oral antidiabetic and may move on to insulin if required. Insulin can be given intraperitoneal, which is more physiological, but there is a risk of bacterial peritonitis and subcapsular hepatic steatosis. Again, absorption of insulin is erratic. However, the dose of insulin for intraperitoneal insulin is quite double. Say if a patient is taking 10 unit or 20 unit of insulin before starting the dialysis, peritoneal dialysis, then if you have to shift on the intraperitoneal dialysis, then this will require 20 unit of insulin. So peritoneal dialysis always contains supraphysiological concentration of glucose, leading to worsening of glycemic control, hyperlipidemia, obesity, and weight gain. So we have an answer for this. We can use carbohydrate-free peritoneal fluid preparation like icodextrin and amino acid dialysate solution. Now coming to the oral drugs, sulfonylureas, and in sulfonylureas, short-acting glipizide is the preferred agent in ESRD and dialysis patient. Among meglitides, rapaglinide is the drug of choice. Nataglinide is contraindicated in these patients. Again, DPP-4 inhibitors are concerned. Linagliptin is the good drug, but there are not several studies in dialysis population. Sitagliptin and saxagliptin can be used with dose modification. Thiazolidine, again a very popular drug, and recent studies have shown that it has reduced risk of cardiovascular morbidity and mortality in insulin-free patient, but not on those insulin requiring. But thiazolidine causes fluid overload, and it also increases the risk of fracture, so it should be avoided in end-stage renal disease patient. Again, alpha-glucosidase inhibitor are not very good drug in ESRD patient. Biogonodides we cannot use below 30. As far as SGLT2 inhibitors are concerned, if once they are started, they can be given even EGFR below 30, but if once patient has started on renal replacement therapy, it cannot be given. GLP-1 agonist, there are limited data as far as severe CKD is concerned. Now coming to important, diabetic ketoacidosis in ESRD, which is not very common, but recognition of ketoacidosis is delayed in this patient due to uremia and volume overload they are misnomers, and there is a consensus guideline to treat ESRD in these patients are lacking. So what are the tips to treat decay in ESRD? Likely, these patients are likely to respond to lower doses of insulin. Fluid replacement should be given in boluses. Frequent serum potassium monitoring is compulsory. Maintenance potassium is not usually given due to hyperkalemia associated with ESRD. Replacement is only given if it falls below 3.5 millimole per liter and given slowly. Patient undergoing hemodialysis needs frequent blood sugar monitoring as they can get hypoglycemia with hemodialysis. Any stressor or cause of insulin deficiency must be identified immediately and to correct it as soon as possible. Patient is somewhat accustomed to mild acidosis associated with ESRD, so bicarbonate is not given in anuric patient. Now coming to the hypoglycemia, which is very common in ESRD patients, so how we will treat them? So first, most common cause of hypoglycemia in ESRD patient is anti-diabetic medication. And we should give 15 to 20 gram of dextrose per oral, typically in the form of orange juices or anything which we have with us. And if repeated blood glucose is less than 70, then repeat glucose injection, ultimate blood glucose is more than 100. If patient is unable to tolerate per oral, then we should give 50% 50 ml of intravenous dextrose or intramuscular 1 milligram glucagon. So preventing and managing recurrent hypoglycemia is very much important in end-stage renal disease patient. So we should consider using anti-diabetic medication with low hypoglycemic risk like thiazolidines or DPP-4 inhibitors, reduce insulin dose in patient with insulin-dependent diabetes, refer for diabetes education if indicated. We should optimize nutrition. We should always rule out adrenal insufficiency by doing plasma cortisol and implement ambulatory self-monitoring of blood glucose. So conclusion, patient with type 2 diabetes mellitus and ESRD on dialysis may have higher morbidity and mortality rates than the rates of those without type 2 diabetes. It has been shown in various observational studies that very low HbA1c, less than 5%, and high HbA1c are associated with poor survival. CGMI, continuous glucose monitoring indices, are commonly useful in advanced CKD. Some patients with type 2 diabetes on dialysis may experience burnt out diabetes, in which they may have normoglycemia and a HbA1c below goal. Despite this fact, this condition is not positive and can be linked to bad outcome. Diabetic pharmacotherapy in ESRD should be individualized. In patients with type 2 diabetes and ESRD, insulin is the anti-diabetic medication of choice. If an oral agent is required, the preferred agents are glipizide or rapaglinide. Given the high mortality rate among these population, there is compelling need of larger clinical trials to know the optimal management of diabetes in dialysis patient. Thank you.
Thank you very much, Dr. Mrityunjay Singh. It was an excellent deliberation on diabetes and end-stage kidney disease. Due to paucity of time, questions at the break. Thank you very much, sir.
Thank you.
Hello. Now I would like to invite Dr. Darshan Banker, sir, for his talk on choice of coronary interventions in diabetic patients. What do you say about this introduction? Introduction, everybody knows it.
Good morning, and thank you, Kamaldeep and Akash, for inviting for such a wonderful conference. And it's been, I'm really privileged for two things, for inviting me, and secondly, to felicitate two of my mentors, Dr. Vasant Bhai and Dr. Shailesh Bhai. So it's been a great privilege to be here. What I'm going to talk is not diabetes, but interventional cardiology. So you have some change, and it will be more visual than theories, because you have seen since morning, you have been seeing, and I'm also seeing for the first time, a lot of theories and where the insulin goes and where the the cell takes the insulin resistance and the channels and all that things. So I'm not going to discuss channels and all that things, but what is done in real world scenarios, that is important to understand. And I'll show you what happens to the trials and how does it impact us. So obviously all these things you know that there is, in a diabetic, when you see as a cardiologist, I always say two things as a cardiologist. Diabetes is our number one enemy for a cardiologist, right? You all will agree. But at the same time, you all will agree that diabetes is an annadatta for cardiologist. So obviously, it is like we all know higher incidence of MI, sudden death, morbidity, mortality, LV dysfunctions, arrhythmia, sudden death. All these things is more common with diabetes. You have all seen this, all complex mechanisms has been discussed since morning, and I think the time has come that we get out of this. So why diabetes is important for, as a cardiologist for us? Because it creates a, we know, a prothrombotic state. It's a diffuse vascular disease and obviously glycometabolic dysfunction. So all this leads to reduced efficacy of thrombolytics, reduced efficacy of antiplatelets, then impaired compensatory mechanisms, which leads in clinical terms, we will say, increase in infarct size, proarrhythmias, and ongoing ischemia, which in turn leads to increase in morbidity and mortality. That is how we look at diabetes as a cardiologist. So what is the difference between a coronary of a normal person and a diabetic person? That is where we have a scare, because as such, the Indians have smaller coronaries compared to the rest of the world, or especially European and American populations. And since diabetics have smaller coronaries, I would say in India, diabetics have tiny coronaries, not even small. That's how we measure it. Like routinely, let me put it in a perspective, clinical perspective, routinely a normal coronary of an American is around 3.5 to 4 millimeter size. And average Indian would have 2.75 to 3.25 size of coronary. In a diabetic, we get many times less than 2.5 millimeter, or most of the time less than 2.5 millimeter size of coronary. How does it impact clinically? Smaller the artery, higher chances of restenosis. So that's how we look at it. What is the dimension of coronary is very important to an interventional cardiologist, because smaller the coronary artery, higher chances of restenosis, higher chances of complications, and less ability to put devices, especially the stents. So that's how we face huge difficulty. You have a diffuse disease. So diffuse disease increases the size of the length of the stent, and longer the stent, more the chances of restenosis. Lesion progression is more rapid. I have seen patients coming to me just now, within maybe a week back, maybe 1.5 years back, I had done circumflex angioplasty. Patient recovered totally. 6 months, stress echo absolutely normal. Presented with unstable angina. Critical left main disease within 2 years in a diabetic. That is what we see. And that happens because of various reasons. We all know that. Obviously, all other things we know, larger necrotic core and plaque burden, which strongly relates to a plaque rupture in diabetics. Well, this is what I was telling you. This is what the classical coronaries of a diabetic. I mean, if you look from the perspective, we feel such coronaries cannot be treated interventionally. That's how we look at it. And we have to leave such patients on medical management. Chronic stable anginas, out of maybe 100, 30 of such patients we leave on medical management, because we don't have a choice of doing anything. Forget about angioplasty, even the bypass surgery does not help such type of patients. So unfortunately, we get such a large number of such patients with us. Thrombolize or revascularize. And obviously, in today's world, always given a choice, especially in cities like ours, where now you have 20 cath labs, you always send patient for an primary angioplasty, always gives a better result, especially in a patient who has an anti-wall MI. Irrespective is diabetic or non-diabetic, he goes for a primary angioplasty. That's how we have to look at it. And obviously, For stable patients, we have to see the guidelines. Now, I'll come to my issues with the guidelines later on in my presentation. And obviously, as I told you, angioplasty is more beneficial, but in Indian scenario where patient is away from, say, 6 or 8 hours away from an angioplasty facilities, you have to give him a thrombolytic therapy. Should I stent it? I mean, this is another question. And before the era of drug-eluting stent, it was a nightmare to stent diabetic patients because we knew 50% will come back. If you have put 3 stents, almost 70% of the patient will come back with restenosis. So in that era, bare metal stent era, diabetics were a nightmare for interventional cardiologists. But not so now with a drug-eluting stent. The whole scenario has changed, and the in-stent and restenosis or in-segment restenosis rate has come down to, say, 5 to 10% depending on the segment, depending on the length. And with the newer stent, newer procedures, it has become even lesser. And obviously, this was a Texas data which showed a significant reduction in in-segment and in-stent restenosis. And there were huge trials which carried out and proved beyond doubt that in a diabetic, we can put stents. That was, I am talking about 2008, when the controversy is whether we should stent diabetics or not. We knew by 2008 that, okay, you can put diabetic a stent. Now, which patients you should put stent? And that's where the whole, which kind of stent will help? Does the drug in the stent, we use various drugs like sirolimus, zotralimus, paclitaxel. Does any of the drug has a different effectiveness in a diabetic patient? The answer is no, in a simple terms. So whatever the stent is, whether it is Xience or whether it is Onyx from Medtronic or Synergy from Boston, they have different drugs coated on that stent. It does not change overall long-term perspective in a patient. Is it safe to put a stent? And obviously, short-term and long-term outcome of PCI in a diabetic has shown in recent era tremendous results. And the registries, IRIS DES registry, done just now, Jack has published, Journal of American College of Cardiology has published results of 25,000 patients, 5-year morbidity, mortality, almost the same, except in whether patient undergoes an angioplasty or CABG, except one thing, that reintervention rate was higher in an angioplasty patients. So I'm talking of multivessel PCI. In a multivessel diabetics, the rates of morbidity and mortality compared to CABG are almost the same in today's world, which was not so in combat or pre-combat era. So obviously, diabetes is one of the major risk factors for restenosis and MACE in all of us. So what problems we face in diabetics while doing an intervention? We get long lesions, calcified lesion, diffuse involvement. More commonly, left main and proximal LAD is involved. There is a multivessel disease and stent thrombosis and restenosis. So obviously, we are doing, after pre-combat trial in a Korean study, left main interventions are done left and right, I would say that way. And even my juniors or my senior registrars and junior consultants also have started doing left main interventions because it is one of the, initially we had not established protocols for left main interventions. Now we have, and it has become one of, because the access to left main is very easy, and it is this I'm talking about. Okay. Here, this is the left main where there is a blockage, and we do a balloon and angioplasty. It is, access is easy and you can just open it up. And obviously, the visualization, I'm coming to the visualization. So in a left main disease, if you have a syntax score, which is we do in all angiography blockages, and if your syntax score is less than 22, obviously angioplasty is the procedure of choice. As syntax scores increases, you go more towards CABG. So what favors angioplasty versus CABG? in today's world, we must understand that in another 10 years, as I understand, surgeons will be doing more and more complex cases, and angioplasty will become more and more complex, as well as will be available to more and more number of patients. So surgery will become option for more diffuse diseases, more redo procedures and all that things. And obviously, there are various things. I'm not going, it's a very long slide. I don't want to go into detail of this because it's not. Another thing which has become very common for us to do is a very challenging thing, left main bifurcation. And I would say in very few centers, even in Gujarat, do left main bifurcations with OCT and all that things. And every day almost now I get one patient for referral for left main bifurcation angioplasty. And we are routinely doing this thing. Obviously there are bifurcations is the one thing which all cardiologists now working on, and it is, our conferences are actually dedicated to bifurcations now. So this is a classical case of left main bifurcation. You can see a critical blockage in left main with both the LAD and circumflex are originating from there. So it's a very complex sort of procedure we do. And what we do is we put 2 wires in there and 2 stents, then we recross it and put another stent across that, and then we do visualization of that. This is what the final result looks like after doing a procedure. But then we do trifurcation also. That is, there are 3 vessels coming out of the left main. So this was one, this is second, and this is third. So there are 3 vessels which are coming from the left main, and we put 3 wires and do triple stenting in such cases. Such things are happening very commonly now in many of our efficient centers in Baroda, day in and day out. Other thing which we are doing now routinely to see the internal anatomy, the media, how the stent is placed, whether stent is fully expanded or not, whether there is any micro dissections in the vessel. What we do is we do a OCT, and this is how it is being done. And I'll just do a run of OCT. Now, this is a 3D imaging of the OCT where you can actually visualize the 3D reconstruction of the whole vessel with the stent inside it. And this is being done routinely for so many patients now. And obviously, you can see the stent, you can see the internal of the stents, and this is the basic OCT image which we get, where we can find out where is the stud, whether it is under expanded stent, whether there is any dissections, whether there is any thrombus, whether we need to put another stent distally or not. So all that things we can make out even by all this visual thing. And this is the, we measure the ultimate size of the left main or the LAD, and then that's how we decide the stent size also on that. I'm not going into these slides. So this is the studies of OCT guided angioplasty, which gives us a better outcome over a period of time. One dreaded thing for us is the intervention in ISR, and ISR happens more in a diabetic patients. What is ISR is there is a intimal growth inside, neointimal hyperplasia, I would say, inside the stent, and that leads to what we call restenosis. And this is one of the dreaded complication which is very difficult to treat interventionally. We are trying it. We are doing drug-eluting balloons, cutting balloons, lasers, drug-eluting stent reimplantations. But frankly speaking, that is an area we are not very comfortable as of now. So obviously this is a case of, this is a stent you can see, and we have again dilated it and put it another stent inside. This lady was in a critical situation. We had no choice, and we just had to put another stent inside. The initial angiographic result will look nice, but obviously there is a huge chance of re-stenosis in such cases. We commonly use IVUS, intravascular ultrasound, for all our patients in undergoing a proximal LAD or left main angioplasty if you are not using OCT. The other thing, calcium. We all know calcium or calcification of coronaries is much, much prevalent and common in diabetics compared to non-diabetics. And how do we deal with this calcium? Because it makes the artery hard, it is many times it's not accessible, many times we are not able to expand the stent. So what shall we do? So there are various things which has come up, the cutting balloons, the lithotripsy, rotablation, and orbital atherectomy. These are the ways of doing it. Except for orbital atherectomy, everything we are doing routinely at Bankers. And obviously there are protocols for how to deal with calcification in interventional cardiology. And obviously this is very exciting technology which has come up now in cardiology. You all know lithotripsy in urology, but now lithotripsy in cardiology has also become very commonly used modality for dealing with calciums. And we have been doing this. We have done in 3-4 doctors also, calcified vessel, left main, and we had to do lithotripsy and put stents in them. And this is how the procedure is done. So lithotripsy has changed perspective for cardiology, because otherwise technically it is not very difficult procedure. It is technically very easy procedure. Only thing as of now it is expensive. So as time goes by, it becomes more and more viable for all the patients with calcium to undergo lithotripsy in cardiology also. So this was also a very highly complex procedure which was done. And the interesting part was, in US also the cardiologists refused that such case can be done. And we have done it for one of the very prominent doctor in Baroda. So this was the OCT run for that. And obviously there was a huge, nice expansion of the stent, and the inside image of the coronary was fantastic. Another modality which we use commonly is the rotablation, which is being used quite commonly for calcified lesions. And obviously the rotablation is basically a drill. It's a diamond cap drill with a rotation of 150,000 to 170,000 RPM per. So that drill is just put through, and it does a selective cutting, what we call. And the calcium core is cut off in that, and it makes the artery smoother, and it polishes what we call in coronary, and then it is very easy. I mean, it is easier to put a stent in such arteries. So ultimately the question remains, which diabetic should undergo angioplasty? So obviously single vessel disease now, as of now, is the domain now of a cardiology. Before 15 years, if you would have asked, I have sent so many patients to surgeon with a proximal LAD or a proximal circ to surgeon, because we were not sure whether diabetics would be helped by angioplasty or not. So obviously single vessel disease straight away goes for angioplasty. No evidence of involvement of proximal or mid LAD, then obviously patient undergoes an angioplasty. 2 or 3 highly discrete lesions, then also patient undergoes an angioplasty. And if you have contraindications like severe COPD, very fragile patient, then obviously angioplasty is the choice. Now, if you are going to perform angioplasty in diabetics, think twice, especially in a multivessel disease. Obviously, we use drug-eluting stents for all of them. High dose of biliverdin and high dose of prasugrel, ticagrelor is a must. And coronary prevention measures are always important for them. So these are the recent recommendations for which patient should undergo what kind of procedure. I would just like to mention that obviously this procedure...
So much confusion. Of course, there is a way for the confusion to clear.
We are all confused with this.
Don't be confused. BeConfused.com.
The cardiologists are always confused whether we should do it or not. Because let me give one trial. The trial is, there are so many trials which has happened, okay? Now, one of the trial, Freedom trial, was a trial for multivessel disease, patient undergoing angioplasty versus CABG. Now, FreeADAM trial proved beyond doubt that CABG is better than angioplasty. Okay, there is less morbidity mortality at 5 years. Now, what we always look, multivessel disease freedom trial, CABG better than angioplasty. But if you will actually read the trial and understand the inclusion criteria, it is for chronic stable angina. Okay. Now, in our clinical practice, Kamaldeep will agree, hardly 5% of our patient comes with a chronic stable angina. 95% of the patient either come with a MI or unstable angina. Okay. Now, for that group, this trial does not apply. So what to do? Now, suppose you have a patient, anti-wall MI, multivessel disease, what will you do? You have to do angioplasty of anti-wall, LAD, treat him, and then think about the other arteries. And once you have treated LAD, if you are not going to put Lima to LAD, CABG is out of question, that patient undergoes another vessel angioplasties only. So, we are still more confused by all these trials, because all these trials are designed for Western people, and they design trials for chronic stable angina patients. In our population, we hardly see chronic stable angina patients coming for an intervention. We have a totally different subset of patients. Anybody above 60 over there undergoes a stress thallium. Okay. Whether he is symptomatic, asymptomatic, irrespective. And then they find out, oh, we have some area of ischemia. And then on that basis, they decide, oh, now this ischemia is there, let's do an angiogram. And then angio, they find a multivessel disease, and then they include him in trial. Here, the scenario is totally different. Patient comes with chest pain to the hospital, never with a stress thallium. So we have a totally different subset of patients, and that is what confuses us all the time. I thank you all for patient hearing. Thank you very much.
Thank you, sir. Thank you for the excellent talk.
For the next talk,
You have confused me.
I call upon Dr. Jimit Vadgama from Surat, who is a very promising diabetic specialist, endocrinologist. He will be talking on, till now we were talking about beta cells, but he will be talking on alpha cells in diabetes mellitus, which also has an important bearing. Over to Jimit.
Thank you so much, respected chairpersons, and let me thank Dr. Akash Singh sir, Dr. Kamaldeep sir, Dr. Dishang Bhai, and the whole team of IDCM for inviting me here. And as sir you have said, we are all discussing beta cells, but still there is a large unmet need or undiagnosed or untackled role of alpha cells, and it is very, very important to know what the future can be if we invest more in this field, more in the research, and what benefits or what magic benefits we can have if we go more into details and research into alpha cells. So you have learned wonderful interventional talks in the previous speakers, Dr. Darshan sir, and my talk will be, please forgive me, it's kind of like a physiological lecture initially. So please forgive me for that, but the role of alpha cells still needs to be explored more, and I'll be highlighting how we can, what are the possible ways we can utilize these cells. The knowledge that is lacking, we can improve more on that to help our patient. So since last 100 years of research have been guided by almost exclusive centering to the beta cells and insulin. This is a very important thing. The beta cell stunning and beta cell that has been the exclusive focus for type 2 diabetes and even type 1 diabetes. But regrettably, the role of the remaining humoral factors was subordinated and framed to the insulin resistant paradigm. So everything is focused on insulin resistance only. And it has been challenged because newer possibilities we need to think, because insulin and beta cells is not the only thing. This insulin resistant paradigm has been challenged. So bi-hormonal theory is now being proposed, which suggests the coexistence of relative or absolute hypoinsulinemia with relative hyperglucagonemia. This is again bi-hormonal theory in type 2 diabetes patient, and clinical and experimental evidences have shown that type 2 diabetes occurs with elevated serum glucagon level despite hyperglycemia. Once, as should be the hyperglycemia, ideally the glucagon level should be suppressed, but in type 2 diabetes the levels are still high despite hyperglycemia. So alpha cells, if you go by the history, they were discovered in 1907, later than the beta cells. As we know, the priority is the beta cells only. One of the 4 major types of endocrine cells in the islets of Langerhans. So you can see the figure here. On the external side, you can see the exocrine pancreatic cells. But inside, this is the islet of Langerhans, where the alpha cells, they secrete glucagon, beta cells which secretes insulin, somatostatin is released by delta cells, and F cells, they also secrete pancreatic polypeptide. And rarely some ghrelin producing epsilon cells also exist in the islet. So alpha cell function and mass in type 2 diabetes. So as I said, it's kind of bi-hormonal disease. It is characterized by hypoinsulinemia, either relative or absolute, and hyperglucagonemia with elevated levels of blood glucose levels. And hypoinsulinemia, it results from inefficient insulin secretion and is associated with 25 to 50% of decrease in the beta cell mass. So this is hypoinsulinemia, but patients with type 2 diabetes often show persistent fasting hyperglucagonemia also. And there is lack of suppression of this glucagon level despite postprandial spike. So glucagon should be suppressed, but it is not getting suppressed, what we call the persistent fasting hyperglucagonemia. And hyperglucagonemia aggravates the hyperglycemia that has been due to absolute or relative insulin deficiency by enhancing the hepatic glucose production. So this is one of the very important mechanisms how glucagon increases the blood sugar level via the liver axis. And data has suggested a causal role of glucagon in the pathophysiology of type 2 diabetes, and it supports the development of the pharmacological agents that inhibit the glucagon secretion, or you can inhibit the glucagon action also to alleviate the hyperglycemia in patient with type 2 diabetes. So we can use this model, but there are few hurdles also and few untouched research also. How? So very interesting observation. If you block the glucagon receptor in the liver, okay, very important thing. What you see, you again see alpha cell hyperplasia. Again, a very important mechanism. And there is abnormal lipid metabolism also, hepatic steatosis also, and elevated plasma levels of liver enzymes. But it can be an appealing strategy for treatment of type 2 diabetes. What can be the benefits? We have seen it is hypolipidemic. It reduces LDL level. And glucagon benefit, we all know, it's kind of life-saving agent when our patient is having severe hypoglycemia or stage or level 3 hypoglycemia. So that is the commercial pharmacotherapy, but they can be having us reduce LDL level also. And one of the important aspects we will discuss in last about the curing of type 2 and type 1 diabetes, the possibilities. Alpha and beta cell together, if you see in the setting of unchanged alpha cell number, we know type 2 diabetes beta cell numbers are less, mass is less, but alpha cell mass is usually unchanged. So levels are same. The ratio of alpha cell to beta cell is higher in patient with type 2 diabetes. This finding is substantiated by detection of insulin and glucagon in bi-hormonal cells also in the islets in type 2 diabetes. And alpha cells might be an important source of GLP-1, that is very important, this incretin hormone, and also another peptides capable of stimulating insulin secretion to lessen the symptoms of type 2 diabetes. So again, GLP-1 can be secreted from alpha cells. So what can be the direct effect of glucose on alpha cells? Again, a physiological mechanism, alpha cells. So this is a basic cellular level physiology. Alpha cells usually they have calcium ion oscillation. So despite increase in the glucose concentration, whenever there is increase in the glucose level, whenever there is hyperglycemia, so this electrical calcium activity falls down in normal alpha cells, and these changes in the calcium are opposite to that of observed in the beta cells. Okay, evidence suggests that the initial metabolic sensing of both of glucose by the alpha cells might be similar to that of beta cells, but they act differently. So sensing is similar, but they act differently. And in particular, if you see glucokinase, is the enzyme. It is expressed in both alpha cell and beta cells. But once you knock out glucosylceral enzyme in alpha cell, it leads to hyperglucagonemia and progressive development of hyperglycemia. So glucokinase is an enzyme which lets glucose penetrate inside the cells, and if you knock out these alpha cells, they presume there is no hypoglycemia and continuously they develop hyperglucagonemia. And again the GLUT2 transporter, which has affinity for glucose in the normal physiological range, it is absent from alpha cells. So these are kind of basic physiological things and unexplored things which need to be developed. Very important thing is the paracrine control. We need to change the inter-islet cell interactions, which we also call paracrine control. In addition to glucose, there are numerous paracrine hormonal and nervous signals. They fine-tune the glucose secretion. So what you can see here, whenever glucose enters into the beta cell, we all know it stimulates insulin secretion. Also, insulin via the delta cell, they stimulate somatostatin. And this is the alpha cell. Alpha cell has both insulin receptors also and somatostatin receptor also. And both of these receptors, they inhibit the glucagon secretion. Similarly, interestingly, we have beta adrenergic receptors also, which can, once there is increase in the adrenaline via sympathetic activation, it directly stimulates the glucagon secretion. And one of the reasons at this adrenergic receptor or the sympathetic activity increases the blood glucose level. Similarly, via neurons, via brain acting, brain glucose sensing, we have two additional control on alpha cells. So these are parasympathetic tone and via GABAergic neurons, which can again stimulate the glucose secretion. So whenever there is hyponeuroglycopenia, so these two axes can also secrete glucagon from the alpha cells. So this is a paracrine control and neuroendocrine control, and this is the same thing. So what can be the basic activators and inhibitors? Yes, physiological activators can be GIP, GRP, adrenaline. Via parasympathetic, we have acetylcholine also, cholecystokinin, ghrelin also, which are the physiological activators which increases the glucagon secretion. And inhibitors are insulin, we all know, then somatostatin, leptin, secretin, and serotonin, and very important, GABA and GLP-1, they inhibit the glucagon release. Coming to very important aspect of alpha cell and liver axis. This is a thing which I told you, that if you disrupt the hepatic glucagon signaling in the, block the glucagon in the liver, it invariably linked to alpha cell hyperplasia in rodents and even humans also. This is again a very untouched topic, and how we can use this information in the future in our type 2 diabetes patient. And again, very interesting observation is the amino acid production. So whenever amino acids level is increased, it goes into alpha cell and increases the glucagon secretion. And this glucagon secretion again promotes the utilization of amino acids. So this is again another axis that has been untouched, and we can use this alpha cell hepatic axis. Last part, very important thing, is the alpha cell development and its possible modulation, how we can modulate this as a therapy in type 1 diabetes patient. So we know the foregut endodermal cells, which are very progenitor cells, they form pancreatic progenitor cells, and then they differentiate into endocrine progenitor cells. And via multiple transcription factors and circulating factors, this can develop either into alpha cells or beta cells. But very interesting observation that has come in recent years is we can modulate these alpha cells, which I already told, the alpha cell mass is still there in type 2 diabetes. Even in type 1 diabetes, alpha cell mass is still there. So how we can modulate these alpha cells, remaining alpha cells, and we can transfer them to beta cell, or can transform them to beta cells. And this can be a reason for future research. And you can see in the type 1 diabetes, so beta cells, the green cells are all dead. You can see the alpha cells are still there. But there are a few studies that we can stimulate these remaining alpha cells with GABA and artemisinin, and these two stimulus, they can transform the remaining alpha cells, some of the alpha cells, into either bihormonal cells or even in beta cells. So they can be a probable rescue for type 1 diabetes. So this is a alpha cell to beta cell reprogramming, can be a magical treatment for type 1 diabetes. And let me summarize due to paucity of time. So all the long thought of health culprits, the dysfunction of which contributes to the pathophysiology of both type 1 and type 2 diabetes, And it now appears that alpha cells might be our saviors also, and able to provide the new source of beta cells if we can transform them. And a demonstration of this provocative concept in clinical practice might ultimately herald a new era in diabetes mellitus research and treatment. I thank you again, everyone. And if there
Thank
are
you very much, Dr. Jimit Vadgama. It was an excellent deliberation on a difficult subject.
Yes.
Maybe in future more light will be thrown into alpha cells also.
Thank you.
In the interest of time, I think there are 2 more sessions left. So Dr. Vadgama will be available for questions in the break. Thank you very much.
I think Dr. Jimit Vadgama, you can remain on the stage, and I would ask a respected chairperson to give a moment to Dr. Jimit.
Thank you, sir. Thank you, sir. Thank you, ma'am. Thank you, sir. Thank you. Thank you. Excellent. Thank you.
Now I call upon a stage Dr. Darshan Banker, sir, to receive a moment of appreciation. Now I call upon a stage Dr. Mrutyunjay Singh to receive a moment of appreciation. Now I request Dr. Mohammad Kedi to come at the stage and to facilitate our chairpersons. So with this, we are winding up the session number 2 and quickly going to session number 3, which is going to be chaired by Dr. Mohammad Kedi. And I also invite Dr. Kishan Jani and Dr. Sandeep Shah to come on the dais to chair the session.
So it's a really pleiotropic or hybrid conference. Lot of interest from physician perspective. And we have seen that each session is pleiotropic. Each session you crisscross the interest. Otherwise it is diabetes, 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 hypertension, hypertension, hypertension. So we congratulate. And one of the kingmaker is here in front of you. So please, Dr. Kamaldeep Chawla, please go ahead.
Thank you, sir. Good evening, good afternoon, friends. I'll begin my deliberation today, Future of Cardiology, Healthcare. So, frankly speaking, we should not forget these beautiful words from Soren Kierkegaard, who's a thinker, philosopher. Life must be understood backwards, but lived forwards. So, a typical case of a coronary angioplasty now 30 years old, but I think the day is not far where our prescriptions will not have ecosprin, beta blockers, statins, but our prescriptions will be routinely seen as rivaroxaban, SGLT2 inhibitors, evolocumab as the molecules of future. Some startling facts. Approximately 60% of world's heart disease burden is in India, despite having less than 20% of world's population. As in the previous talk, Dr. Banker said about the Indian coronaries, small, fragile patients, and small vessel diseases, and more morbidity and more mortality. And the big question is why? because we have a genetic predisposition with a thrifty gene in all of us. So what happens in utero is seen macroscopically, microscopically in the human being as life progresses. The future is the future advance in care of patients with ST elevation MI who will not come from analysis of trials that do not reflect current practice. So the delays that we see in our country, in major underdeveloped countries, has to be overcome. The new challenge is to network local organization, team education and training so as to shorten total ischemic time and improve the number of patients reaching hospital. So we will take help of artificial intelligence, public-private partnerships, etc. And that is the future of managing a primary angioplasty. We will do our jobs in the hospital, but the patients have to reach on time. The stents, if you remember around 2010 to 2015, there was a major debate that the stents have failed. But then again, the new technology came in, we got in new stents, and again our outcomes are as good as that the outcomes or the beneficial outcomes are above 98% in majority of patients. The newer strategies also lie in using certain invasive modalities like 3D printing. We also in the morning a case of LA appendage closure. So now what they do is they 3D print that particular patient's LA appendage, make the device accustomed to the patient, and the safety outcomes are significantly better. Preventive outcomes like ESMR, that is extracorporeal shockwave myocardial revascularization for particular patients of diabetes, as we saw. You cannot do anything for those patients. No bypass, no angioplasty, but you cannot let them to live in chronic angina because you have a technology with you and you can use it. Coming to the valvular section of the future of cardiology, we are going from surgical replacements to percutaneous replacements. The technology in terms of aortic valve, in terms of mitral valves is significantly advancing, wherein by a keyhole or a puncher, small puncher, we enter the valves and deploy to repair the valve, to replace the valves in less than an hour, and the patients are discharged the next day, unlike a surgical replacement wherein patients stay in the hospital for around 7 to 8 days. Similarly, tricuspid valve repair, a dreaded outcome or a dreaded option even for the surgeon to do a tricuspid valve repair, and we can do percutaneously. I want to bring to your notice that we are all discussing a lot about towers, transcutaneous aortic valve replacement, mitral valve replacement. But don't you think that a day will come wherein the life of these valves is 5 years, 6 years. So we'll have a pool of patients who have outlived these valves. Even the percutaneously replaced valves have stenosed again. So what will we do for these group of patients? And the answer is in future of cardiology, Cardiawave, which is a French startup. They have done 4 patients using shock waves and ultrasound waves. They have opened aortic valve of valve area 0.9 percutaneously only by non-invasive mechanism. So these are the options, because we will not have more patients for invasive outcomes or for percutaneous outcomes. Majority would want a percutaneous outcome. In terms of bypass surgery, we are moving mainly from open heart surgery to MICAB surgeries, wherein the whole bypass instead of a median sternotomy is done through minimally invasive sections. Robotic came into picture, which was seen as a future in cardiology, but it's not highly feasible because of several cost constraints and several technological constraints. We are moving to the era of robotic angioplasty. The cardiologist is sitting 40 kilometers away and performing a robotic angioplasty in a setup where he cannot reach. This may be the future of cardiology. Another good procedure concept, not majorly implemented in our country, but definitely as a future, we are going to see a lot of hybrid procedures, wherein the surgeon will put in a Lima graft to LAD, and cardiologist will perform angioplasty of RC and circumflex artery to give a good long-term solution to the patient, to give a minimally invasive option to the patient, and faster recovery to the patient. We are seeing a lot of cardiac transplants. This is in vogue. Major centers are pumping in money, corporates are pumping in money, so that the country moves to the era of cardiac transplant so as to reduce morbidity of patients. Coming to pacemakers, we have forgotten, or we are slowly going to forget, the art of implanting pacemakers, because again we are going very less invasive. We are going to percutaneous routes to implant these bullet-shaped pacemakers into the heart. And we can say that Baroda as a city has implanted more leadless pacemakers than even Ahmedabad in our own state. Moving from implanting devices, we are going to the era of putting subcutaneous devices, so that the device is put subcutaneous and it works from outside and we do not enter the patient's body. As cardiologists, we are entering into new territories. We are going into acute stroke programs, because if you see the statistics, there are some 8 lakh strokes per year and only 200 neurointerventionalists, and whereas there are almost 8,000 interventional cardiologists available. The whole army is there, you just train them, and that may be the future, that various other territories might be conquered by cardiologists. This is an example of a fibroid removal percutaneously, and there is one cardiologist in India who is prominently marketing himself in Calcutta that he does exclusive work for this only, and he does almost 10 procedures a day for uterine fibroids. We have not geared up, but we don't know what the future may bring to us. The future lies for research-based healthcare. I think majority of us in this hall don't want our kids or our progeny to become doctors. But definitely we should encourage, if they want to enter healthcare, a research-based healthcare at the level of mitochondria to treat diseases macroscopically, at the level of sarcoplasmic reticulum to treat diseases on a macro level. Good words, encouraging words by WHO Deputy Director General in 2007, through the research strategy, what we can do to democratize R&D so that knowledge is not just for the rich and is equitably used to improve health for all the people. Beautiful words take us to the future, and this is what lies: a public-private partnership in terms of synergy and innovation, deliverability, benchmark performance, capitalization of expertise and strengths. To summarize, the cardiovascular disease continuum begins with risk factors onto microscopic endothelial dysfunction, onto macroscopic myocardial ischemia, angina, and ultimately remodeling, cardiac failure, end-stage disease, and death. So the innovation and future lies in education, practice, and evaluation. We need new imaging technologies, we need new targeted drugs, we need less invasive procedures, we need biodegradable technologies, we need gene therapy and nanotechnologies, and this may be the future. I just want to share with you. This is a favorite slide of mine. So this slides I had prepared almost in 2015 for a talk, and I am continuously evolving these slides. And that time I had this slide which I have not changed, and this is my last slide. In 2015 to 20, a robotic copy of a human body remotely controlled via an external device may be available, and yes, we are seeing a robotic angioplasty. 2020 to 25, this is all in process. This is all going on all over the world. An avatar in which a human brain is transplanted at the end of one's life. You know, I think who has attended yesterday's workshop on Know Your Subconscious Mind? So what it says that you remove a nucleus from the cell doesn't die. It's only when you crush the cell that it dies. So even at death time, the brain lives for some time. By 2030 to 35, an avatar with an artificial brain in which a human personality is transferred at the end of one's life. And by 2040 to 45, we may have a hologram-like avatar, you know. So I think in future lies that we may all be sitting 50 years from now and talking again about future of cardiology and healthcare. Thank you.
Thank you very much, sir. Let's have a deja vu in future, and we'll discuss more on this. Thank you very much, sir. For next session, we would love to invite Dr. Pradeep Dalwadi for the topic bone health and diabetes. Over to you, Dr. Pradeep Dalwadi from Surat.
So, very good morning, everybody. First of all, I would like to say thanks to Chairperson for kind words of introduction, and I would like to say thanks to IDCM team for giving me the opportunity to talk in front of you. See, as Chairperson has rightly said, that this conference is not monotonous. We are not talking about a single aspect of the disease. We are talking about different aspect of the disease. And today, I'm going to talk about a very different aspect of diabetes, that is diabetes and bone health. Okay. So diabetes and bone health is a very important aspect. In a diabetic patient, we need to concentrate on bone health as well. So I'll be talking about whole bone health in a diabetic patient. So, okay. So in my presentation, I'll be starting with introduction, then I'll be discussing epidemiology, then we'll be discussing link between type 1 diabetes and bone health, link between type 2 diabetes and bone health, then we'll be discussing assessment of bone health in a patient with diabetes mellitus. At last, I'll be discussing management, and I'll summarize my presentation. Now, if I tell you about definition of osteoporosis, we all know that it's a skeletal disorder characterized by compromised bone strength that predisposes to an increased risk of fracture. And what is this bone strength? The bone strength reflects the integration of two main features. It is not just density, it is a bone quality as well. So bone strength reflects integration of bone density and bone quality. When compromise bone strength, it increases the risk of fracture, and that is called an osteoporosis. Now, diabetes and bone health, we know that the prevalence of diabetes mellitus is increasing exponentially. Currently, we are having more than 450 million people affected with diabetes mellitus across the globe. And similarly, diabetes-related renal and cardiovascular complication, in particular, resulting in enormous burden on the healthcare system. As cardiovascular disease and microvascular complication, see, diabetes-related bone disorder is also a very important aspect. See, diabetes adversely affect the skeletal as well, and the increased risk of fracture is an important complication of diabetes mellitus. So, in a diabetic patient, diabetes and osteoporosis are both common disease condition, especially in older patients, and might occur together at a time. See, this association of diabetes with poor bone health was first described 50 years ago by Albright and Reffinston. He has shown that diabetes might possibly show association with low bone mass resulting in osteoporosis. Now we have a lot of small studies available says that diabetes is definitely associated with adverse bone health. Now if I talk to you about diabetes, fracture risk and BMD, we all know that there is no doubt in a diabetic patient there is increased risk of fracture. And so many studies are telling us that there is increased risk of fracture in a diabetic patient. But this increased risk of fracture is currently underestimated by currently available conventional diagnostic modalities. So what should we do in that situation we'll be discussing. However, now if you ask me, diabetes and bone density, see there is controversial result. See, diabetes not only affects the density, it affects the quality of the bone. So there are controversial results. Some studies are telling us that diabetes may be associated with lower BMD. Some studies are telling us that diabetes is associated with no change in the BMD, while some studies are telling us that type 2 diabetes may be associated with higher BMD, but at the cost of poor quality of the bone. So in terms of fracture risk, there is no doubt, there is increased risk of fracture. But if you ask me in terms of BMD, you may have decreased, normal or high BMD in a diabetic patient, because diabetes affects the quality of the bone. Now if you ask me about pathophysiological interaction between diabetes, see, diabetes bone disease is caused by a complex underlying mechanism leading to impaired bone quality. Okay. And different mechanism plays a role in patients with type 1 and type 2 diabetes mellitus, which affect bone strength, bone turnover, and stem cell differentiation, resulting in altered bone density and bone quality. Okay. Now, if you ask me about bone health in a patient with type 1 diabetes mellitus, see, the risk of fracture in a patient with type 1 diabetes mellitus is threefold higher than general population. And increased fracture risk start 10 to 15 years earlier than non-diabetic population. So they are at very high risk of developing fractures. And fracture risk is higher in a patient with type 1 diabetes mellitus if they are having some microvascular complication. So type 1 diabetes patient with microvascular complication have a very high risk of fracture at relatively younger age as compared to general population. Now if you ask me mechanism of increased bone fragility in patient with type 1 diabetes mellitus, it is all because in a patient with type 1 diabetes mellitus, there is decreased BMD. And the BMD decreases more at hip as compared to the spine. And this is strongly associated with microvascular complication. If you ask me about bone turnover, see, diabetes is a state of low bone turnover. And if you ask me about bone geometry, it predominantly affects cortical bone. If we talk about non-osseous factor, see, recurrent episode of hypoglycemia is very common in patients with type 1 diabetes mellitus, and it will increase risk of fall and increase risk of fracture. Sometimes autonomic neuropathy and retinopathy also increases fall. If we talk about additional factor, see, uncorrected thyroid dysfunction is one of the risk factor or a factor which is leading to a poor bone health in a patient with type 1 diabetes mellitus. So many patients with type 1 diabetes mellitus have a celiac disease, and if they have a celiac disease, it again compromises the bone health in a patient with type 1 diabetes mellitus. Because of uncontrolled blood sugar level, they do have hypogonadism, and if they have hypogonadism, again it compromises bone health in a patient with type 1 diabetes mellitus. So in a patient with type 1 diabetes mellitus, they have a low bone mineral density, and that is because low body weight, low level of insulin and IGF-1, low amylin, and there are so many numerous mechanisms. Again, there is increased risk of fall, like it may be because of retinopathy, neuropathy, or hypoglycemia. There is poor bone quality because of age, and associated disorder like celiac disease, hypogonadism, vitamin D abnormality, all contribute to increased skeletal fragility. So in a type 1 diabetic patient, there is no doubt, there is increased risk of fracture, there is decreased BMD, and we need to screen this patient for osteoporosis. Now if you ask me about bone health in a patient with type 2 diabetes mellitus, see, patient with type 2 diabetes mellitus carry lesser fracture risk than type 1 diabetes mellitus, but higher than the general population. Among the skeletal site, the hip fracture is quite common. Okay, a young age, prolonged duration of diabetes mellitus, axial ethnicity are the factor associated with higher risk of hip fracture in a diabetic patient. Again, if you ask me to link fragility in type 2 diabetes mellitus, regarding BMD, we have a controversial result. Bone turnover, it is low bone turnover state. Regarding geometry, there is alteration in the microarchitecture. Non-osseous factor, again, there is increased risk of hypoglycemia, which may increase risk of fracture. And autonomic neuropathy and retinopathy increase fall, which lead to fracture. On top of that, there is additional factor like drugs. We know certain drugs affect the bone quality of the patient. Now, if you ask me in detail about effect of diabetes therapy on the skeletal parameter and a fracture risk, let me start first with the insulin. We know insulin is anabolic. Though anabolic, it increases risk of fracture. Okay, how? It increases risk of hypoglycemia, and by hypoglycemia, there is increased risk of fall, and that lead to fracture. So, effect on the bone is positive. It is anabolic in nature, but it increases risk of fracture because of hypoglycemia. Now, if you ask me about metformin, again, even a metformin is anabolic. It reduces oxidative stress. In a meta-analysis, the use of metformin has said that it reduces risk of fracture, and it is because there is lower risk of hypoglycemia with metformin. So overall, the effect of bone is positive, and there is reduced risk of fracture with the use of metformin. So in a patient with diabetes and osteoporosis, metformin, definitely it's a very good agent. Now if you ask me about sulfonylurea, effect on bone metabolism is negligible, but again the risk of fracture is high, and that is because hypoglycemia. A meta-analysis of 11 studies, including 25,000 patients, says that there is increased risk of fracture if the person is taking sulfonylurea, and that is all because of hypoglycemia-related fall. Okay. Now, if you ask me about SGLT2 inhibitor, initially we had thought that SGLT2 inhibitor reduced BMD. Even one of the studies has said that canagliflozin reduced BMD at hip. But if you see a meta-analysis including 30 studies, RCT demonstrated that there is no increased risk of fracture, and there is no direct effect on bone because of SGLT2 inhibitor. Okay. Now, if you talk about pioglitazone, I think we all know that pioglitazone reduces BMD, and it increases the risk of fracture. That was demonstrated by various trials, and we know the mechanism because it inhibits osteoblast differentiation. Ultimately, it reduces bone density, and meta-analysis involving more than 25,000 patients is telling us that pioglitazone is definitely associated with negative impact on the bone health, and it increases risk of fracture. So we have to be very cautious when we are using pioglitazone in elderly patients with osteoporosis. Okay. Now, if you talk about DPP-4 inhibitor and GLP-1 receptor analog, they have a neutral effect, and there is neutral effect on a risk of fracture as well. So many studies say that it is not associated with poor bone health, and definitely there is no increased risk of fracture. Now, if I talk to you about metabolic surgery, I know we all know that Roux and Y gastric bypass can decrease BMD and can increase risk of fracture. Okay. Now, risk assessment modality. Do we have any modality to assess risk in patient with diabetes mellitus? See, risk stratification of patient with diabetes is still lacking. Tool available are DEXA, FRAX, and HRP QCT. But if you ask me about DEXA, DEXA is a gold standard for bone health assessment in a general population. In a type 1, you may find low BMD. In a type 2, you may find high or normal BMD. But in both diabetes, BMD underestimate fracture risk. Regarding FRAX tool, we know it is 10-year probability, it gives you 10-year probability of fractures, and it is based on clinical risk factor and the hip BMD. But again, the FRAX tool underestimate risk of fracture in both type 1 and type 2 diabetic patient. So both modality do not provide satisfactory fracture risk evaluation. You can use high resolution peripheral quantitative CT. It is a better predictor of fracture in patient with diabetes mellitus than DEXA, but not widely available for routine clinical practice. So what should we do in this situation? We need to take help of our clinical clue. There is one group, like the Bone and Diabetes Working Group of International Osteoporosis Foundation, and they have given indication. What recommendation they have given? In a diabetic patient, you can use cutoff of -2 rather than -2.5. So in a diabetic patient, you can use lower cutoff, that is -2 in place of -2.5. In a diabetic patient who are having risk factor, you monitor BMD at 2 yearly, and if there is gradually significant bone loss over a period of time, that is 5% bone loss in a 2 year, you need to treat the patient for osteoporosis. And if there is a worsening of bone density and it is approaching -2, again it is an indication to start treatment in a patient with diabetes mellitus. But this criteria has a limitation. It's a very low, I can say, level of evidence, and it is not applicable in Asian people. So there is a limitation of recommendation. There is no uniform consensus available. This is one group working on it, and they have given their own recommendation. In diabetic patient, when we are not having consensus, when we are not having recommendation, I think we need to use our clinical judgment for the management. And how can we approach patient with type 1 diabetes mellitus? Evaluate for additional risk factor like history of vertebral fracture, fragility fracture, poor glycemic control, associated disease, recurrent hypoglycemia. If patient is having multiple additional risk factor, if the patient is having risk factor, yes, you do DEXA scan, and if you see the score is -2, in that situation you start treatment for osteoporosis. But if the risk factors are not there, then you give calcium, vitamin D, and physical activity, and re-evaluate periodically. Now, what to do in a patient with type 1 diabetes mellitus? Again, evaluate for diabetes-specific clinical risk score like duration of diabetes, anti-diabetic medication, poor glycemic control, microvascular complication, low BMI, recurrent hypoglycemia, postmenopausal women and elderly men. These are the risk factors. Based on the risk factor, you try to manage the patient. If the patient is having diabetes mellitus and hip and vertebral fracture, straight away you can start the treatment, there is no doubt. If the patient is having other fragility fracture, do a DEXA scan and do a vertebral morphometric assessment. If there is morphometric vertebral fracture, you start the treatment, no issue. If the patient is having T-score -2 or less than -2, you again start the treatment. But in that situation, if the score is below -2, or I can say more than -2, in that situation, calculate a FRAX. And if the FRAX algorithm says that person at a higher risk of fracture, you start the treatment. And if the FRAX score is not suggestive of treatment, in that situation, you monitor periodically. Now, the most important group, if the person is having no fracture, what do you need to do? In that situation, you use diabetic-specific clinical risk factor, and if the age is more than 50, you do DEXA scan. And if the DEXA scan is suggestive of treatment, start the treatment or monitor every 2 to 3 yearly. If the patient is having no other clinical risk factor, in that situation, you need to do annual assessment of clinical risk factor and fracture. So this is, I can say, a clinically used algorithm you can apply in your clinical practice when you are managing type 2 diabetes mellitus for bone health. Now, management of coexisting type 2 diabetes and osteoporosis. See, so many times we see type 2 diabetes mellitus and osteoporosis. What do you need to do? Modification of lifestyle, like moderate weight loss, exercise, calcium and vitamin D supplementation. You need to do aggressive monitoring. Management of diabetes mellitus, and the preferred agent is metformin, DPP-4 enzyme inhibitors, GLP-1 receptor agonists, because you want to avoid hypoglycemia, you want to reduce the fracture risk. In that situation, you can use these agents for management of diabetes mellitus. And regarding management of osteoporosis, we are having 3 prominent agents, that is teriparatide, denosumab, and bisphosphonate. Okay. So if I summarize my presentation, both type 1 diabetes mellitus and type 2 diabetes are associated with bone fragility, although via different mechanism. Okay. The situation seems more complex in patients with type 2 diabetes mellitus as BMD is elevated and the bone quality alterations are multifactorial. Okay. Diabetes-associated osteoporosis and fractures are important complications to consider when evaluating patients with a long-standing uncontrolled diabetes mellitus. And we need to use realistic approach because we are not having consensus available. So we need to use a realistic approach or clinical decision as there is no consensus available regarding how to screen and when to start treatment for osteoporosis in a diabetic patient. So we need to take our own clinical judgment for the management of diabetes mellitus. So this is all about diabetes and bone health. Thank you. Thank you for your patient listening.
Thank you very much.
Thank you.
And the main summary carry home pack is don't overtreat. Diabetic patients already on so many pills. So unless you find real deficiency, don't overtreat patients with calcium. So there is little correction in the next session. Instead of Dr. Sanjeev Pathak, we have got Dr. Rotem Kainan from Israel, who will talk on novel treatment for hypertensive CKD patients.
Thank you very much, chairs. And thank you very much for the organizers for having me here and inviting me for this very nice conference and very well organized. I'm Rotem Kenan, and I will start with my presentation. Okay, I want to show you a novel treatment for hypertension and chronic kidney disease patients. It's called the NephroSpec. And it's a low-intensity shockwave treatment therapy for the treatment of chronic kidney disease and hypertension. As you probably know, more than 700 million people globally are suffering from chronic kidney disease and hypertension. It's 100 million of them are in Europe, and it's the 10th cause of death in the world, and by 2040, it's going to be the 5th cause of death. Chronic kidney disease are going into end-stage renal disease, and then the only options they have are currently dialysis and transplantation. Both are invasive, and a lot of drawbacks into dialysis. It's a long-life treatment. In Europe, they come for 3 times to the hospital. They cannot work anymore. It's costly. It costs lots of money. It's 15 billion cost in Europe, and it's about 100,000 per patient per year. And it's a high-rate infection, and the 5-year survival rate is only up to 50%. So with the NephroSpec, what we do, we target the diagnosis of CKD stage 3 and 4 patients with hypertension, and we provide an outpatient, non-invasive, safe, and I'll show you also in my slides, an effective treatment for CKD patients when we treat hypertension and chronic kidney disease patients. It's built out of 3 components, major components. You have the shockwave generator with the probe generating the shockwaves to the kidney, then the ultrasound, which is helping us to aim the treatment to the correct spots on the kidney, and the XY system that we use for that. I'm talking about chronic kidney disease and hypertension because almost all chronic CKD patients are suffering from hypertension as well, more than 90%. And these are the patients that we are attending now in our clinical practice. It's a strong IP protected in the US by a patent of method and technology also in the rest of the world. And just a glimpse of the results we currently have, impressive, I might say, from the preclinical study that we did in Mayo Clinic with a grant from the NIH of $3.4 million. You can see, I think this picture can tell more than words about the ARAS model they had on swines, pre-shockwaves and post-treatment, and you can see the capillaries, how they, it's a micro-CT image, how they perform better, and the perfusion as well. For the study we did on humans, the clinical trial that we did in Japan in Osaka University, and these were CKD patients with diabetes, 3B stage CKD. You can see a dramatic decrease in hypertension, in blood pressure and a slight improvement in globular filtration rate and in blood urea, maintaining the functionality of the kidney. So we can already say that we are reducing the blood pressure, improving the hypertension. We are increasing the renal functionality. We are saving a lot of money to the healthcare system, depending on what healthcare system you are talking about. And it's a compact system that can be transported and can be used in clinics in the community as well as in the hospitals. So going a little bit thoroughly into the results themselves, a preclinical study that was done in Mayo Clinic in the US by Professor Lilach Lerman, a nephrologist. We used arteriosclerotic renal artery stenosis model, and unfortunately the precontinuous artery stenting was not very successful, is not very successful in restoring the renal functionality. So the hypothesis was to try and use low-intensive shockwave therapy to improve that functionality. So 28 domestic pigs were randomized to actually a treated group and non-treated group, 4 groups, 2 were treated and 2 not. And they were administered, they blocked one side of the kidneys and gave them a special diet to get ARAS. And after 3 weeks, they started with the treatment to the treatment groups, twice a week, 6 sessions in 3 weeks. And the results were that in terms of safety, no adverse events. It was 15 points that they were targeted with an energy flux of 0.09 millijoule per millimeter square, and no hemorrhage, no real severe adverse events were observed. And the results themselves were very, very interesting, because we saw a very dramatic decrease in norepinephrine and plasma renin activity, which, as you know, correlates with the hypertension monitoring. And you can see it's correlated to the results we receive from the main arterial blood pressure checked invasively, which was reduced accordingly. You can also see here it was a well-invested study. So you can see in the micro-CT I showed you before, and you can see it in numbers down there on the graph. The density of the capillaries was increased dramatically, and the bold MRI, using with a 3 Tesla MRI system, was reduced. You can see, you can see nicely the oxygenative tissue, which was increased after treatment. You see this is ARAS plus software and ARAS alone. And you can see the hypoxia reduction and the modular hypoxia also reduction. You can see nicely the single kidney globular filtration rate, which was increased, single kidney renal blood flow, which was increased nicely, urine proteins, which was decreased, and also the arterial pressure, of course. Enos activity, synthesis of nitric oxide increased dramatically, and a tubular injury reduced. All these nice things were done, and this is a slide from the study itself, published in one of the papers. There were 5 papers that were published from this study, and you can see the shock waves are influencing the arteries, the nephrons, and the kidney itself, and promoting the endothelial growth factors. And these are all tested and proved, angiopoietin and enos to increase, to promote angiogenesis, reduce inflammation, and what's most interesting is the homing of the stem cells to the stimulated tissue. And that all together comes to an improvement on renal function, a reduction in oxidative stress, and reduction in renal hypoxia. And these are the 5 studies, if you want to look on them. And these are the 5 studies that were out of this, preclinical trial. Now we went to Japan and we did a clinical study there. And you can see the same system that I showed you previously. This is how it's on a human subject. We aimed it to 4 locations on the kidney artery, and on the cortex, three spots on the cortex. And it was nice to see that also here you see the blood urea going down, the GFR slightly improving and definitely restoring through time, and a dramatic reduction in hypertension, in blood pressure. And now we are continuing, we are ongoing with a few studies worldwide, in the Philippines, in Israel, and we are opening new sites for a multi-site RCT study in Europe and the US. And there we are using a slightly different protocol, 8 spots to cover more parts of the kidney, 5 parts on the cortex, 5 spots on the cortex, 3 spots on the renal artery, and also 6 sessions twice a week, 300 shocks per location, adding it together to 2,400 shocks per kidney, 4,800 for both kidneys, and the results are quite nice because they are quite similar to what we got from Japan currently. We have, I will show you a meta-analysis in a moment. This was supposed to be a movie that's working, but you can see the setup and you can see nicely the kidney on the, and this is how the machine is working during the treatment. You position it using the ultrasound, diagnostic ultrasound, and you locate and you move, using the XY system, you move it from point to point. It's very nice, very easy to do. And the results, the meta-analysis of the results we currently have already from the studies that are ongoing are very promising because we got, for instance, for the systolic blood pressure, you can see a dramatic reduction. And this is very promising for us. There are other alternatives or other technologies, new technologies for treating hypertension. Renal denervation, you probably heard about it. And if you're talking about these two major companies in this cycle, which is Medtronic and Recor, then the difference between them and us is that we are not in non-invasive. We are treating also the kidney. We are aiming to postpone dialysis and treat kidney functionality and not only hypertension. We don't need sedation, we don't need hospitalization, and no radiation. Our respectable advisory board is Professor Amir Lerman, the cardiologist from Mayo Clinic, very known worldwide, and Lilach Lerman, which conducted also the preclinical studies. She's a nephrologist. This is our team. And I thank you very much for your listening, and I want to take advantage and proudly announce also that we put the first device in India, in Vadodara, in the clinic of Dr. Kamaldeep. And we hope for a future collaboration with the Indian Medical Society. Thank you very much.
Congratulations, Mr. Kainan. Definitely you have raised a wave of questions in audience, but due to lack of time, we'll take questions at end of the session.
Okay.
Thank you very much. So next topic would be addressed by Dr. Prasanna Shah from Mumbai, which is on endobariatric therapy for obesity current modalities.
Hello. At the outset, good afternoon, and congratulations to the wonderful team of Akash, Dr. Chawla and Anuradha Kapoor and all for organizing such an exquisite conference and getting all various specialities, under one board, and that's amazing. That's so a big round of applause to all of them. Wonderful, well done. Thank you. I'll be talking something on endobariatric procedures, EBT for obesity. Let me ask you, do you know this word endobariatric? I'm sure you'll have heard of it. Anybody, show of hands, you'll know what endobariatric is? Okay, so it's basically endoscopic management of obesity, and what is the current scenario. So we know what the definition of obesity is, and this is a typical patient or a person we see in India, medical condition in which excess body fat has accumulated to an extent it may have an adverse effect on health, leading to reduced life expectancies and other problems. This is the classic classification. I think you've been hammered by this throughout in the last 2 days. I don't want to go through this. But the other one, please understand, we have what we call as the Asian classification. So, and the WHO. Look at our Asian, it's much less than the WHO. So just keep a note of this. And therefore, all of you people who think that you all are overweight, you all have all turned obese grade 1. Okay? And those who thought were normal BMI have now become overweight. So, this is important classification for our Asian population. Everybody's heard the word pandemic, epidemic. So I call this as a pan-epidemic of our world, which is gripping us. It's a worldwide obesity has tripled since 1975, thanks to many, many factors, which I'm not going to go into. 1.9 billion adults are of 18 years and older were overweight, out of which 650 million were obese. 40% of adults aged 18 and over were overweight in 2016, 13% were obese. And the biggest worry is the children. 41 million children under the age of 5 are overweight or obese. We all know bariatric surgery, it's the best. Even I say it is the best. I'm not going to debate that. It gives us the best results. But is there anything else? Do we have an alternative apart from pharmacotherapy? Endobariatrics. Now, what happens with bariatric surgery? There is a morbidity, anastomotic leaks of around 1 to 4%. You can get obstruction in the gastric pouch up to 5%. You can develop marginal ulcers and bleeds from these marginal ulcers, which we get to see. Strictures we get to see over a period of time. What is the mortality? 30-day mortality anyway, you know, from 0.3 to 1.9. Now, because of better modalities of knowing anatomy, surgery, skill, all the complications of strictures and bleeds have become less, and so has mortality also become less. Initially, which started at 2% is 0.3%. But still, mind you, 0.3% mortality is still very high. We do not want mortality in any procedure. So, we come to endobariatric procedures, which are primary and secondary therapies. The primary therapies are balloon therapies, tissue apposition techniques, and nutrient diverting therapies, which I will not be discussing today. What are the primary therapies? Is the intragastric balloon, which is approved, tissue apposition techniques, which is called ESG, endoscopic suture or sleeve gastroplasty, and the nutrient diverting devices are the endobarrier. Basically, it's putting a plastic sheath from the pylorus, it goes all the way down into the jejunum, and we create an artificial bypass. Secondary therapies, and this is where actually sleeve gastroplasty came in, was transoral outlet reductions, or also called TOR, and revision in obesity surgery, which was done endoscopically. So intragastric balloons, what are the balloons which are available? The common ones which are available now in India are the Orbera balloon, the Spatz balloon, the reshaped duo balloon is not available, the Obalon balloon is not available, the ellipse balloon is now recently available in India and has been launched, and the transpyloric shuttle, which is not available. Now, let us look at the Orbera balloon. I think the video is not working. Anyway, most studies widely, it's not working. It's okay. Most studies and widely used balloon, it's a single spherical balloon which is made of silicon. It is placed endoscopically and removed endoscopically. We inflate around 400 to 700 cc of methylene blue. That's the saline with methylene blue. I've done more than 350 procedures, and 700 is a bit too much. 5 to 525 cc is well tolerated. It has undergone several changes. Otherwise, this balloon was initially called the Star Edward balloon, introduced way back in 1983, but had complications of perforation, had complications of migration, obstruction, and therefore it was removed. And now, after it has been redesigned, it is now available, and it has been approved. These patients averaged around 26% expected weight loss. Only 3 studies had adequate control groups, with the Orbera patients losing an average of 27% of more weight than control patients. RCTs are there. Expected weight loss in 12 months is around 25 to 26. Total body weight loss at 6 to 12 months is around 13% to 11% respectively. Now, the PV is a standard which has been set for endoscopic bariatric therapies, and the expected weight loss more than 25% at 12 months, EVL 1% higher than the control group, and the total body weight loss more than 5% at 12 months. What does all this jargon mean? This jargon means that this balloon which we introduce, we can expect 25% of weight loss. It goes down after 6 months around 11%, but it definitely works. And this is at 1 year. What is a reshaped duo balloon? The reshaped is basically you're introducing 2 balloons in the stomach. So you're just occupying space of the stomach, and therefore there is early satiety, decrease in eating, and your quantity of food goes down. So each balloon is filled with around 450 ml of saline. So totally you have 900 cc. It is removed endoscopically. This is not available in India. 24 weeks, the duo subjects had an average weight loss of 25.1% compared with 11.3% in the diet patient group. An average 66% of weight loss at the time of balloon removal was maintained at 6 weeks later. This is another balloon which is available, and it is called the SPATS balloon, and this is an adjustable balloon. The importance is this is placed endoscopically, and you see this. This is a catheter which is attached to the balloon, and this can be pulled out endoscopically. The only drawback of this balloon is that every 3 months, the advantage I would say, you can instill saline and remove saline. So after you place the balloon in the stomach, if they have a lot of nausea and vomiting, which most of the patients do, they can come back to you and you can aspirate 100 cc. Once they tolerate it, after 3 months, you can again put it back. The problem with this balloon is that there are repeated endoscopies which need to be done, and it is not just one endoscopy which we do with the Orbera balloon. So that is the disadvantage, I would say, of the SPATS balloon. 73 patients, 45% expected weight loss. Now we have the swallowable balloon, or the gastric balloon, or the ellipse balloon. The number of patients, it's a small little study. Weight loss 6%, expected weight loss at 25%. Now the beauty of this is you do not need endoscopy. It is done radiologically. We instill water in this balloon, and within 6 months the balloon disintegrates on its own and is passed off in the stool. The weight loss is around 25% at the end of 3 months. So the data is very small. The number of people are very small. So this needs some more validation, but it is available now in Mumbai. So same thing repeated. One thing which I wanted to say is a transpyloric shuttle. Basically the small balloon, a big balloon. This is a weighted balloon, and the concept is that it just causes partial intermittent obstruction, and therefore the patient cannot eat more or has nausea and does not eat. So this is an idea which has been put forward. They are doing some studies on it. Again, 25% at 3 months, 41% at 6 months. The disadvantage, because of the bobbing of the large balloon in the pylorus, they can find erosions and ulcers in the gastric antrum. And so therefore, it was not useful. This is the new thing, the endoscopic sleeve gastroplasty. This is an anchor exchange. This is a handle. This is a needle. You load the suture, and through the anchor exchange, you close the handle and you can take a bite. It is loaded onto a specialized endoscope. It is a double channel endoscope. The ESG falls under the umbrella of endoscopy, non-surgical procedure using an endoscope, a flexible tube with a light and camera attached to it. It basically reduces the size of the stomach, causing a sleeve. Now, This is the suture patterns we take, 1, 2, 3, 4, 5, 6, 7. So this is how you take the bites. You start from the incisura and you work upwards, and finally you create a small little pouch here. Look at F, and that is the thing. And this is what we do. This is one of my patients, BMI of 36. She had undergone the gastric balloon twice, but she still put back the weight on. She underwent ESG. 6 sutures were applied. Some people use 4, some people use 5. Because she had put the gastric balloon twice, her stomach was much more distended than a normal stomach, and therefore we had to use 6 sutures as compared to the conventional 5 sutures, and she's lost around 23 kilos at the end of 1 year. This is just data to tell you after 1 month, 3 months and 6 months. Look at the total body weight loss. It's around 8.4, 11.9 and 14.9. My only thing to tell you is that these results are continuous from the first year, second year and the third year. EBTs with their characteristics of minimally invasive nature, reversibility and high applicability are emerging as valuable alternatives for patients with doubts about bariatric surgery or ineligible for bariatric surgery. The safety, feasibility, repeatability and potential for reversibility of ESG has been shown by several multi-studies. Now, the slide is a little confusing, but I'll take you through this. We are basically comparing ESG with laparoscopic sleeve gastrectomy. Obviously, let me tell you at the outset, LSG obviously scores more, but what was interesting was that the outcomes is LSG achieved greater body mass index decrease and % total weight body loss. That we know. There were no significant differences in the percentage of total body weight loss between the 2 procedures in the subgroup patients of BMI less than 40 in multivariate adjustments. So whether you do an LSG or an ESG, your weight loss is practically going to be the same for the BMI less than 40. So 30 to 40 ESG, 25 to 30 should be a gastric balloon. This is how you should keep your patients. Above 40, yes, the choice would be bariatric surgery, but sometimes the patients are so ineligible to come on the table, you can use this as a bridge for taking the patients for surgery later, and that is the gastric balloon. Let me have a look. What are the adverse events? Adverse events were much less as compared to the LSG group. Case match retrospective study evaluated 6-month quality of life after operation between 23 pairs of ESG and LSG patients. The ESG cohort reportedly significantly showed better results in GI symptoms than LSG group. IGB was introduced 30 years ago. Fawad et al. Compared 2 EBTs, ESG and IGB, out of which 58 ESG and 47 IGB patients achieved meaningful body weight loss. The ESG group showed significant higher mean percentage of total body weight loss than the IGB group. That's all I want to tell you. And what about behavioral interventions? Cheskin et al. Conducted a case match study which showed 105 patients who underwent ESG and 281 patients who underwent high intensity diet and lifestyle therapy, and compared these 2 groups. And what are the groups? ESG group had a significant greater percentage total body weight loss than the high DLT group through a 12-month follow-up, 20 versus 14.3%, which is definitely significant. In conclusion, ladies and gentlemen, may I tell you that worldwide obesity has tripled since 1975. Bariatric surgery is to stay, will stay, but be careful of its morbidity and mortality. There is a new emerging branch of endobariatric which is coming around, and there are multiple modalities which we have now, and that is the gastric balloons which are FDA approved. ESG is showing promising results, and percentage of total body weight loss is superior to the gastric balloons. ESG is superior to diet and lifestyle changes in percentage of total body weight loss. Endobariatric procedures are safe, well tolerated, easily available and cost effective. Thank you.
Thank you, sir, for throwing very precise lights on this hot topic of today. I think we conclude the sessions due to paucity of time.
Thank you.
So thank you very much, all the esteemed speakers, for the wonderful sessions. Because of the paucity of the time, we are not taking the discussion at that time. And now I call upon a stage our first speaker, Dr. Pradeep Dalwadi, to receive a moment of appreciation. Dr. Pradeep Dalwadi, if he is here, please come on the stage. Okay, I think he is not here. So I invite Dr. Prasanna Shah to call upon a stage and to receive a moment of appreciation. Now I invite our esteemed faculty from Israel, Mr. Rotem Kainyan. Please come on the stage to receive a moment of appreciation. I also invite Dr. Vivek Vasanani to come on the stage to felicitate our chairpersons. Thank you very much, chairpersons. So now we have one session left after this, but before we go to session number 4, we have some very important announcement. And to announce this, I invite Dr. Jayant Panda, Professor and Head, Department of Medicine, SCB Medical College, Cuttack, Odisha. He is also the National President of Clinical Cardiodiabetic Society of India. He is also chairman of API Odisha State Branch, governing body member of National API. He is organizing secretary of RSS Day 2070, and he has many other credentials in his name. So I invite him to do this special announcement. Please welcome.
Thank you, Dishan. Actually, it's a pleasure being here at Vadodara with all your love and in this fantastic gathering. I'm the leader of CCDSI, which is a group working with the similar spirit, started from the land of enlightenment, land of knowledge, Gaya, and there are branches all over the country. You will be surprised to know with the concept that the Indian Diabetes Cardiometabolic Disease Association started in Vadodara, the place of banyan tree. Similarly, the same spirit, almost 5 years back, there was a movement started in the eastern part, that's Gaya, and we are much ahead in the sense we have branches in the Bihar, Jharkhand, branches in the Tamil Nadu, branches in Odisha, Bengal, Gurgaon, and Gujarat branch was on the way. We had a word with Dr. Akash, Dr. Chawla, Dr. Anuradha, who are all part of the movement. And because we are here, our past president, Dr. D.P. Khaitan is here, our national secretary, Dr. Mrityunjay Kumar Singh is here. So I invite the leaders of CCDSI and leaders of IDCM to formally announce the Gujarat chapter of CCDSI now. I invite Dr. Khaitan, Dr. Singh, Dr. Kamaldeep Chawla, Dr. Akash Singh here. I call Dr. Dishant Patel, Dr. Akash Singh and Dr. Anuradha Kapoor also to please join. You see, cardiodiabetes problems cannot be fought. Akash, please come. Cardiodiabetes problems cannot be fought alone. It requires a team. I understand there is a group working from the Banaras in the same spirit. Please come. So Ashutosh is here. So all team members. Shubhas? Yeah. It's a big fight. India, you must have seen on the World Population Day that India is going to surpass China. Similarly, as the heart attack capital of world, as the diabetic capital of the world, very soon will take over from other countries. You heard about the endobariatric surgery. In obesity, we rank third, and it's in no time we can surpass China and US and go to one. So may it be obesity, may it be diabetes, may it be all related complications. We have to get ready from now. So the similar-minded associations who have come up in the field of cardiodiabetology have to work together. So we are happy to collaborate with IDCM Vadodara, and I request Akash to say a few words before we formally announce the Gujarat chapter here before we break for lunch. Dr. Akash.
Thank you, Dr. Panda. Respected Dr. Khaitan sir. Dr. Muttanjay Singh ji. So basically, we formed IDCM a couple of years back, but after forming IDCM, after 3 to 4 months, I got a call from Khaitan sir that Clinical Cardiodiabetes Society of India, which is a very academic organization, I must say that majority of the noted academicians in cardiac and diabetes, especially non-interventional cardiology and diabetes, are associated with CCDSI. So we have been working jointly since last 2 years, and CME India, the group which has the maximum following of physicians and diabetologists, cardiologists, and is also a part of CCDSI. So this organization basically is one of the premier organization in academics in clinical cardiodiabetes and metabolic disorders, and has a following across globe. It is not confined to India, it is a following across globe. So there is a request that we should have a Gujarat chapter, and already we have 25 members in Gujarat, and that is why Dr. Panda sir, who is the president of CCDSI, wishes to announce the opening of Gujarat chapter. So I give the mic to Dr. Panda sir.
Will you say something? No. So we are joining hands, CCDSI and IDCM, to fight the menace of cardiodiabetes in India. So formally, I announce the launching of Gujarat chapter of CCDSI, and will be happy to collaborate with the locally born but functioning nationally and globally, the IDCM, and I'm sure both the associations so vibrant together, we can go much ahead, bringing good news for all of you to provide good health care and good future for all the patients.
Thank you, and this is officially a body now. But it's a request, sir, that with your able leadership, with Dr. Akash Singh as president, Dhiren sir as patron, and the team, the youngsters have to be on the front now, and they have to take the leadership, come forward, involve in the activities, and you have to see that they are invited on the national forum.
Sure, sure. Our past president, Dr. Khaitan, is here, the senior most physician, I think, in the gathering, and Dr. Singh is the dynamic secretary. Will take all care for the youngsters to come forward, take the baton, and fight against the menace. So formally, I request Dr. Singh to give a vote of thanks.
So the present body consists of Dr. Dhiren Patel, who is presently the president of Association Physician Gujarat. He will be the patron of this body. Dr. Kamaldeep Chawla would be the secretary of the body. Dr. Sushil Patel and Dr. Dishang Patel would be the joint secretaries, and Dr. Vivek Vaswani will be the treasurer, and I will be looking after the body as in the form of a chairperson. Thank you. So I thank Dr. Panda and Dr. Khaitan sir and Dr. Muttanjay ji for imposing this faith in me to carry the activities of the academic activities forward. Presently, we have a academic wing called as Indian College of Cardio, Diabetes and Metabolic Diseases, ICCMD. There are e-bulletins which are being published on regular basis in nephrology, cardiology and diabetes and metabolic disorders. There are regular CMEs being conducted alternate Sundays, annual conferences which is being conducted. This year's CCDSI conference is on 3rd and 4th November in Goa. Then there are the CME group, which most of you are member of, is being actively promoted by CCDSI. And majority of the faculties in majority of the national conferences are from CCDSI. So this is a brief about CCDSI. Thank you very much.
So give a big hand for this CCDSI IDCM collaboration. And with this, we are more stronger. We'll move forward. Thank you. Thank you all.
I just announced it. So now after this important announcement, I now again will start the session, and this is our last session in this hall, and after that we have a case discussion, very important case discussion. So I request all the delegates to remain seated, and that is going to be a very interesting case. But before that, we are going to complete our last session. So this is session 4, and for this session, I invite Dr. Sanjay Iyer, Dr. Viren Jetwa, and Dr. Neeraj Chawda to come on the stage and please chair the session.
Yeah, hopefully after such a wonderful announcement by Dr. Panda, I presume that he does not require any further introduction. Without wasting further time, I'll ask him to please request him to come to the stage and take the podium.
Thank you, sir. Thank you, chairpersons. Elite audience, I am overwhelmed in my stay and the interactions with the people around, and this is a very important conference of IDCM, which has successfully launched its first edition, and I wish that it will go further, fighting, publishing, spreading the knowledge across the world. My topic is very interesting. In next 10-12 minutes, I'll tell you very first about a very important aspect, the autonomic dysfunction in diabetes. All of you know about diabetic neuropathy, the peripheral neuropathy. But specifically from peripheral neuropathy, the autonomic dysfunction becomes so distressing to our patient, and that need to be kept in mind, detected in time and intervene, that many people forget, and it become a very uncontrolled problem in our patients of diabetes. So let us see that the autonomic dysfunctions, how we'll go around and how we'll control these problems. The cardiovascular, GI and genitourinary autonomic neuropathies are mostly I'll be touching upon, and you know the autonomic nervous system, also called visceral, vegetative or involuntary nervous system, is distributed throughout, and the nerves, the ganglia, the plexuses that innervates heart, blood vessel, glands and other visceral organs, and the smooth muscles are constituted. You read this long back in your first MBBS, the parasympathetic and sympathetic innervations of the autonomic nervous system, and most important, the end of postganglionic sympathetic synapse, the adrenergic receptors mediating the effect. The diabetic neuropathy, as we know, is a heterogeneous disorder. The proximal and distal peripheral sensory motor knobs are affected, so also autonomic neuropathy. And the diabetic autonomic neuropathy is a widespread disorder where the cholinergic, the adrenergic, and the peptidergic autonomic fibers in context of diabetes are affected. The diabetic autonomic neuropathy occurs as a system-wide disorder affecting all parts and manifests first in the longer knobs, characterized by the subclinical form that's detectable only by tests, and clinical form in the presence of signs and symptoms. We have to remember that it's a diagnosis of exclusion. Many of the time we don't have a clear approach to establish the diagnosis. So this complicated slide just shows the hyperglycemia leading to shame, oxidative stress, advanced glycation and end products, protein kinase C, the polyol pathway flocks leading to the knob dysfunction and subsequent complications. So poor glycemic control is the single most important risk factor. The long duration of diabetes, the increasing age, the female sex, higher body mass index, and smoking and elevated triglycerides are other factors leading to the diabetic autonomic neuropathy. And you can see, starting from pupillary affection, that's decreased diameter of the dark adapted pupil, the Argyll-Robertson pupil, the hypoglycemia unawareness, hypoglycemia unresponsiveness, tachycardia, exercise intolerance, cardiac denervations, orthostatic hypotension, heat intolerance, neurovascular problems like areas of symmetrical anhidrosis, the gustatory sweating, hyperhidrosis, alteration in skin blood flow, constipation, gastroparesis, diabetic quorum, the diarrhea and the fecal incontinence, esophageal dysfunction, the erectile dysfunction, the retrograde ejaculation, cystopathy, neurogenic bladder, and defective vaginal lubrication. All of you have come across these presentations in your patients. Many times we think of a functional symptom, many times we forget to intervene them, but they can be done or diabetic autonomic neuropathy. So from today, when you listen this, please work out, exclude other causes, and diagnose as diabetic autonomic neuropathy, which is the first step in approaching the patient. Quickly, I'll be covering cardiac, GI, and genitourinary before we end the program. The cardiac autonomic neuropathy is defined as impairment of autonomic control of the cardiovascular system, where degree of glycemic control, disease duration, as related problems they affect, and always the hyperglycemia leads to the cascade of advanced glycation and products resulting it. The impaired heart rate variability is one of the first presentation where there occurs 1.6% impairment in less than 5 years, 6.2% in 5 to 9 years, and 12% in more than 9 years. So you can realize along with the duration how the deterioration of the heart rate variability can progress or deteriorate. If more than 100 beats per minute is the heart rate in the rest, it's taken as the resting tachycardia. So heart rate that's not responding to the mild exercise. It may happen otherwise. The person is doing exercise and heart rate is not going up, indicates nearly complete cardiac denervation. And they have the result of autonomic neuropathy, ultimately leading in the silent myocardial infarction and the death. The exercise intolerance is a presentation which is reduced by the reduced ejection fraction, systolic dysfunction, and decreased diastolic feeling. The prolonged corrected QT interval, the sensitive, non-invasive, and simple predictor of the cardiac dysautonomia many times is missed, though we see in the ECG, don't correlate it with the autonomic dysfunctions. The abnormal circadian pattern of the blood pressure, that blood pressure rising at night, you know there is a nocturnal dip. Instead of nocturnal dip, it rises in the night and falls early in the morning, correlating with the postural hypotension is a very important presentation. All of us from our undergraduate days detect postural hypotension, but in diabetic patient we forget to record the BP. So the first diagnosis of pre-diabetes and diabetes can result in autonomic neuropathy. So A1C, the fasting blood glucose, the postprandial blood glucose, you have to, if you, other way around, if you see any of this autonomic neuropathy, you do a diagnostic test, and if it's not known, patient may come out as diabetes, and it may be the first encounter. So at the diagnosis of type 2 and 5 years after the diagnosis of type 1, you must test for the cardiac autonomic neuropathy by deep breathing, by standing, by Valsalva, and blood pressure response to standing and isometric exercises. And these are the long list which shows the heart rate response to deep breathing, to standing, to Valsalva, and you can do it, especially the orthostatic, the systolic BP more than 20 and the diastolic BP more than 10. If comes down, we have a response to the autonomic neuropathy, and this is a sophisticated lab which shows how you can do autonomic testing, but first is the clinical suspicion or the method of exclusion. If you have done that, you'll refer the patient for the complete workup. So the early stage, it's just heart rate response. Intermediate stage, it comes as abnormality of Valsalva. Severe stage, it's a postural hypotension. And the risk of the test, that during tests also there is transient increase in intracranial, intrathoracic and intraabdominal pressures, and the intraocular hemorrhage and the lens dislocation is a risk. So the high value to risk ratio, and you have to correlate with the different presentations. So you can advise the power spectral analysis, the MIBG SPECT or the 11C hydroxyephedrine scintigraphy, which can further tell you about the problem. I'm not going to the details of the treatment in view of the paucity of the time. You know the blood glucose control is important, and the rest of the management is symptomatic. General managers, the symptomatic medicines and the specific drugs like midodrine, the fludrocortisone, the octreotide, and beta blockers, the clonidine and desmopressin are advocated in orthostatic hypotension. Quickly covering the genitourinary autonomic neuropathy, there is a sensory and secretory function modulated by the interactions. The evaluation of the GI autonomic function is difficult in the humans, and usually it is done by diagnosis of exclusion. How common are these presentations? Nausea, bloating, abdominal pain, diarrhea, constipation, delayed gastric emptying, and they are very commonly associated, and you'll be surprised to know that we miss them without suspecting autonomic dysfunction. So lot of tests are there, but it's very difficult to do. But clinical presentation of bloating, the early satiety and postprandial fullness should prompt you, and you should proceed to take the history approach in the mild, moderate and severe cases and diagnose the patient. Constipation is one of the most common presentation affecting 60% of diabetic patients, and bouts of constipation may alternate with the episodes of diarrhea. In a diabetes which is minimum 5 years onwards, you think that it can be the single most presentation of the autonomic neuropathy affecting GI tract. So the altered motility, increased secretion, the bacterial overgrowth, the anorectal dysfunction, the exocrine pancreatic insufficiency, the dietetic food sorbitol, the concurrent disease, bile acid malabsorption, all can present, and you have to do a level of investigation, first line, second line, third line, and the treatment is usually symptomatic with loperamide, clonidine, and the octreotide, and the blood glucose control is the mainstay. Quickly, I'll take 1 minute to finish the genitourinary autonomic neuropathy. The neurogenic bladder, the erectile dysfunction, the female sexual dysfunction is very common, and you have to see the bladder habits, take the history. Erectile dysfunction you should not forget, and retrograde ejaculation is an important thing. The bladder and the erectile dysfunction, detailing you can work, and other types include the metabolic problems like hypoglycemia, unawareness, which can be fatal and result in the death of the patient. The pseudomotor problems like peripheral dry skin and paradoxical excess sweating in trunk, the gustatory sweating, the peripheral vasomotor changes, the texture of the skin is changed, loss of nail, the anhydrosis, the callus formation, and the development of the fissures and the cracks, which precipitates the diabetic foot, peripheral edema and the venous prominences, loss of sympathetic vascular innervations, and abnormal local reflex, the vascular control increase, osteoclastic activity, and then Charcot's neuroarthropathy may be complicated with diabetic autonomic neuropathy. Pupillary involvement I have already told, and the conclusion, I'll just show you a table that this is GI, the cardiac, the sexual dysfunction, the bladder dysfunction, the pseudomotor, pupillomotor are the long list. Just if you keep these in your mind, that in a diabetic, type 2 of 5 years duration, these are all possible diabetic autonomic neuropathy for which will control the blood glucose and see that the patient recovers from these potential dangers, then our presentation of this topic will be done. So diabetic autonomic neuropathy is a system-wide disorder affecting all parts of the autonomic nervous system. It's usually a diagnosis of exclusion. It can affect various systems, mainly the cardiovascular, gastrointestinal, and genitourinary, and the heart rate variation tests are sensitive detectors of diabetic autonomic neuropathy. Again, I thank the IDCM team for the invitation and congratulate them for a very successful conference, and wish together we can go much ahead, giving better life to our patients. Thank you. Thank you all.
Thank you very much, sir, for a very quick and to-the-point talk on a very vast and exhaustive topic. Thank you very much, sir. For the next talk, I invite Dr. Subhash Kumar from Patna for his talk on motivational interviewing and behavioral modifications in cardiodiabetes practice.
Good afternoon, delegates, respected chairpersons. My sincere regards from the city of Patliputra. My talk is on motivational interview and behavior modification. It is completely a clinical topic which is useful for our practice, and it doesn't involve any molecules, so you just relax and enjoy the talk which I am going to give you, but the time is very less for me, but then I'll be trying to do justice to this topic. Normally, every guideline suggests that we have to do lifestyle modification, either be it is a diabetes treatment or be a hypertension or any other cardiovascular illness. We talk that we should do lifestyle modification first. We should try it for 3 months and so on. But none of our patients listen to us. And these includes not only the dietary intervention, physical activity, but also it has a content of behavior modification, because you think that whatever you advise your patient is going to listen to you. No, you have to understand their need first, that at what level of mind slot they are. For that, we have to understand what is a behavior modification in a person do. Normally, when they don't listen to us, we jump on to some conclusion that patient is not understanding or not taking the thing seriously. And whatever we explain, people think that, okay, you have to do this, and then they don't come to us with the result which we want, because they are not ready to listen to us. And what I'm going to talk is how to make them understand their problem and how we can go about doing a consultation so that they can be more responsible to whatever we want to their lifestyle. Normally, we try to instill fear, which doesn't work. You ask the patient, भाई इंसुलिन नहीं लीजिएगा तो आपका किडनी में प्रॉब्लम आएगा, आपका हार्ट प्रॉब्लम आएगा, आपको स्टैटिन चाहिए, आपको ये चाहिए, and they are not going to listen. And where we'll end up in this condition. We try to push hard with whatever advice we want, and we think that he should be doing. And why this happened most of the time? Because we have been traditionally treating patient in a different mode of way, different mode. Normally, we act as a masters and we want the patient to listen to our order. This doesn't happen in in the modern medicine, because now things have changed. People are more aware, and we have to come to a level where both of us are in the same level. We are the expert of medicine or the treatment, but the patients are expert of the disease. So we both have a same level, and we have to understand, and we just can't give order. We have to talk to them and find whether you have to take, you have to just listen to his prospect also. So for that, there have been different models how to go about consultation and how to understand patient need. For that, there are two things. One way is to understand their need first, and at what stage of mindset they are. And this is described very well by James Prochaska and his team, which is known as TTM model, that is Trans-Theoretical Model of Behavior Modification. This has been tried worldwide. He is a very noble scientist and has worked a lot, and this model has been accepted worldwide because this has taken in consideration for different behaviors like smoking, alcoholism, obesity, diet changes, and all other things where we want to change their lifestyle. And this model works. I'll just teach you how this model is. And we have to learn to find out there are different stages of a patient mind. And these are 6 stages, and there are some 10 processes. I can't give all the detail about the processes, but at least we must understand what are the different 6 stages the patient come to us, and how we have to deal with them. So these are the different stages and processes. And if you look at the 6 stages first, it starts with pre-contemplation, contemplation, preparation, action, maintenance, and relapse. So no change can happen in one night or one day. One has to go through these 6 different stages starting from stage 1 to stage 6. And you think we start jumping to the final stage of the consultation, which will not happen. We need to identify that those people who come to us, the patient come to us, they are at what stage, and we have to give them advice accordingly. Normally 40% of the people, when they come, they will be in the stage of pre-contemplation, and 40% in contemplation, and rest on. So we just cannot, what we do is we just go finally and do our consultation. And what happens in stage 1, this is the stage where patient is in the mode of denial. First time we'll say, आपका sugar बढ़ गया, आपको diabetes है, आपको hypertension है, आपको heart का problem है, you have kidney disease. Patient will be in the mode of denial. And whatever thing we are going to do is, we are going to tell, they are not going to listen to our advice. They are not thinking of changing anything because they are happy user of their whatever habit of getting up very late, not doing exercise, eating too much according to whatever they wish, because they have learned that helplessness and their behavior has been adopted for several years. Now we ask to reduce the portion size of meal. See, whatever therapy we do, it will not work because until we teach them how to live their life and how to do their day-to-day activity. But at this stage, they will not listen to you. You ask them to join a gym or do a morning walk or go or consult a dietitian, they will never listen to us. So here we need to raise the consciousness. So this is the first stage when most of the patient will be coming, and we have to understand how to deal with them. In the stage 2, if they are next, if you help them, they will jump to stage 2. In this stage of contemplation, the person is at least started thinking that, okay, I have to do something. But still, he has a lot of ambivalence in mind. He'll be in a state that, okay, I should do, but it's very difficult for me to get up morning. It's difficult to leave my bada pav. It's difficult to do the lifestyle which doctor is telling. And he have a lot of things, confusion in his mind. Then you have to help him to move further and tell him, taking his perspective, that what do you want and how you think. He will say, but my knee is paining. So, okay, come on, then you should lose weight. And that's the way you have to go on. So in this stage, patient will be thinking of changing, but there will be chronic contemplators. They will be thinking for last 2-3 years, and they'll have a lot of decisional balance, and they have fixed up their mind. It is the time for us to help them and come out with some solution. And if we push them, we give them some choices, at least 2 or 3 choices, then they can come up with some solution, and they can move to the next stage called preparation. Here the person is now seriously thinking of changing his behavior, And typically it is seen that it is 30 days that they will take time to come to this, to this stage, and they will start thinking seriously and doing some changes like buying shoe for the morning walk, or thinking of joining some gym or some diet consultation, or maybe they are coming to us and thinking, doctor, I want to do, like, just give me some clue that how should I go about it. And this stage of preparation, they would have made decision as they have formed plans, and they will be starting, at least they are going to near park, and they stand and they think that people are walking. So and this is the stage of preparation. Now it is the time when we consult them to go to some expert or some dietitian, or maybe come to us, and then we can help them accordingly. And in the next stage, that is stage 4, when they will be in the action and they will be starting doing some exercise, and at least they are showing some action in their life. Now next stage, they will come as a stage of maintenance according to James Prochaska, and they are doing it very happily, and they are comfortable at least, but they have chance of going back to the old behavior. So but they have learned how to sustain these things, and there is no issue for them to continue with this. And then later on, they have also started, this is another stage where, stage of termination, when they have, people are sure that they will not return to the old behavior, and they have 100% efficiency at this stage. So these are the different 6 stages. Later on, the relapse was also added, where the patient goes back. So when we understand that patient's behavior cannot be changed in one day, our advice should also be accordingly. And there are chances that they can go back to the old behavior, and they can also have, they can further move forward. Our duty is to help them, and for that we have to have a motivational interview, and we have to understand different processes. So I'll because of the paucity of time, I may not be able to talk, but these are conscious raising, dramatic relief, environmental re-evolution, decisional balance, self-efficacy, and so on. Out of that, the very important issue is of motivational interview. This is the second very important thing which we have to understand, because it is a client-centered, collaborative, goal-oriented, non-judgmental style of communication. Our communication, and first time when they come to us, is very important, how they perceive about us. So, yeah, just 2 minutes. So any evidence-based medicine will not be useful unless until the patient, we don't understand their need, and we have to have remove their ambivalence in mind. So whenever there is a smoke, or patient is not following your advice, then you have to stop. How to recognize a smoke when patient has negative comments about the treatment, or hesitation to follow your advice? So in that case, don't try to pursue them, because they will be wrestling with us. If for wrestling, 2 people are required. If you stop wrestling, then they will also stop. And then you go back and start consultation. Always avoid rightening reflex. We have immediately to jump, okay, this is wrong. You should not eat like this. You should not do like that. You are skipping your medicine. You are not continuing this. So this is the rightening reflex which come very easily. And how to avoid that, and what is the next step? Next step is showing empathy. Empathy is not like sympathy. It is something that you put in the patient's shoe and think what they are going through, what they feel once they have diabetes, or they have any issue, or they have neuropathy, or whatever. And then you talk to them that, okay, I understand what is the condition you are going through, and you have to give, dropping with affirmation is that you give them time to talk to you and understand what is it going on. And unless until you show them empathy and affirmation, they will not be in your mindset and the way you want to change their life. So you have to give them personal choice, what they want, and depending on his way of autonomy, you can move forward. And the best way is to ask a strategy where what you do, you ask the patient first, kya aap chahte hain ki I can tell you something which can help you? I know what you are going through, and I really feel bad, like you have anyone will have in that condition. So you can go with this ask technology and listen to them first. Unless until you listen, they will not comply your advice. So stop wrestling to them whenever they are not ready, and drop back and express empathy with affirmation. Role by supporting autonomy, that okay, your things I understand, then now how I can help you. And if at all they are not happy, then you have to apologize at time. So you should not do what thing is, don't try to convince them or persuade them or give them advice which is not take in, ignore patient perspective and you just tell you have to do this, you have to do this, and get stuck, and then they will not listen to you. I think we all understand these, but it was never emphasized. And most of the senior physicians will do the same thing what I'm going to talk, but it should come in a structured way, and this is the part of curriculum in US, UK medical schools, and they teach how this trans-theoretical model works, and we have to learn a lot when we come to motivational interview, and how do we take patient to comply to the lifestyle modification and do whatever good for them. Thank you.
Thank you very much, sir, for enlightening a topic which has not been learned in the medical schools. It is a psychology which is to be changed when we want to change the lifestyle and habits of the patient. Thank you very much, sir.
Thank you, sir. Now, before we proceed further, we have an announcement. So I welcome Dr. Dhiren Patel, Dr. Yogesh Desai, Dr. Ketan Joshi, and Dr. Akash Singh.
Hello, hello. Thank you very much. Friends, I'm between you and the conference for some specific reason. First of all, I congratulate IDCM President and Secretary, Dr. Akash Singh and Dr. Chawla, for undertaking an excellent conference which will be cherished and remembered forever. Big hand for them. Myself, Dr. Yogesh Kumar Desai from Surat, and here is with me Dr. Dhiren Patel. He is APG API President. Currently, Dr. Ketan Joshi is Secretary of APG. So, APG now is a API chapter, Gujarat State. You know it very well. We have made alignment in 2019. And you also know that we had conducted and hosted from Surat an excellent 42 APG Con. So this time, we are hosting 43rd APG Con. It's a history in its part that Association of Physicians of Gujarat is known for doing great things as far as the scientific feast, entertainment, enjoyment, recreation, diversion, and meeting our old friends. So dear friends, please come together with your friends. Register yourself at the earliest, and the conference is held on 30th and the 31st July this month at Courtyard by Marriott, Ramdev Nagar Crossroad, Ahmedabad. Please contact Dr. Bhagirath Solanki, Dr. Anil Kumar Kulsreshta, he is the chairman, and Dr. Bhagirath Solanki is organizing secretary, and Dr. Jitendra Anand. Please come in large number, convince your friends, motivate your friends, and do the needful to enjoy and flirt everywhere. Thank you.
And for this conference, those students wants to submit that abstraction, like for paper presentation or poster presentation, they can submit as early as possible. And once again, I thank you and congratulate Dr. Akash Singh as a president for IDs and Dr. Kamaldeep Chawla and the whole organizing team for wonderful arrangement. Thank you very much.
Thank you, sir.
Okay, sir. All the best.
Thank you both the speakers for the wonderful session. Now I invite Dr. Jayant Panda sir to please come on the stage to receive a moment of appreciation. And I request chairpersons to please felicitate our speakers. Now I invite Dr. Subhas Kumar to please come on the stage and receive a moment of appreciation. Finally, I invite Dr. Aswin Bhatt sir to please come on the stage to felicitate our esteemed chairpersons. Thank you very much, sir. With this, now we are moving ahead towards the last session, that is the case-based discussion. This is a very special session where we have the totally blind case, which is prepared by Dr. Anand Ahuja, and we will have the interesting panel discussions from the various super specialties. To chair this session, I invite Dr. Prakash Bagade to come on the stage and start the session.
Hello. Good afternoon, everyone. As we proceed towards the end of this mega event, we will be having a case discussion based on cardiometabolic syndrome. In our panel today, I would like to invite Dr. Kaushik Trivedi, Dr. Vishwa, Dr. Kamaldeep, Dr. Abhijit, and Dr. Parag. And now I call upon Dr. Anand to start the discussion.
Good afternoon, everyone. Although it is a fag end of a wonderful symposium, but I just hope that this case is lively enough to. No, don't want to do it. Slide. Okay. So we just hope that the case is interesting enough to keep us motivated to stay in this hall, so that the food can wait a little longer. It's an interesting case. I'm just going to present it as a houseman or a first-year resident. And it's a linear case like we see in our day-to-day practice. So it's not a snapshot. It's a linear progression over the years, how a physician or how any specialist would see, and how do you address this case. Let me tell you that this is not a perfect case, or this is not the best way to treat by any means. There are certain things which are done right, certain things which could be done better or differently, for which we have all the experts to comment upon. So I'll be just presenting as a registrar or a general practitioners, and these are all prima facie facts or details. This is a real case scenario which I've been encountering and facing. If you ask for, so the experts, I request you, if you wish for any more information, you can ask and I will share. All inquisitive questions are welcome, either from my side or from the audience. We can ask questions to the experts, you know, how different certain situation can be managed. I'll ask individual, referral to specialists, because this case involves multiple systems. It involves endocrinology, it involves nephrology, it involves a general physician to, provide his inputs. So we'll, go to them for specific inputs, and we will all collectively contribute. So I would request if everyone who's sitting in the back, if would like to come forward and have a active participation. You're all free to raise your hand and put your inputs. This is not a passive lecture by any means. I'll request the experts, wherever there is a need, you might just share any evidences or share some expert opinion or your experiences in similar case also. So basically together it's an active participation from every one of us. So the case starts in 2009. This is a 24-year female. She approached the physician with complaints of paroxysmal palpitations since last 1 month, and she used to have palpitations almost every day. Usually they were more around the late afternoon or evening hours, 4, 5, and around midnight after 2, 3 hours of going to sleep. Associated with the palpitation, she also had complaints of some cold extremities and excessive sweating. She had some weakness and lassitude, and she had a recent loss. Her father died just 3 months ago. So with this basic background history, this person, this young girl, goes to the physician, and this is what she complains. Now, sir, we'll have active inputs from everyone, sir. You also. So, yeah. We can start dissecting, commenting at any point of time. I don't have a formal presentation to make.
First thing that goes in my mind is a young person coming with paroxysmal palpitation. I'll generally think in terms of paroxysmal supraventricular tachycardia. Because she has some recent loss of father as an emotional issue, it might be one of the precipitating factors. And most of the supraventricular tachycardias of some kind are associated with coldness, extremities, sweating, weakness. I would normally insist on taking a record of what kind of palpitations she generally describes. I would be very interested in knowing how the heart thumps under her chest, how she is able to tap on the table or tap on something, so that I know about the rhythm, how fast it is, how irregular it is, and that will give me some idea about what kind of supraventricular tachycardia it might be dealing. It could be sinus tachycardia because of anxiety, but I would keep that later in the list because of some kind of autonomic symptoms.
Sir, that information you can ask me, I will provide you. I have purposefully withheld certain information.
Let us put our differentials.
Yeah, perfect. So if you want to have more details about the palpitation, I will provide, sir.
Does she get up from sleep? And does she get up from sleep 12 o'clock midnight because of the palpitations?
Yeah, she gets up from sleep because of palpitation. It is very disturbing.
Okay, so given these points, I would first like to rule out anemia, maybe because of emotional outburst, she's not eating properly, nutritionally deprived. Secondly, I would like to rule out a thyroid disease because of female 24 years, paroxysmal cold extremities, excessive sweating, weakness, lassitude. Maybe because of this emotional trauma, maybe she's a known thyroid and not taking her medications. Maybe she forgets to take them. Third, I would think as a cardiologist about Takotsubo cardiomyopathy because stress-induced reversible cardiomyopathy. And lastly, an emotional, organic cause or something.
So would you want any more information from me?
No, I think I'll give differential at this point of time.
Just remember, just one point, she's having everyday palpitations.
And the timing is 4 p.m. and midnight. So timing would give us
Yeah,
the
this are usual.
Can I have the BMI, height and weight of the patient?
Yes. So I'll provide. That's her. Her body mass index is 33. She is obese. Her vitals, heart rate is 90, blood pressure is 130 over 90. Systemic examination, everything else is normal.
Yes, so there is something is going on, something after meals, right? 4 p.m. and midnight.
Yeah. Her palpitations usually last for around 15 or 20 minutes. They are slow onset and slow offset, associated with some weakness and some cold extremities. There is no complaint of any chest pain, breathlessness, any other cardiovascular symptom, no loss of consciousness, no syncope.
So the exertion increases this palpitation or it does not?
She has an overall sedentary lifestyle. She doesn't exert enough, so she does not give any specific details about exertional syncope.
Okay, so there is no exertional component involved. Okay.
We don't know.
You don't know?
The patient doesn't exert enough. She is having a sedentary lifestyle, so she doesn't have any exertion to complain of exertional.
Okay, so as far as the DDs are concerned, Dr. Kamaldeep has narrated everything, but this is in 2009, so 13 years are still remaining. So we would like to know what's the progress of this patient.
No, but you have to intervene, you have to do something at this point.
Does she have any history of sugars being measured at any point of time in her life? Does she give an history? Somebody has measured her sugars at the time of palpitation?
So you ask whatever information, what investigation, so I'll provide you with that.
Okay. So
provide all complete general,
whatever investigations we have done.
She is a poor patient, so you have to judiciously order investigations.
So first
and you have to justify why you want a certain investigation.
This houseman is very naughty, let me tell you. Now, first of all, general examination.
Systemic examination, general
It's
examination.
absolutely normal. Systemic examination, absolutely normal.
Is normal.
Okay, so
Except for obesity, there is no nothing remarkable in this patient.
Okay, so now can you please let us know the basic investigations?
Okay.
Basic.
So, resource limited. So, whichever investigation you want, you will have to justify. Don't say everything LFT, RFT,
So
thyroid,
we
whatever.
first ask for complete
Okay,
blood.
I'll provide a few. So, CBC is normal.
Sugars?
TSH is normal. ECG
Sugars?
is normal. I'm telling you, sir. I'm providing. So, with this, this is a real case scenario. This is what exactly had happened. The physician these were the only tests which were done in this particular case. And she was given bisoprolol and
sorry to
anxiolytics.
interrupt. The sir's question is very valid. You cannot treat this patient without checking her sugars.
I agree, so that is what you have to say. This was actually done. This is a real life scenario. What was done was, so you should say that at this point you would want to see sugar. And why do you want to see sugar, sir?
The palpitation is going on post-meal, right? So probable some sort of hypoglycemic event you need to rule out in this patient.
Exactly.
Okay, and she was in stress. So as sir narrated that she might not be taking proper nutrition, so hypoglycemia prone. Or some other, if you are further discussing the history, we can find some other endocrinologist cause, but at least we should need the
Her diet and appetite was normal. She's actually obese. In fact, she has some stress overeating problem. She was given anxiolytics, escitalopram and clonazepam along with bisoprolol. So this was the treatment given. This is a real case which actually happened. Now she
Why
was called up-
bisoprolol?
Yes.
Why bisoprolol?
For palpitations.
But BP is normal and everything.
It is normal. But her pulse rate was high. She had
And
tachycardia.
escitalopram and clonazepam, or it was a combination?
Combination was.
It was not available in 2009. Combination came later on.
No, I don't remember the combination, but she was given anxiolytics. along
Because
with
you
bisoprolol.
made the case.
Okay. No, this is not a made-up case. It's a real case.
Please go
I tell
one
you.
slide back.
What?
Please go one slide back.
What do you want to see?
The pulse rate was 90.
On admission, but she was.
So do we have
she had
any
reported palpitation.
during episode ECG?
Yeah,
or
yeah.
any-
No episode, but she reported to have palpitation and fast heart rate. She was given a low dose bisoprolol along with this. Considering that, yeah. So this is what had happened at the primary care level. Now then she reported with the same doctor again after 1 month. There was no significant change in her symptoms. She remained almost the same. Palpitation slightly reduced perhaps because of bisoprolol. Her fatigue and cold extremities, that symptom, weakness had actually worsened. Now there was a new complaint of fine tremors also, which she had not noticed before, but now she notices. And on investigations, thyroid function tests were also done, chest X-ray was done, that was normal. Sugar was done at this time now, SGPT and creatinine, thinking about hypoglycemia, but again it was normal. And she was given multivitamins, vitamin B12 and vitamin D3 supplements.
So even in second visit, there was no ECG done?
What?
ECG?
ECG was normal, sir. I forgot to mention. It was normal.
I think it was not there in first visit as well. Here it is not mentioned.
ECG is normal.
ECG is normal?
ECG is normal. Yeah, we don't have an ECG during the episode of palpitation, but ECG at the time of presentation to the doctor is normal. Sinus rhythm and the rate was also okay. And her palpitations improved actually.
These vitamins were started without knowing the levels? Or?
Yes, without knowing the levels, this was given empirically. No. She did not have any Raynaud's phenomenon. Her palpitation improved perhaps because of bisoprolol or perhaps because of anxiolytics, but her other symptoms actually increased. So what do you think made her to worsen? What happened?
Beta blockers can be worsened.
So perhaps it is beta, although it is a cardioselective beta blocker, but it's not absolute. So that's one possibility.
I want an echo at this time.
What?
Echo. Echocardiogram.
At this time. For what?
Let's see what's going
on. No, but what do you want to see?
Mitral valve prolapse is there, not there, what is there?
Mitral valve prolapse? Young female, quite possible. Yeah?
So metanephrine levels, urine metanephrine levels.
Urine metanephrines?
Yeah.
For what?
For, she's basically having catecholamine associated symptoms. So I want to know whether she's having FEO or something like that.
If you consider
to
pheochromocytoma or paragangliomas, the usual presentation is flushing, palpitation, headache, and episodic tachycardia and hypertension. There is no such hypertension or anything noted in this person.
We want if you have done.
Yeah. No, it was not done. It was not done. And she's obese. Usually such people are underweight or cachectic. So echo was done, sir, and it was normal. So there is no evidence of any mitral valve prolapse. Treadmill test was done. It was negative, but there was an abrupt chronotropy noted. Like the resting heart rate from 90 immediately jumps to 130, 140 on stage 1 of the treadmill test, Bruce protocol. Holter was done now, and that showed some occasional few episodes of inappropriate sinus tachycardia, not proportionate to the level of physical activity. She didn't have any fever or any other reason to justify her sinus tachycardia. Apart from that, no episodes of NSVT, VTs, atrial fibrillation, atrial tachycardia, or anything else. This was, and random blood sugar at this time was 186. She did have episodes of palpitation at that time. When Holter recorded sinus tachycardia, she did have palpitations. That is what we conclude. Yes.
At this time, I think
yes.
we can assume that whatever we are saying as inappropriate sinus anxiety may be genuinely ectopic tachycardia. Because the P wave looks like sinus, it may not be genuinely sinus.
Yeah, it could be.
Any significant drug history for her? Is she on some medicines
she was
prior?
Not,
is she a
she wasn't on
healthcare
any
worker?
other prior, any Ayush medication or anything
Nothing
else.
like that.
No. And this is her fasting and postprandial blood
This
sugar.
random sugar was anywhere related to exercise, or why this random sugar? When it was done? 186.
That was a random sugar because it was 186. So fasting and post-meal sugar was done, which was not.
So that was on the, again, OPD presentation, not during exercise or something like that.
Anand, at any point of time while she was symptomatic, sugar was monitored?
No, at the point of palpitation, we don't have a sugar report at that time. So this is her office readings. When she presents to your OPD, that is the time.
And if she has no this kind of, I would generally ask for PG2BS, not PP2BS, because we don't know whether she is diabetic or not. So because that would give us fair idea of the insulin.
So maybe an endocrinologist would want a maybe oral glucose tolerance test, so to say, perhaps. So we don't have a ECG at the time of palpitation, so the doctor advised a Holter which showed episodes of sinus tachycardia. So that is what we have. And her HbA1c is 5.4%. Yes? Chest X-ray is normal. Chest X-ray is normal.
What was her MCV in the first CBC?
MCV is normal, sir. The CBC entirely is normal, including
And cortisol
MCV,
level,
MCH, MCHC, RDW is all normal.
whether they have gone for a cortisol level?
No, cortisol level was not done in this case. But why would you want a cortisol level?
If she was on any steroids for any purpose and it was abrupt withdrawal.
She denies any history of steroid intake, and she doesn't have any features of, except obesity, she doesn't have any Cushingoid features, so to say.
So this abrupt
and if you're thinking of Addison's to explain her hypo or anything, then that is not.
Abrupt chronotropy could be because of sedentary lifestyle and obesity, both of
It could be physical deconditioning also leads to abrupt chronotropic response, so we may not, dig more into that. But that was a finding. No. She is not taking any medical supplement, either modern medicine or Ayush medicine. Nothing.
Anand, any evidence of, I am sure, we would not think it, but last signal average ECG or something of that sort for autonomic.
It wasn't done. It wasn't done at this time. No, it used to. Yes? What gynec history do you want? Menstrual periods were normal. She was unmarried and G0, P0, A0, and menstrual history was regular. She did not have oligomenorrhea. If you suspect, what are you suspecting otherwise? Why do you want to know menstrual history? Because of? I didn't get the reason. Yeah, but how do you correlate that? There is no correlation between her palpitation and her menstrual history. It happens any time of the month. No, sir. No, sir. That she is denied.
No.
Yes? No, she was not having adequate sleep. She was slightly mentally disturbed because she lost her father some time back. And because, the doctor thought that perhaps this could be anxiety related, so she was given anxiolytics. But after that, she was fairly okay.
So before 2009, there was no medical surgery.
There is no
right?
prior medical history.
Just to
before
confirm
this.
it, right?
Yes.
Menstrual history is very suggestive of hormonal balance in the system. So it's very pertinent to know.
Yeah, I just want to know, trying to dig out. I'm a first year resident, so I'll do what
the answer is that we want to know whether hormones inside or
As till now, whatever we have discussed, the only positive finding was that on which we need to think probably why was her cold extremities worsen. So that is one point that should clinch, because that otherwise everything is okay. So why would her cold extremity, and that is part which probably still is persisting, apart from palpitation. So, what would be the differential? Can we think of these cold extremities? One, we talk of beta blocker. Can we think of anything else? Peripheral pulses were okay, as you said.
Sir, I'm first year resident. You tell
so
us.
peripheral pulses, did you?
I would order for CT abdo-pelvis to look for any adrenal adenomas or something like that.
If you're still thinking of paragangliomas, then usually they're microadenomas, they won't be picked up on a CT. What? Lipid profile was done subsequently. At this time, it was not done.
Okay, so we go ahead.
Oh, yeah. Forward, if we move forward, it would be. So, at this time now, she was switched over from bisoprolol to propranolol. It was not done. GI endoscopy was not done. Why do you want to do it? What? GERD. She doesn't have symptoms, and unfortunately, it was not done as such. Yes? No, there's no history of substance abuse. It was not available. Sleep apnea. Look for sleep apnea. How would sleep apnea explain her palpitations or cold extremities? Okay. But the Holter did not show any paroxysmal atrial fibrillation. But yeah, no, see, sleep study was not done, number one. And number two, she doesn't know, and she has a separate room, so no one else in the family. She is unmarried, so she doesn't have a husband to report that. So we don't know. But she sleeps quite well after starting on anxiolytics. Now her anxiolytics, which was switched over to alprazolam, and she was switched over from bisoprolol to propranolol, considering that, having a non-cardioselective beta blocker will take care of her tremors better.
Does she have wet peripheries as well, along with cold extremities? Perspirated?
Yeah, she used
It
to
is
have
perspirated.
during that episode, not all the time.
Okay, during that episode, she is perspirated.
She says she sweats in her palms and there is cold extremities. This is a very important history.
Yes.
But I would give you only when you ask for it, sir.
We are going ahead.
Sure. Okay. So what do you want to do? Would you want to do something else at this time? Okay. Are you happy with this management?
Yeah.
Switch over? Okay, fine.
Yeah, now
No, we'll see. Now she comes back after 3 months. Now this is 3 months later
At
from
that
the index
time,
event.
we were not having CGMS, unfortunately. But
No, we did not have
Yeah,
CGM
but
at
this
that time.
patient was a candidate for
Yeah.
CGMS as well.
Which is why this is 2009, sir. You are smart. Yeah. So the episodes continued. Now they are more clustered. Usually now she reports more specifically that, usually happens 2 or 3 hours after her meals.
So basically the relation with meal insulin levels and hypoglycemia, that need to be,
So
because
there is,
after meals you are talking.
there is no documented hypoglycemia, but she reports episodes of
After
palpitation and cold extremities around 2 or 3 hours after a meal.
Yeah, so in 2009, we should be very happy doing
And she
6
reports
times.
that symptoms are relieved by taking some sugar.
So it was there in first bite side, post meal and post dinner. Her symptoms were 4 p.m. and midnight, right?
Yes.
Something after dinner
Few
that
hours
was
to
going
3
on.
hours
Yeah,
after.
so that was one point. So we couldn't have CGMS in 2009, but at least 6.7 point blood sugar monitoring would have been ordered at that time to check.
So, yes? Dumping. No, sir.
Reactive hypoglycemia.
I just...
Reactive hypoglycemia.
You want to consider insulinomas? So what would you want to do for this? Would insulinoma patient be obese?
Generally obese.
Be very cachexic. Yes.
Hyperphagia.
I'm sorry, I can't hear you. Can you please come forward? आगे आ जाओ सब लोग. You know, this case is going to last till date. We are still in 2009, so we still have a lot of things to talk. But usually insulinoma, very high insulin levels will.
Hypoglycemia can happen, but then.
Okay.
Okay. So next, I think we asked.
So now she's come to you. This is her symptoms. What do you want to do?
Then in this case, probably, as Suresh said,
A glucose tolerance.
we would
test
ask for
might help
FPS,
us.
PG1, PG2,
Yeah.
PG3, PG4 along with insulin levels.
Okay. So she was actually, this is true story. She was advised a high carb diet so that her hypoglycemia can be taken care of.
It would aggravate
This,
actually.
this is actually
yeah, that's
happened.
right.
Yes.
It would aggravate.
Yes, sir.
Yeah, obviously. Yes. Again, it's similar to what.
So, sir, do you attribute all this to her anxiety?
This is physiology, simple physiology.
Okay. So, what do you want to suggest? What should she eat?
If small frequent feeds and no carbs.
Okay.
And no carbs.
Okay. Okay. Sir, can we please come on the front? So this is what actually happened. Like she was prescribed a high carbohydrate diet to take care of her postprandial hypoglycemia episodes, and she comes now 1 month later. After 1 month more, that is 4 months from the index event, her symptoms remain the same. There is no change. There is no improvement in her palpitation and cold extremities. Her anxiety has actually worsened. She feels more anxious now, and she was referred to an endocrinologist now. Now the physician thought that let's get some expert, and the endocrinologist orders a oral glucose tolerance test. Her fasting sugar is 91. Half an hour post glucose is 75 grams glucose is 146, then 141, then 134 and 116. This was a 2-hour glucose tolerance test.
So generally for reactive hypoglycemia, your PG4 should be less than 70, which is 116.
Yes.
So that part is PG1, PG2, PG3, PG4. PG4 should be less than 70. This is fasting. PG4 should be less than 70. PG4, this PG4. That's PG4.
No. Half an hour, 1 hour, 1.5 hours and 2 hours.
Oh, sure, that is how it is. It is not 1, 2, 3, 4 hours.
No.
Okay. I thought it's 1, 2, 3, 4.
Fasting, half an hour, 1 hour, 1.5 and 2 hours. So what do you want to interpret from this OGTT?
Ideally, you should go for PG1, PG2, PG3, PG4. Up to 4th hour you should do, then only you can catch it.
But
ideally.
this is what
this
we have.
was done, okay.
This is what we have. And her symptoms are usually around 2 or 3 hours. She had undergone this. This is a report. And she was thought that, even maybe it is less slightly. Perhaps the physician thought that perhaps the sympathetic overactivity is taking care of her latent hypoglycemia. But the diagnosis is postprandial hypoglycemia. And maybe further workup was recommended. C-peptide levels were done that were slightly elevated. USG abdomen was normal. CT abdomen now, Dr. Abhijit, is normal. What do you want to do now?
Random C-peptide or which C-peptide?
No, fasting C-peptide levels.
Achha. Okay.
Not markedly elevated again in the insulinoma range, but
Okay.
it's slightly more than the normal.
So fasting insulin levels? Fasting insulin levels?
That was not done.
That was not done.
LFT was done on a prior visit, was normal, sir. Yeah, please. So what do we do further, sir?
Creatinine levels.
Nephrologist. So do you think that this is perhaps due to renal failure? And a previous visit, creatinine was normal.
She was like an undiagnosed chronic kidney disease for whatever reasons. She could have had hyperinsulinemia because of reduced renal functions.
Okay.
Where excretion doesn't occur. So that could be one of the reasons.
Okay, so you want a creatinine?
Unexplained.
She was given metformin 250 milligrams twice a day by the endocrinologist, and she was prescribed a low carb diet considering insulin resistance. This was the advice given, and with this advice the patient thought, my problem is low sugar, and if I take metformin it will further worsen. So she came back to the physician to ask why such a suggestion by the endocrinologist. Will my symptom not further worsen? And the physician actually also thought that, yeah, perhaps this is quite possible. Your logic is quite reasonable. The endocrinologist had actually counseled the patient, but was not available for discussion with the physician. This is actually a true story because the endocrinologist had gone out of India. And, after consulting, this is what really happened. And what was the advice given by the physician? The advice was, you continue the advice given by the endocrinologist for a week. See if your symptoms worsen. If your hypoglycemia or whatever symptoms worsen, then you discontinue that. If there is no relief, stop the metformin. Just take normal carb diet and take sugar if required for symptoms like she used to do previously. And this was considered either a stress-induced hyperinsulin release or an insulinoma, again, was a possibility considered by the physician. This is 2009. There were no other features. There was no loss of consciousness, no seizures. But her quality of life was worsened because every 2 or 3 hours, she would have to have some sugar, and she was not very comfortable with her symptoms and anxiety. She also actually lost her job because of, not feeling absolutely productive. And her mother also now started getting more and more anxious. What is happening to her? Now 6 months later from the index event, that is further 2 months, she now gets a job in Kuwait and she comes for a pre-employment assessment. Anxiety of the family is worsened because the mother thinks who is going to take care of her while she is alone. She needs the job because the father is no more and she is the breadwinner in the family. Her palpitations have now partially relieved after being on whatever medication. But other symptoms like excessive sweating and cold extremities persist. And she was counseled frequent small meals, one. Number two, carry chocolates for hypoglycemia because in case of problems, in case of stress. And a personal glucometer was recommended by the physician because she's going to stay alone in Kuwait. So anytime, and he gave her his WhatsApp number so he can be a help anytime for charting. Now she comes back after 6 months of her job, and this is now 1 year post the index event. On visit, she has now improved episodes. The frequency of palpitation has actually come down. Her symptoms of excessive sweating have come down. Now she doesn't feel as anxious as she used to be. Now this only happens during festivals. And she noted that, when she has symptoms during some festivals, when she is at home, her sugars are in the range of around 70. Now she has a glucometer. Normal meals, whenever she has, which are available in the office cafe, are absolutely okay, and she has no problems with that. And the advice given to her was to continue the same because now she feels much better, nothing new needs to be done for her. And she was reassured that perhaps it was stress related because of the loss of her father, and that should improve with time. It's now already 1 year post. Now she is having a stable job and she is doing fairly well professionally. Now it's been 2 years post this event. Now she's back for her own wedding. Now she found a guy in Kuwait and she gets, engaged to him, and they come back for wedding in India, and she comes for a routine checkup. Her symptoms start to worsen again. Now she starts worsening again, and the impression is again stress perhaps, because the stress precipitated, the cause of stress was different. Loss of father, and now the wedding is her new stressful event which is worsening her symptoms. Again, she was recommended a high carb diet and frequent small meals to take care of her current situation. And she was reassured that, once she goes back to Kuwait, once she's settled in Kuwait, goes back, things would subside and settle down again. Nothing else is done at this point of time, and it's 3 years now. She returns for pregnancy. She is now 5-6 months pregnant, and she comes with a maternity leave. She wants to get her delivery done in India, and she visits a gynecologist. Gynecologist finds HbA1c 5.8%. Glucose tolerance test is done again, 84, 147, 149, 121, and 116. This is again half hour, 1 hour, 1.5, and 2 hours. Proteinuria plus 3. This is where we have Dr. Abhijit again. Blood pressure is 150/90. And the gynecologist changes from propranolol. She was, thought, instead of propranolol, let's give her labetalol. Safe in pregnancy, will take care of her blood pressure also. So this is what was given. And she was also prescribed nifedipine considering her proteinuria. So Dr. Abhijit, would you be happy with this? Yes? Yes? Casts were not available. Sugar is negative. Proteinuria plus 3. Except that, no other abnormality is seen. Yes? 24-hour urine what? Protein, cast? Okay.
So the proteinuria could be because of preeclampsia. We are not sure. She returns for her pregnancy. So it could be related to her pregnancy. It could also be related to a native kidney disease, which has not been detected so far. So either of these two.
Yes. So these are two possibilities. Preeclampsia should be considered, certainly, of course. There is borderline blood pressure elevation, and her sugars are also okay. And GFR at this point was okay. ANA was not done, sir. ANA was not done. Actually, she now, yes, second trimester, around 6 months or so. At this time now she does not have palpitations, but her anxiety has worsened. Now she gets pedal edema also. There is no seizures, there is no eclampsia, so to say. And the impression is that perhaps this is just preeclampsia and perhaps stress-mediated worsening of her anxiety. And she has a stillbirth at 7 months. This is what happens at 7 months. And it is expected that there would be further stress and that would be further worsening of symptoms. This is what is expected. Or if it is preeclampsia, then post-delivery her symptoms should actually improve. So what happens is blood pressure remains persistent. She continues to be on the beta blocker, labetalol, as well as nifedipine, that is continued. Proteinuria remains persistently +3. It does not come down after delivery. And now she is referred to a nephrologist now that, this is not preeclampsia, something else is perhaps there we need to consider. So the nephrologist, now that she is not pregnant, switches from nifedipine to enalapril. Now she can safely take ACE inhibitors. It is okay. That will help her proteinuria. And a renal workup is done. Renal function tests are okay. USG abdomen is repeated, and urine analysis and electrolytes. And all these are normal except for the proteinuria.
So she needs a renal biopsy now.
Yes. Now she also has again worsening of palpitations, and a cardiologist is involved. Holter again shows intermittent inappropriate sinus tachycardia, the same. There is no atrial fibrillation or ventricular tachycardia, and she switched from labetalol to bisoprolol back because young female will prefer a cardioselective beta blocker. She's advised meditation, she's advised moderate physical activity, which would help her improve her insulin sensitivity, reduce her weight also. So walking is recommended, and ask for to look for signs symptoms of hypoglycemia. So this is what done by the cardiologist. The impression is that perhaps it was the stress of stillbirth which worsened her, and it was expected that a preeclampsia should have improved her problems post delivery, but that did not happen. It was not observed, no improvement, and she was continued to be monitored, and she returned back to Kuwait for her job. Blood pressure now remains well controlled, 130/80, she's fine. Sugar remains okay. Now she does not have much problems when she's back to her job, and she returns back after 4 years. Now she develops overt diabetes and hyperglycemia post 4 years. That was detected by the doctor in Kuwait, and she was prescribed metformin full dose 500 milligrams twice a day. And there is remarkable improvement in symptoms of palpitation, improvement in her excessive sweating as well as tremors. And the impression is that perhaps these were neuroglycopenic symptoms, perhaps, which improved with development of hyperglycemia. And the therapy was continued while watching for hypoglycemia. So now she's on proper dose of metformin, and she was on guarded anti-diabetic diet. She is prescribed a low-carb diet, but at the same time, she should watch for hypoglycemia. Nephrologist is again consulted for her proteinuria, which is still persistent despite continuing on ACE inhibitor, and it has not changed. There is a strict sugar and BP control, which was recommended by all the doctors, and it is quite okay. And cardiologist was consulted. The cardiologist again repeated echocardiography, showed mild left ventricular hypertrophy, normal ejection fraction, no wall motion abnormality, and just grade 1 diastolic dysfunction. And again, now ambulatory blood pressure monitoring was done at this time. Now it's around close to 2014 or 15 perhaps. And it showed a fairly average 24-hour control. She was a non-dipper, no early morning surge also, and no BP variability also. It almost remained same, but the only abnormality was that she's a non-dipper. So, yeah. At this point now she reports, like she came with her brother, and now brother also reports similar symptoms of palpitation. He did not come out, he was not forthcoming with his symptoms, but when probed and actively asked for that, then he said that. So chlorthalidone was added by the cardiologist, considering
What
that
was the reason of
non-dipping
her-
might increase his risk.
What was the cause of death of her father?
The father died at around, say, 55 years of age from cardiovascular disease. No one asked me that before. I thought you would. All right.
I didn't imagine this will go on this now.
Okay. All right. So now what does the physician do? He continues treatment for diabetes, hypertension, and proteinuria, ACE inhibitors. Gynec is now consulted because she wants to get pregnant again. And she is advised to get her weight under control, obesity, so that other metabolic parameters can be well controlled, and screening of her brother is recommended. The brother also reports similar features incidentally. He does not come out on his own, but when probed, he reports. But then, now he is counseled for low carb diet, exercise, and if at all there is some asymptomatic sinus tachycardia, bisoprolol 1.25 milligram was given to him.
Till now
Yes, so like what do you want to do about it? Would you want to do anything more like different? Okay. So, proteinuria is persistent despite taking her, and she has not undergone any kidney biopsy. She has not undergone 24-hour urinary protein, which was recommended. This could have been a nephrotic syndrome, and maybe biopsy might have helped us identify the underlying pathology. So that was quite valuable, but it was not done. And what? Yes. Yes. Yes.
Kidney biopsy is absolute must.
Kidney biopsy was a must. It was recommended, but not, but refused by the patient. To look for what? Yes, exactly. So, and therefore, low-dose chlorthalidone 6.25 milligram once a day was added to her prescription to take care of the nocturnal dipping also. Because of some edema, maybe it could have been obesity related also, she was not given a calcium channel blocker, she was given chlorthalidone. And now it's been 10 years. So it's close to 2019, she comes for an annual routine checkup, she gets a positive stress test now. And she's advised a cardiology consult. She was told that she could have possibly blockages. Now she's scared. She doesn't want to do any treatment there, so she comes back to India and returns for further evaluation. And she goes to the cardiologist, who again wants to do a coronary angiography to evaluate her positive functional stress test. The angiography shows triple vessel disease. All are long, diffuse, around close to 70% lesions. They're not very flow limiting, so to say, on prima facie evidence. And she's not symptomatic. This was an annual checkup, incidentally detected positive treadmill. So she was given a trial of optimal medical therapy with an option of either a multivessel PC or CABG if there is refractory angina. She was told, because at this time she's hardly 35 years of age, so she would have aggressive atherosclerosis, there would be a high MACE risk, and she's asymptomatic, so why subject her to any coronary revascularization? Considering these things, the cardiologist advised her medical therapy. And he ordered a lipid profile. The LDL cholesterol was 131, HDL was 26, triglyceride 191. A typical scenario which we see in our patients. What would you want to do for this? Yes. Would you like to wait one by one, first statin and then a fenofibrate, or both at the same time? Because fenofibrate definite indication would be a very high trial. This 191? Marginally, yes, maybe to the tune of 10%. Okay. Just one thing is, this one point, indirect evidence of insulin resistance. If the triglyceride to HDL ratio is more than 4, it's a very strong clue of insulin resistance. So if that is done on first attempt, you might not have done insulin levels. We don't do in routine cases. We don't do, even hyperuricemia is a marker of insulin resistance, and a TG to HDL ratio more than 4. It should be close to 1:1 if possible. Anything more than 1:4 is certainly abnormal, and it has a very, very high propensity to develop cardiovascular disease. Yes.
For somebody who was just positive BMP and proteinuria.
Sir, even she and her mother is anxious and insists that whatever needs to be done, she doesn't want any treatment. Yeah. So, it's a. Sir, diagnostic angiogram should be okay. Should have a low threshold. That's all.
I would have done CT angio. I wouldn't add a diet.
Sir, with +3 proteinuria, you would want to do with minimal contrast. So, a conventional angiogram would be preferable over a CT angiogram, which would require more contrast.
It's a good argument.
Yeah.
Saving a diet is a good argument. Anyway,
But you would certainly want to give her statin, you will want to give her antiplatelets, beta blocker and ACE inhibitor she is already taking. Okay. So she is given aspirin, atorvastatin, nitrates if required. As such, she is asymptomatic. And her beta blockers and ACE inhibitors are continued. This is
Can
10
I ask
years.
simple question?
Yes, please.
To cardiologist colleague. What dose of statin, what intensity of statin you would recommend this patient? Okay, so whatever dose is needed, you will try to bring it to 70.
What would you recommend? Because all the recommendations are for people above 40 years of age.
Yeah, it's 35, but
She's
there
35.
are 3 risk factors: hypertension, nephropathy, diabetes again, so 4 risk factor, and father's death. So of course, high intensity statin, regardless of age.
So would you want a 40 milligram rosuvastatin or 80 milligrams of
No,
atorvastatin?
20 Rosua or 40 Atorva would be, I am fine with.
Okay.
So moderate to severe intensity, I am okay.
So would you prefer atorva or rosua in this patient?
So I think renal involved, so you can imagine. I'm better
At
with
present,
Rosua.
except for proteinuria, there is no renal compromise,
That
no
we have,
oliguria.
yeah, but still, creatinine and EGFR is a gross marker of kidney function. So 3
Yes.
plus persistent proteinuria, it's definitely going on in background. We haven't checked it.
So primarily, what was the reason for her timed paroxysmal palpitations that she was having? Underlying
Neuroglycopenic symptoms. Now she doesn't have those. After developing overt diabetes, her symptoms have improved. Yes. So regarding the choice of statin, maybe rosuvastatin has good primary prevention, but this is not primary prevention. Now we are looking at secondary prevention now. After having a triple vessel disease.
Yeah, but there is not an event. So you will consider this is a primary prevention. Primary prevention.
She's already developed coronary artery disease now. Now you're talking of second, you want to reduce further events.
Further events. There is no event at all right now. Is there any
Coronary
ASCVD
artery-
event?
Would you not
You
consider
said it was asymptomatic on routine checkups she was diagnosed. This is not
functional
event.
status is different thing. Coronary artery disease,
Sir.
a triple vessel disease.
Okay, wait. Sir, you consider this is an event of an ASCVD or it is?
This is ASCVD. This is, yeah. Yeah. Yes. This is,
So giving statin to this patient will be considered as a primordial prevention, primary prevention or secondary prevention?
yes. Sir.
Kamaldeep
Very-
sir, will you consider
very
it as an
interesting.
event or it's still, we are planning for primary event prevention? It's an event.
Yes, sir. This is established coronary artery disease. Triple vessel disease, what do we want? We don't want to wait for an MI or a stroke. So this is,
Or, sir, Neeraj bhai, your comment. Akash sir, you can comment.
yeah, that's, this will be secondary prevention. Yes.
Please.
Okay.
Yeah. That is why I'm asking everybody.
Anand, I'm surprised she has not undergone a kidney biopsy so far.
She refused a kidney biopsy. She was recommended, but she did not agree to it. So, she has a sedentary lifestyle, so no major symptoms. We don't know whether she would have any angina. So, no usage of nitrate, so to say. Nephrologist was again consulted for proteinuria or risk of contrast nephropathy in case of
Can I
any need
interpret
for
over here?
revas.
See, in 10 years back, whatever stress and everything was there, at that time BMI was 33 and at that time there was sedentary lifestyle. And even after decades she is on sedentary lifestyle, it is our failure.
Yes. She has not changed her lifestyle, which is a very common thing in our...
It's our failure,
population, yeah.
our failure.
Yes. So what does the nephrologist do? Proteinuria is still continued, he has to treat. Now the creatinine is slightly on the borderline, 1.4. USG shows now bilateral bulky kidneys.
So one would like to have a fundoscopic examination to look for diabetic retinopathy.
Okay. And would you would still need to do a protein, 24-hour protein and, try and insist for a biopsy because...
Yeah,
What would you consider when you see bulky kidneys and borderline renal function?
This is diabetic nephropathy. I mean, this could be diabetic nephropathy, provided she has other macrovascular and microvascular complications because of diabetes.
So usually kidneys are shrunken. In what conditions would you expect bulky kidneys with CKD?
So differentials for bulky kidneys, CKD would be diabetes, ADPKD, you could have it with HIV,
Amyloid. And there's four
and
causes.
any deposition disease, correct?
Yes.
Lymphoma.
And all those things you can get very clear by doing a biopsy. Electrolytes were done, which were normal. And the patient denies any further workup. There is no oliguria or edema. The patient does not agree to anything more, especially the biopsy thing. She was counseled for a close follow-up and a tight BP and sugar control because that is all that could be done. Cardiologist was consulted before leaving for Kuwait, and her mother said, you know, she just wants that there should not be any event in Kuwait, so whatever needs to be done, you have to fix it here only because she stays alone there. So safety of optimal medical therapy versus coronary revascularization. If she has an event, what do we do? She's all alone. Yes. So the cardiologist in this case advised FFR of the lesions to determine, feasibility of revascularization, whether that was to be done. And it showed that LAD and the OM was FFR positive. The RCA lesion was not FFR positive. So he counseled that if you don't want to take a chance, maybe you can opt for angioplasty. PCI was done with 2 stents and a high MACE risk was explained considering aggressive lesions, very early onset aggressive atherosclerosis and longish lesions, diffuse lesions, and presence of diabetes again. It was safely done. Thankfully, there was no worsening of contrast nephropathy at this time.
Very theoretical.
Yes.
But still it's very theoretical. FFR and DVD may give sometimes a wrong impression.
True.
It's a balanced ischemia state. Plus FFR is more subjective, FFR is can be more subjective at times rather than being objective. So, I mean, I would honor whatever has been done, but still I think a stress thallium or a stress MRI would have been a better option.
So you would prefer a stress thallium to detect the percentage of area, ischemic area over agree to that. The only concern was she lives alone in a foreign country with no support. So therefore, the doctor also did not, I'm not trying to justify, I'm just saying that he ordered a functional testing to determine if she needs revascularization or not.
The thought process
that was the
perfect.
thought process. Fortunately, there was no contrast-induced nephropathy, and she was given aspirin, ticagrelor, rosuvastatin, beta blockers, and ACE inhibitors. Endocrinologist was consulted before leaving for her home, for her Kuwait, and titration was done because now the sugars were slightly on the higher side, and she was given metformin, sitagliptin, and acarbose. Monitoring sugars, control weight, physical activity, stress management, all these lifestyle measures were recommended. Dr. Vishwa, would you want to do anything more at this time?
Yeah, I think either SGLT2 inhibitor or GLP-1 receptor agonist must be on board because now she is established as CVD, CKD, right? So yes. I think that part I can add here.
And considering her borderline kidney functions, what would you choose?
Yeah, so both are there in guideline, but SGLT2 inhibitor being oral will be preferred. And considering weight and all, GLP-1 would also good option for this patient.
Okay. So now it's now 12 years. Now this is 2021. Last year, she comes for an annual checkup in India. She has undergone an angioplasty already. Physician consult is done. Now she has a history that, 2 times in the last 1 year, she lost, first trimester pregnancy lost 2 times. She was counseled to have a planned pregnancy, discontinue ACE inhibitors before pregnancy. A gynec referral was planned, who recommended that
would you not like to discontinue statin as well before pregnancy?
Is it a contraindication?
To me, I think it is. No. Statins are not indicated in pregnancy.
There's no... Okay. I'm not aware of pregnancy and statins. So cardiologist was consulted, echocardiography was done, a treadmill was done which was positive. We thought perhaps the unrevascularized RCA could give a positive stress test. Lipids, HDL was 31, LDL 81 and triglycerides slightly more, 211. Would you want to do anything at this time? For
the dose of statin she's on?
She is on rosuvastatin.
40 or what,
Yeah,
20,
yeah.
40.
What's the serum creatinine now?
Okay. Lipoprotein A, sir, what you asked for is 71. The extra, whenever we have a premature or early onset atherosclerosis, do not be satisfied by just the conventional lipid profile. Ask for ApoA1, ApoB, lipoprotein A, especially in family history if it is positive. We might not have any medicine to reduce lipoprotein A, but lipoprotein A confers a higher cardiovascular risk, which implies that we need to continue high intensity statins to kind of lower the risk as much as we can possibly. Yes, because so one thing we can add ezetimibe or anything fenofibrate or saroglitazar for this patient? Sir? No. For 200 you would not perhaps consider. Maybe some sugar control and weight control would take care. Okay. A check angiogram was done for functional testing and it showed diffuse stent restenosis in LED and OM stents, diffuse RCA disease which has worsened, and there were fair-sized collaterals from the right to the left system. Statin doses were increased.
She also becomes a candidate for starting evolocumab now.
Yes, sir?
She also becomes a candidate to start evolocumab.
Okay. Yeah, PCSK9 inhibitors and such. Yeah. So you first give statin, then ezetimibe, and then PCSK9.
But overall, I think the experiences with ezetimibes are very weak. Whatever data, combination of statin and ezetimibe, they prove to be very weak in comparison to the target that you want to achieve.
Sir, what's your take on the recently come new drug for statin?
Bempidol?
Yes.
I don't have a personal experience, Anand. I have just read the monogram, but I have not used it.
No, it's not HMG-CoA, it's another. Yeah, it's a different pathway. Yes.
Pathway for? For which molecule? Sorry. Bempidol.
Bempedoic acid. So statin doses were increased from 20 to 40. She was advised CABG, but again she was told that this would still have a high MIS risk and she was not willing, and again this is asymptomatic, so the doctor was also not very keen to offer any further revascularization. Yeah, that should have been done. She now also has 2 first trimester pregnancy losses, so you would want to know that. On the first instance with proteinuria especially.
Yeah. The first trimester losses would again suggest that she might have developed renal failure now. So she's not able to take them to term.
Yes. So now she gets to the nephrologist, proteinuria, creatinine 1.2. Now the USG, on this time the report shows a normal size kidneys. The CMD is still preserved. She's advised hydration, no NSAIDs. She denies any biopsy or any invasive test. And endocrinologist recommend, finds that the HbA1c is 7.1. There is no hypoglycemia. There is obesity, so he recommends empagliflozin for diabetes, weight loss, and watch for genitourinary infections because she uses public toilets and poo weight. Now, I got a few questions. After developing diabetes, she never had any palpitation.
Now
This
there
was
are
prior to the
palpitation
onset of
because
frank
of other
diabetes.
reasons, not primary reasons.
Yes. So, some questions to the cardiologist here. What would be the choice of coronary revascularization in such patients? Because, you want to look at long-term MACE, which is always better than CABG. But would you order CABG for a 35-year-old girl?
Yeah, it's a tough call, but then we should follow the guidelines. I mean, it's as simple as that. So after second angiogram, you would send for a...
No.
Sir, yeah, so I think we discussed that point. Had it been a stress thallium, which would have said that all 3 territories are ischemic, we would have sent for bypass. The first, so Anand, so your question is the second angio or the first angio?
Which at whatever stage, would you offer any revasc or just continue medical
Yeah,
therapy?
second time definitely bypass.
This is
surgery.
asymptomatic functional test positive in both situations.
Yeah, but
But again, you know, this might not be truly asymptomatic because she is sedentary.
and she's diabetic.
She is diabetic.
So silent ischemia is a part which we should remember.
Could be. So would you want to revascularize her? If
Yes,
possible?
definitely.
Okay. Would you want a still tighter lipid?
Definitely.
What LDLC goal would you target here?
55.
Or 40?
55.
Okay. Rule of
Amaldi,
PCSK9,
just for
I
my
think you
understanding,
already mentioned.
What makes
Yes.
you say 55? What is the guideline, or why are you saying 55?
It's in the guidelines.
That's the guideline.
ASCVD
Yeah.
guidelines, yeah.
For people with very high risk, the guideline should be the LDL, target LDL is less than. How would you address the residual MACE risk? Because, you know, whatever you do, she would still carry and she's too young to
Yeah,
have.
so Anand, she's part of metabolic syndrome and the disease, like what we say, the continuum. So she may land up with heart failure eventually. And
Would you want to consider bariatric procedure for her?
well, I would not take the decision alone. I would take it as a team discussion.
Maybe Dr. Vishwa, your input?
Yeah, I think she was never, starting from initial history, she was never been forced to do exercise and lifestyle in a way to achieve proper weight loss. So of course, we would like to force her, or at least guided weight loss should be tried. Unless she fails multiple attempts, yeah, of course, and everything is going on, then at last, still
Exactly.
BMI is more than 30, 35 in this type of patient, you may consider bariatric, but they are not initially.
So yeah, you should motivate someone for a lifestyle modification before you offer any invasive procedure. But would a bariatric procedure help her in any way?
See, such as extensive level of atherosclerosis going on in spite of everything. We missed too many things, that antiphospholipid and kidney biopsy and all, but in spite still too many things are going on. So if we could achieve weight loss by any means, it would help. It would have helped.
Fair enough. So you'll need an aggressive, very aggressive secondary cardiovascular prevention program. Any role of dual pathway inhibition? Maybe would you want to switch over from she was on ticagrelor, would you want to switch to a low dose rivaroxaban for better
She's a
long-term
typical companion.
polyvascular disease control?
So she's a typical companion patient.
Yes. So your choice of antiplatelet would be aspirin or clopidogrel?
Aspirin.
And 2.5 milligrams
rivaroxaban.
rivaroxaban. How long?
At least 3 to 4 years from now, and then maybe take a call. What evidence comes out to us?
Okay.
In 2022, I would put her on that.
Yeah, this is now 2021. This is her last status. Now I got a few questions for the endocrinologist. How would you see people with insulin resistance? You know, perhaps insulin resistance could have been detected on first attempts in the first few visits. Perhaps we could have done at that time when things were perhaps reversible. Is it possible?
Yes.
With these kind of symptoms when people present, generally we should ask for this entire OGTT, first, second, third, fourth hour, HOMA index, R2, that would tell us everything. That is the best way to tackle this. Because she had very clear, 4 p.m. she had hypoglycemia, midnight she had hypos. Nobody had measured sugar at that time.
Yeah.
So, basically, this is how we should approach. That's the only way to find out
So
in
if you
practice.
do HOMA AR and find her to have insulin resistance, what would you do differently?
Nothing, but instead of metformin, I would use Voglibose.
Okay.
That's all. Otherwise, the same thing. This is a natural course which we see. So
Would you want a thiazolidinedione for her?
she was obese, you said, no? So there's a little concern about weight. That's all. Otherwise, yes,
But it
it's
would
a
help her
wonderful thing.
improve her insulin
Saraglitazole
sensitivity.
could have been added, but yes, now 2022 we can.
Yes.
Yeah, can I add
So how do you
something?
diagnose insulin? How do you diagnose insulin resistance?
Can I add something in that first point?
Yes.
If we would have thought of insulin resistance at first, second visit, once she comes out of the trauma of her father loss, she must have been put on heavy diet and exercise regime on that point onwards.
Right.
It was, we could have done. And this might have prevented if we could have achieved her BMI to, or say less than 25, probably whole life must have been little different than what we've seen.
What exercise regime in particular would you want her?
Yeah, so basically she was at that time 24, 25, right? So most of the time we would like to believe that she must be able to indulge in all aerobic probable activities, anaerobic, that is some muscle strengthening as well, and then stretching. So all three best possible exercise he must have been put on at that time.
Yeah, so this is important. You know, we do recommend aerobic exercise, cycling, running, skipping, jogging, swimming, etc. But it is strength training which actually improves insulin resistance. So that has to be highlighted to people. Maybe on alternate days, if not every day, but that is important. So how do you diagnose insulin resistance?
See, in morning there was a very good lecture of Dr. Mona madam. So clinically we have very good markers, especially acanthosis, right? If you have habit to see nape of neck and axilla more than I think in males it has almost 80 to 90% correlation as far as the clinical finding is. In female it's slightly less, right? So very less often you need HOMA-IR or C-peptide or insulin testing, but clinically you can always consider these points.
Yeah. So, you know, just like heart failure with reduced ejection fraction and filling, what happens in preserved ejection fraction is the ejection fraction remains near normal, but at the cost of higher filling pressures. Same way in diabetes, early on the sugars might remain normal, but at the cost of higher insulin levels. So if we can pick up that early and intervene early, we might be able to save this person when things are quite reversible. So how do you treat? Is again we discussed, maybe metformin. Would you think acarbose help insulin resistance? Actually, anything which reduces chronic glucotoxicity would help. So even acarbose should, in a way. And a low stringent, would you recommend keto for such patients? Keto diets?
Low carb diet should be preferred. Keto diet is again little debatable, but yeah, low carb diet would have been.
Yeah, at least avoid simple refined sugars, perhaps. Yes. Okay. So yeah, any role of intermittent fasting? We have a lot of talk about that.
Intermittent fasting, there's a lot of, you know, school is divided across the globe basically. But then low carb and people have been doing a lot of intermittent fasting. So if you see in ADA 2022, there was a major lecture on this fundamentally, on intermittent days, or this, not exactly reversal, but this. They were very clear. The lecturer who was presenting the data, she was very clear that VLCC, very low carbohydrate diet is out. But that is not possible to follow, number one. Number two, as far as the reversal of whatever they are talking, for it's an entire schedule which is followed. Difficult to follow, as yesterday Sir had said. So that is also out. The only thing is that intermittent fasting is useful in certain subgroup of people. So you need to choose that and then you do it. Because we all have seen in practice so many of patients who have been following the intermittent fasting, but then they have some relief, but it's very difficult to follow for the lifetime. And the data is, I believe, it's very limited. Vishwa?
So I am not a big fan of intermittent fasting, because what generally these people advise or they are doing is they take their night meal and then afterwards they start their next meal in afternoon, right? So almost 15-16 hours without meal. And if you see their lifestyle, their peak working hours in morning, right? So if we see the physiology, your liver will give you almost 6 to 8 hours of glycogen after you eat, right? So it's a very stressful condition in morning that they go through without taking any tea or proper breakfast. They start doing their work. That is probably the best possible productive hours of their career, right? So there are reports that it is little detrimental as well, right? So unless you have sedentary working pattern, probably you are not very much active in morning and you are very much active in evening. So in this subset of patient, if you ask for intermittent fasting, that probably may sound little interesting in those patients, but yeah, in general, I am not a good fan of intermittent fasting.
I agree, practicability and feasibility are different issues, but if we just talk about science, maybe Akash sir or Ashwin sir, would you recommend frequent small meals or intermittent fasting just based on the science behind it? In principle? Okay. Some mix of both. Okay. Okay. Sure. To compare. True. Yeah. Maybe a mix of both. Just avoid snacking would be a middle path. So choice of, would you want insulin in such patients or oral hypoglycemic therapy?
No, there was no need of insulin as such.
To reduce our insulin resistance, some people think?
No, it's not.
Okay. And how do you monitor her insulin? Would you want to monitor her insulin levels rather than just monitor her sugar levels and just target the insulin levels, so to say?
No, not at all required as far as the clinical practice is concerned. No guideline tells you to
We don't have a
monitor
guideline
insulin.
for it.
Right? So,
And GLP-1 RA?
yeah, it has definitely role.
For this patient?
Yeah, so initially, as long as she was in insulin resistance phase, there was no role of GLP-1 receptor, at least on paper or in guidelines. Once she became diabetic, of course, there was a role. But yeah, in off-label, as I know many of our colleagues, we do use GLP-1 receptor agonist to achieve desired weight loss in even pre-diabetic or even non-diabetic patient as well. So there is a definite role of GLP-1.
And which one do you choose? Dulaglutide, Lira or Sema?
Yeah, so Sema has just come now, so oral Sema we are keeping aside, but in Dula and Lira, my preferred choice is liraglutide. One simple reason behind this is that as we know that GLP-1 receptor agonists do have in initial days GI upset, right? So most of the time what happens, we start with low dose and goes ahead, right? So if patient has to develop GI upset, so if you're a once daily injection, so probably if there is a side effect, it will go much earlier than the weekly injection, right? So in that regard, daily injection would be preferred as far as weight loss is concerned in this patient, right?
Right. And saroglitazar are for managing residual serotonin.
So I think your triglyceride cardiologist would be better.
I think in this particular patient, my choice, seeing the patient and all evidence is statin plus PCSK9 inhibitor. So there remains no role of saroglitazar now.
We don't have CV outcome data of
Exactly.
saroglitazar. So. And some for the nephrologist. CKD, bulky kidneys, we've already talked. Role of kidney biopsy.
Yeah,
Whether this would be diabetic or any alternate etiology, and maybe role of other calcium channel blockers.
So,
how do you manage isolated proteinuria and
So if we have other macrovascular disease processes in the body which are suggestive of diabetes, then we won't biopsy all patients. If there was any active sediments like hematuria or something associated with it, then probably she will warrant a biopsy. And especially after her cardiovascular disease, where she's on antiplatelets, biopsy is not indicated in this patient.
okay? And how do you manage isolated proteinuria?
So isolated proteinuria, just, it kind of denotes that there is vessel disease in this person. And it could be a part of diabetic nephropathy if the amount of proteinuria is very high, more than 3 grams nephrotic range, then one would really think whether she's having a diabetes plus syndrome, like say membranous nephropathy or something associated. In which case then nowadays there are modalities available where you could serologically test them for some antibodies, and if those turn out positive, again there's no need for biopsy. But if it's negative, then you always are towards a biopsy.
And the last question, maybe an increasing, growing, recognition that there is a role of renal as well as brain sympathetic nerves in the genesis, initiation, and progression of hypertension. Would that make you think of going back to non-cardioselective beta blockers for such patients? Because our cardioselective beta blockers will not touch the brain or the kidneys.
I mean, if RDN was successful, that would have helped her, but this is a choice between CV outcomes and selective beta blocker.
Fair enough. Any more inputs? With that, I just conclude, and I think maybe, would you want, sir, Trivedi sir, maybe diagnosis of sympathetic overactivity, some comment? Would you, anyone, we don't have a neurologist, but sympathetic nerve action potential to actually document that? How do you assess the role of abrupt chronotropy and late recovery as interpreted as a telltale sign for sympathetic overactivity? Recurrent first trimester abortions, we have to consider hypercoagulable states, also a renal failure, which you mentioned. And this patient did not have features of polycystic ovarian disease. There was no hirsutism. There was no primary infertility, so to say. This was recurrent abortions. So, sir, your comments, last comments on this.
When we could not find out any good, correct reason for the palpitation, we could have thought of sympathetic overactivity as one. Getting abrupt chronotropy is one of the signs of sympathetic imbalance, and getting inappropriate tachycardia during treadmill is also one of the very good indicator. If you get a very high rates at unacceptable load levels and takes a very long time to recover to its normal level, all the three signs were there. Only thing, we didn't interpret it correctly, so that was the problem.
Fair enough, sir. Thank you very much. I hope it was quite interesting. The patient is still alive and she's doing fairly okay with medicines. Thank you.
Yeah, and I want to appreciate the patient that she stuck to one doctor. Actually, changing doctors, then
It would have been worse.
Must have gone.
But not the same, like, she would have gone, but she's persistent. She's still in follow-up.
Thank you. Thank you very much, all the panelists and experts, for having a wonderful case discussion. Now I invite Dr. Akash Singh sir to present a moment to our panelists. Dr. Abhijit Konur, Dr. Kausik Trivedi sir, Dr. Kamaldeep Chawla, Dr. Viswa. Dr. Anand Ahuja, please, to receive a memento.
I just presented. Thank you, sir.
Now finally I invite Dr. Akash Singh sir, President IDCM, to give a vote of thanks.
It is very satisfying moment that this conference has just ended. First of all, I profusely thank all my seniors, all my colleagues who have come to attend this conference. They deserve the maximum appreciation and gratitude from our side to make this conference a success, because without their presence, this conference would not have met with any success. Secondly, I appreciate and I acknowledge the intense support of all the pharmaceutical companies who have come together to sponsor this conference in a big way. Otherwise, such a good conference of national quality, which everybody has appreciated, would not have been possible, because budgets were pretty huge. So I congratulate them very much. Thirdly, I congratulate the organizing committee of IDCM to make this conference a great success. And for this, the three people which have intensely worked to make this conference successful are Dr. Dishang Patel, Dr. Sushil Patel, and Dr. Vivek Vaswani. They have worked day and night, and they have really made this conference a very, very good success and coordinated the conference in the difficult moments of the conference. I also wish to acknowledge the support of all my seniors, all our patrons, all the senior members of family who have basically come and blessed us in this occasion. I also acknowledge the support of all the national faculties. None of them whom we have approached have refused to come. 100% people have come, and they have also physically come actually. They have not only promised, but they have made their promise successful. Only Dr. Sanjeev Phatak had developed COVID infection, and therefore he could not come. Otherwise, everybody has come, and this is a very satisfying moment for Baroda basically, because this signals that we are now on the national map as far as the national conference is concerned. With this, I also wish to acknowledge the support of Team Sterling basically, who have managed our registration counter, and and also some of the pharma members have worked out of way basically to help us in managing our guests basically, in arranging their transportation to and fro. So everybody basically has helped, and this is the reason that we could have made this conference successful. Also, I acknowledge that we had a straight support, a very, very straightforward support from Association of Physicians of Baroda and Association of Physicians of Gujarat, who have unhesitatingly given their name basically in support of our conference, and in their WhatsApp group have promoted our conference basically. Our event manager, Mr. Sapan Patel, also has worked day in and day night basically, and has worked very well. And I also congratulate the audiovisual team basically for a perfect audiovisual display throughout the conference. I thank you all basically, and I declare this conference closed. Thank you very much.